Good morning, everyone, and welcome to the ABTA Survivorship Taking Control of Your Journey Patient and Family Meeting. My name is Emily Lippert, Program Manager here at the American Brain Tumor Association. We are delighted you have joined us online today. The ABTA's patient and family meetings are free events typically held across the U.S. where brain tumor patients and loved ones can network and hear from experts about the updates in brain tumor research, treatment, and care. This year, we chose to host our meetings virtually to protect the health of our community during the COVID-19 pandemic. Although we are saddened we cannot connect and network in person, we hope our virtual program will be an enriching experience for each of you today. Since we are unable to meet in person, we thought a good way to connect and learn about other attendees would be to participate in some polling. When a poll is launched, a box will pop up prompting you to respond to the question. Your answer will be anonymous and only collective results will be shown. Let's launch our first poll now. What region of the US are you tuning in from today? All right, I see some jumping. Ooh, it's a tight race right now between the West Coast and Northeast. All right, a few more seconds. 3, 2, 1. All right, our highest region we have right now is the West Coast with 39% and the Northeast with 22%. Thank you so much for participating. All right, I'm going to launch our second poll now. And this is just to gauge an understanding of where each of you are at today in regards to your understanding with survivorship. So please rate your overall understanding of survivorship. You will select 5 if you feel like you have an excellent understanding, and then 1 if you feel like you have a very little understanding. There's no right or wrong answer. We just want to know where each of you are at today, and we hope by the end of today's program that you will gain a greater understanding. Okay, a few more seconds. 3, 2, ooh, I see a few more jumping. 2, 1. Okay, I'm going to share the results. All right, we have 0 for excellent. That is okay, because we hope by the end of today that you will have a greater understanding. We have a lot with general understanding with 55%. We really hope that the number 4, great and excellent, will be increased by the end of today. And of course, with the recording of the meeting and the resource document, we hope that those will continue to improve your understanding. Thank you all so much for participating. If you would like to connect and interact more with us like you just did, we invite each of you to join the ABTA Social Hour taking place at the close of today's program at 4:30 p.m. Central Time. You will get the chance to meet fellow attendees from around the world and engage in meaningful conversations. This is the only session where you will get the opportunity to turn on your camera and say hello. This session will not be recorded. I would like to thank ABTA's Program Planning Chair, Dr. Susan Chang, for her leadership in the development of the Survivorship Program. Dr. Chang serves in the Division of Neuro-Oncology at the University of California, San Francisco. She specializes in treating adults with brain tumors. Dr. Chang is a principal investigator of a research project funded by the National Institutes of Health that focuses on optimizing the management of patients with glioblastoma. In addition, Dr. Chang is a medical director of the caregiver program at UCSF, developed to address the needs of family members and others who care for patients with brain tumors. And finally, she is the co-chair of the Patient Care and Survivorship track for the Society of Neuro-Oncology. The ABTA is truly grateful for our partnership with Dr. Chang, and it has been a pleasure to work with you. And with that said, please welcome our chair, Dr. Chang, to say a few words.
Thank you so much, Emily. Welcome everyone to the meeting. Thank you so much for joining. We all know that brain tumor survivors have distinct and complex medical, psychosocial, and cognitive needs, and that these needs change throughout the disease journey and can negatively impact not only the quality of life of the patients, but can sometimes overwhelm caregivers and loved ones. So we hope that today we can provide you with support, information, strategies, and resources to help you thrive. So thank you to the ABTA for making the important topic of survivorship a priority, and to the speakers who will share their knowledge, insight, and expertise with us today. I look forward to the meeting.
Thank you so much, Dr. Chang. Additionally, thank you to ABTA's presenting sponsor, Novocure, our gold sponsors, Servier Pharmaceuticals, Miami Cancer Institute, and Gannon Lee, our silver sponsor, Karyopharm Therapeutics, and our funders, Genentech and Integra Foundation. Thank you all for your support of this virtual event. Without the time and effort from each of these individuals, speakers, and organizations, we would not be able to bring you this quality educational programming that has brought together the brain tumor community. Our first session of today's meeting is all about the American Brain Tumor Association. The ABTA continues to be a proud advocate, and we are steadfast in our mission to be a strong ally and resource for the brain tumor community. This presentation will discuss the many ways that we are here to serve you and how you can get involved. Please help me to welcome ABTA's President and CEO, Ralph DeVito.
Thank you so much, Emily, and special thanks to Dr. Chang for working so closely with Emily and Nicole and the whole team and putting on today's session. I hope everyone enjoys it. So starting with the first slide here, to briefly sum up the mission, we want to advance the understanding and treatment of brain tumors so that we can improve, extend, and then, which we all want to do, ultimately save the lives of everyone diagnosed with any type of brain tumor. So I'll talk very briefly about what we're doing. And of course, never hesitate to ask questions, make comments now or next week. So the first slide, we'll talk a little bit about the next slide is our legacy, which is our commitment to peer-reviewed, investigator-initiated brain tumor research, all tumor types, all ages. If you see on the screen, you look at the history of the ABTA. We are proud that we have funded research throughout the US and around the globe. And so many of the research we have funded have gone on to produce significant opportunities with NIH funding. Next, you will see one of the real gems of the research program. This is a photo from 2019, the last time that we were able to bring back. We invite back all of the researchers that the ABTA has funded to come together for 2.5 days in Chicago to learn, to network, and to support one another in the writing of grants, joint publications, etc. We are pleased that we're going to be getting this group back together in person in 2022. So it's a great opportunity. We invite, as I said, all the folks that we have funded through the ABTA numerous research grants. Again, all tumor types, all ages. We have just sent out a notice that the letters of intent are due back in, I believe, in about a month or so. So if you are interested, please check our website, abta.org, or know someone. You can remind them that they've got about a month to submit a LOI. So that's our legacy. We're proud of the work we do, both directly funding and also collaborating with other organizations to jointly fund research projects we could not afford to do ourselves. The other key thing that we do as an organization is serve, inform, and support brain tumor patients and their families. How do we do it? So the first slide here, we'll talk a little bit about the extensive array of educational brochures that we have. They're free of charge, available for brain tumor patients and families. Again, these are constantly updated. We thank our just wonderful volunteers, the physicians who help us as we update them. Next, we are really proud of our care line also. We have a trained staff that will talk to you on the phone, email, text, messaging, whatever works for you, so that we can provide support, information, talk about resources for the brain tumor patient, wherever they are in their journey. It's initial diagnosis, it's possible recurrence, late stage effects, whatever it might be. It's also for the family members, for the professionals serving the patients. You might want to come to us and talk about ways you can get some information to help your patients. It's a great place to start. It is not a place for medical advice. We are here just to provide basic information, located in Chicago, serving people all over the country. So that's an in-person, direct one-on-one discussion. Next, we have as you see on the screen now, it's used to be in the 20s, and now it's 32,000 members of the Connections, an online community for brain tumor patients and caregivers. So it's a chance to engage online, which so many people feel more comfortable. You can remain anonymous. There are a variety of forums by topic or tumor type. So this is just a mention. Please go onto our website, abta.org, and get more information. Another way that we serve the brain tumor community is throughout the year, we have webinars, leading experts from all over the country that take their time to convey the latest information. And so we're very proud of the one that we've just held on the Survivorship Clinic. Everything is available on Anytime Learning, the ABTA YouTube channel. Leading experts, free of charge. I commend them to you. As we get the schedule for 2022, we will post it on our website. Next, we have these meetings, and normally they were held in person pre-pandemic, but our focus is on the health and safety, and we care about the well-being of the brain tumor patients and their families. So for this year and for next year, these meetings will be held virtually. We fully expect in 2023 to have a combination of virtual and in-person as we go forward. We do make ourselves available in ways virtually. So even when we meet in person, we want to try to continue to have technology be a friend to those who are not able to travel to in-person meetings. So these are in-person meetings normally, and they cover a wide array of topics. And again, Dr. Chang did a phenomenal job working with our team for today's session. Next is our signature program. It is our national conference. It's the largest and best conference in the brain tumor community. It's held annually in September. In fact, we have the dates for next year, September 9 and 10. So please put those dates on your calendar, or they're on the screen, September 9 and 10. So it's free of charge. We had a phenomenal keynote speaker the last few years. We had Maria Menounos in 2020. We had Dr. Burnett, who told such a compelling and moving story as a physician of diagnosing herself with a brain tumor and then her journey. And now she is a featured speaker all over the country, trying to inform and inspire those going through their own brain tumor journey. So September 9 and 10, 2022. Next, we also have something that is very valuable to people going through their own experience, and that is we train patients and caregivers to be mentors. And as you see on the screen, we have a couple of hundred trained mentors. So if you want to be a mentor, please contact us. I think now we're in pretty good shape with the number of mentors we have, but we're always open to listening and seeing if you'd like to be trained. And if you are in a situation as a brain tumor patient, currently in treatment, post-treatment, or if you are a family member, please, we can match you with someone going through your same experience. It'll be a virtual relationship by phone, email, any way that works for you. We're proud of this opportunity. It's just, you can see that the ABTA, we have an array of programs to support the brain tumor patients and their families. I'm very proud of what we do. That is just a flavoring of our research and patient services programs. Let me now transition to ways you might want to get involved with the American Brain Tumor Association. We are based in Chicago, as most of you know, but we're a nationwide organization with activities all over the country and a lot of virtual opportunities for you to get involved with the American Brain Tumor Association. So one of the ways is Team ABTA. If you are a marathon runner, if you're a cyclist, we just had 60 people in the Chicago Marathon who raised, I think, about $160,000 collectively, and so many stories. We are in the New York Marathon that's coming up. We have a post-pandemic, we expect to have a number of cycling programs. So if you're interested, contact us. You can do something that you love and it's healthy, and you can raise money to help us fund more research and serve more patients. We also have a situation where if you go back one screen, if the second item is a fundraise your way opportunity. So feel free to contact us and we will work with you, and you can do something in your home with friends in your community. You can even do your own walk, and we will guide you through the process. Next, we have our signature programs called BT5Ks. And we have them in 9 markets all over the country. We're excited about them. They're going to be on our website very soon, abta.org. We would love to have you get involved with that. We're also going to have a virtual BT5K coming up next week, but also for next year, we'll have an opportunity for you to do it. Again, abta.org. And then just generally, we really appreciate, next screen, please. We really appreciate our volunteers. And as I mentioned, we're active throughout the country, in person, virtually. There are fewer in-person opportunities, obviously, for the past 2 years, but they will slowly, again, ramp up, beginning with our 9 BT5Ks in markets from California to Texas to Florida to Illinois, Michigan, Minnesota, New York, Ohio. So we have opportunities. If you're in any one of those states, go to abta.org, please, and you can be a BT5K committee member. Also, a different opportunity is that mentor opportunity where we'll train you to be a mentor. You can join any of our event committees, or you could just generally be what we call an outreach specialist. And then finally, we're looking for skill-based volunteers. Let's say you have an interest in and a talent doing photography. We would love to have your volunteer skill set so we could capture our volunteers at a marathon, at a bike race, at a patient meeting, at a BT5K, or any other skill set that you might want to offer. Again, we'll customize the experience to where you are, in your time. So thank you for joining us today. Next slide. One of the best ways for you to stay in touch with the American Brain Tumor Association is our free newsletter that we've titled Mind Matters. And in addition, we're on social media, Twitter and Facebook, and a variety of other platforms, Instagram, LinkedIn. And I'm also I try and stay somewhat active on social media. Would love to engage you there and elsewhere, but please sign up, as you see there, abta.org. / Mind Matters sign up / That is a way for you to stay connected with us. Thank you again for joining us. We appreciate your time. I know you'll enjoy the entire day. Thank you.
Thank you so much, Ralph, for sharing with us about the mission of ABTA. I'm going to hand it over to our chair, Dr. Chang, to introduce our next session.
Thank you so much, Emily. And thank you, Ralph, for really telling us about the mission of the ABTA and how much you are doing for our patients and families. We appreciate it. So to start, I think adolescents and young adults are a unique set of those diagnosed with a brain tumor and therefore face distinct challenges from both older and younger age groups. And patients can be diagnosed as a child and have to manage symptoms through adolescence and young adulthood, or be diagnosed as a young adult. So this next session, titled Surviving and Thriving as an Adolescent and Young Adult, addresses endocrine, developmental, and psychosocial needs of adolescents and young adults with brain tumors. You will also learn the stages of transition and how to thrive in survivorship. Now, as we plan the UCSF Sherry Sobrato Brisson Brain Cancer Survivorship Program, we recognized how important it was to listen to our patients about their personal experience to help us learn about the challenges of survivorship and ways that we can make things better. And similarly, I think having a patient voice really sets the stage for our meeting today. So I'm so pleased that Nick Stump, a high-grade meningioma patient who was first diagnosed in 2015 at the age of 23, has agreed to join us this morning. So as a young adult patient, Nick has had to navigate a diagnosis and a recurrence during transitory parts of his life. I'd like to please welcome Nick. So Nick, I understand, thank you again for spending time with us. And I understand that, your time of your initial diagnosis and recurrence, it was really during some transitory parts of your life. So first, maybe can you share with us your tumor journey and your treatment?
Hi, everybody, and thank you so much for having me. My name is Nick Stump, and as Dr. Chang was saying, I was initially diagnosed when I was 23 years old with a grade 3 meningioma, and it was about 2 months before I was supposed to go to grad school at San Diego State University. And it was something that was very difficult. I had to put my life on pause for that first year, or it took a while because from my initial diagnosis, I was in an emergency surgery a week later, and then had other follow-up treatment with radiation and also a clinical trial that I was on afterwards. I was very fortunate in that I got to go a year later to grad school and was able to finish the program. And it was actually the day after I had graduated that I had a second or the first reoccurrence or second that required a second surgery. So I was in, as Dr. Chang was saying, a very transitionary part of my life at that point. And it was something that really required a lot of kind of reprioritizing what I thought was important. Being able to focus on my healthcare as everybody is focusing on jumping into the workforce and different whatever avenues they were. This is something that during parts of my life that really, as things were at different pivot points, really having to make choices on what takes priority, or putting my healthcare at the kind of front of the line on that.
Yeah, so that must have been really hard. So, after your first initial diagnosis, you went on to get your master's degree. So did you notice any differences or have any difficulties getting through your program compared to when you were learning, earning your bachelor's degree?
There was definitely, it was more difficult, especially because during my first semester of the 2-year program, I was still on one of the clinical trials. I'd been taking medicine known as Sutent. So I was extremely exhausted all of the time on this. And the work itself was more difficult than in undergrad, but it was something that I knew I was kind of a leg behind with everybody else, or it would take me longer to be able to work on assignments. So really being able to have that determination to focus on the determination to make sure stuff gets done it took me longer, so I needed to kind of build in that extra time to my schedule, or sometimes it might take me a little longer to make sure that I'm really understanding things than some folks. So wanting to make sure to give myself enough time and space to do that, especially in a world in which I'm trying to manage monthly doctor appointments with still attending school and teaching full time.
Yeah, yeah. Who was your major focus of support for you during those two times? You know, did you have to go back home to your parents? What was that like?
Yep. So during the initial diagnosis, I was living with my parents at the time. So I was fortunate, extremely privileged that that was a resource that was available. Was living with my parents. My mom and dad were extremely helpful through this process. Can't thank them enough for that. And during the second time, or when I was still in San Diego, I'd actually had a couple really good friends who I lived not too far from. One of them who was doing the same program at that time. So it was having the buddy system with that to have folks who could help me out. But after when I was diagnosed in San Diego, I actually moved back to Arizona to receive my treatment again through Barrow Neurological Institute and the Ivy Brain Tumor Center.
Mhm. Yeah, I mean, I think it really highlights that the definition of survivorship not only affects the patients, but also the loved ones and the caregivers around them. So it was wonderful that you were able to get that support. You know, you mentioned, you know, you graduated from master's, you were diagnosed with a recurrence. And now that school is over, you've graduated. How was it like entering into the workforce?
It's very different because sometimes people might not guess things like my health diagnosis based on my age or based on some of the other kind of outwardly facing signs on that. There have been a handful of things that have been kind of difficult to negotiate in terms of needing to receive ongoing treatment while balancing like work priorities, or making sure that what their expectations on making sure all my work can get finished happens, along with still maintaining the like quality of care that I need to be able to receive.
Yeah, and you mentioned that you were actually on a clinical trial when you were going through your studying. And I think one of the things we wanted to highlight with this meeting today was about side effects. So not only side effects of the actual diagnosis and the treatment of tumor, but as I said, the actual treatments that you underwent. So what were some of the side effects that you felt really interfered with your ability to sort of continue with your studies, continue with getting work?
So the couple things were exhaustion. I think one of the things that's pretty universal with most of the medicines, and also being a brain tumor patient survivor, whichever kind of labels you want to describe folks as, or receiving treatment, is it's pretty physically, mentally, and emotionally draining on that. So making sure that can still show up with enough energy to deliver class and make sure that staying on top of everything. So balancing those needs. I think it was difficult, the kind of time aspects of making sure that I can balance when all my medical appointments were with making sure everything could get done with school, regardless of what time in the semester I'm in. I think there are the other, yeah, that I've been very fortunate with the medicines I've taken, that when I've had side effects, they've been still things that have been manageable and been treatable. So if I had to spend extra time going to clinics to make sure that I was getting shots to help with my immune system or things like that, making sure all of those things are taken care of. Something I've been told since the beginning was I need to treat every season like it's flu season. So that's something, making sure to stay safe out there, or knowing that a little illness for other people might be a little bit worse for me.
Yeah, I think especially with COVID, right? I mean, you probably had to go through a lot of challenges with trying to keep yourself safe, keeping your family safe. I think that was an added challenge, I think, for all patients with any kind of illness like cancer. So absolutely. So what were some of the things? I think you mentioned very clearly about time management, prioritization of the things that you need to get done. really attending to your sleep and to your fatigue, things that fatigue you. But what were some of the other things that you sort of took charge of? I think the title of our meeting today is really taking charge of your journey. So what were some other things that you did to sort of say, you know what, I'm going to do this so that I can have the best quality of life?
Yep. It's also then paying attention to as much kind of nutritional advice as possible. This is something that I've had times with everybody has things that works well or not so well with others. Trying things like ketogenic diets. That was something that I had tried. That was not something that was felt well for me, but it's making sure to pay attention to all those other nutritional things. And in terms of eating balanced diets or eating things that are well, what I'm gonna, trying to take care of myself on that. There's also making sure, as you were saying, getting enough sleep or trying to stay active enough, because it can be really, it's that catch-22 that exists sometimes of when you're tired, you don't exercise as much, so then you get more tired easily. Trying to pay attention to all of those things. And then making sure that any kind of vitamins, supplements, things that I am taking like that don't interact negatively with any of the medicines. So trying to take the proactive approach or see things from the long-term view, even when sometimes the research is still being formed.
Yeah, yeah. So what were some of the things you wish were in place at your time of diagnosis, or wish you had known so that you could tap into that weren't available now that you've had a diagnosis for so many years, looking back?
From the initial diagnosis I had, I wish I had had a little more awareness with the kind of like group programs or the kind of other like mentorship that was just being mentioned not too long ago. Everybody's experience is very different, so sometimes those can be very good meshes with folks. Other times not so much. The folks at Barrow do a wonderful job with the like Gray Matters Foundation, things like that. I wasn't aware at the time, but this is something that being able to take proactive approaches with that, that they've been really doing a great job with that. Sometimes being paired with somebody like a social worker who might have things, how do I say it, better understanding with kind of what the day-to-day looks like through going through work, asking about like FMLA kind of questions, or how to actually approach things from an insurance standpoint, because it's a whole other language of its own. Those are a couple things I wish I knew. Sometimes the resources for caregivers are also really important, because we focus very much on the patients, and this is extremely important, and they're the center of the attention in a lot of that. But making sure that there's a strong social network around them, or a strong social system, because caregiver fatigue is a real thing, and wanting to make sure that we're really setting up patients for the best success possible.
Yeah, I mean, I think you're highlighting some of the things that really all brain tumor programs should be focused on. It's not only the sort of treatments, and it's great that we're doing clinical trials, we have cutting edge technology, but a lot of things I've heard our patients and families say is that we need help right here, right now, for things like making sure that we have resources like how to get back to work, and the practical aspects of things. So I think that that's really an important message that that we really need to spread to all of our programs nationally and internationally. So, what has been the most difficult part, you think, of being diagnosed at a young age? I mean, I know it's a malignant brain tumor. That in itself is so difficult to deal with. But being in the age group that you were at, what would you say was the most difficult?
I'd say, if I could narrow it down to three things that I thought were most difficult, I'd probably say there's a huge extent of relating to others that within my same age range that can be really difficult. And that I think the impact on caregivers, as I was just mentioning, can be something that's not thought about, or wanting to make sure that that it is a traumatic experience on other people, or for the folks who do have a child who's diagnosed with any form of brain tumor, it's really hard to deal with, or something that there's no training manual on how to do this or how to interact in that. And then kind of adjusting to the day-to-day life, in terms of a lot of times people have like a really big outpouring and want to know what's going on. And then after time, if things are going all right, the attention kind of fades. So I'd say that can be really difficult of relating to people, making sure that like we're having good care of our caretakers, whether that's healthcare providers or the kind of at-home social networks on that, and just adjusting to what the new normal diagnosis or what the new normal can look like post any kind of treatment.
Yeah, that's so important. And I just love how you think of others. You're thinking of yourself, but you're thinking of your parents and all your friends and family who had to deal with this. That's just amazing. And you are so great at advocating for yourself, which is not an easy skill, especially at a young age. So what advice would you give other young adults to be able to accomplish this sort of ability to thrive, really? I mean, I think you've been able to show you can thrive despite a diagnosis. And that's where we want all of our patients to be.
Oh, I greatly appreciate that. Advice I probably have for folks is having hope. It's a huge thing about the mindset can make all the difference in the world. I know that things aren't easy and that there are things that are outside of our control. Having hope and how you want to approach these kind of things can make all the difference for what you spend your time doing throughout the course of your life. I think being able to give yourself a break is also an important thing, or being able to treat yourself with a level of grace on that, because it can be really difficult when sometimes limits get imposed upon people, whether that's a lack of access to driving or something needing like memory assistance for folks, or any kind of thing. So it's difficult as it is, and as much as I give this advice to others, I'm terrible at doing it, of not comparing yourself to others or trying to benchmark yourself exactly to where maybe people were prior to your treatment or things like that. And the other thing is really kind of do what fills your own cup. I know it's been a phrase said a lot. I've heard recently about do what makes you be able to feel good about the work you're doing, about what kind of change you want to see within this world. I do really want to thank the folks at the Barrow Neurological Institute and Ivy Brain Tumor Center for the ways in which they're really providing hope for people through the innovative processes and the technological advancements to make sure that their clinical trials are safe and providing hope for people in the future. But wanted to make sure that everybody really goes down a different path. So whatever fills your cup, whatever works for you, because sometimes what works for some people does not work for others. I've known several people who really feel great on the like ketogenic diet, for an example, and that there's still a lot of to be said within the trial space within that. That was something that didn't work as well for me. Some people have had really great experiences with the like occupational therapists or other kind of things like that, the neurotherapy. So this is something, if you can feel like you are making progress within yourself, really do it. Trust yourself is what I mean by that.
Wow, that was just such an incredible, sharing of what your experience is like. We really want to thank you so much for that, sort of telling us about your journey and the unique challenges that you've had to face as a young adult. So thank you so much, Nick. I think everyone on the meeting today really appreciates it. And now I would like to introduce Carla Wilson. Carla is a nurse practitioner who has a greater than 45 years of experience in the field of childhood cancer. And she's specialized in working with children with CNS tumors. And for the last 16 years, she's been a nurse practitioner for the childhood and adolescent young adult cancer survivorship program at City of Hope in California. Please welcome Carla as she shares about the transition from pediatric patients to young adults.
Thank you very much for that introduction.
All right, Carla, to activate control of the screen, just take your mouse and click the first slide.
Did that.
There you go.
Today, while talking, really looking at issues for patients that are in what we call the AYA group, which is adolescents and young adults between the ages of 15 and 39. And often people in that age group kind of fall through the cracks because they're not totally pediatric, but they're not totally adult patients either. And today I'm going to talk a little bit about endocrine issues, developmental issues, and other issues for brain tumor survivors as they transition out of that pediatric world and into the adolescent young adult. I will not be talking about cognitive issues because that's a whole topic in its own. So I'm hoping to give you information that helps you be able to transition better and know what types of things to advocate for. So I wanted to give a little background about brain tumor survivorship. And I think one of the very important things about a person having a brain tumor, many of the issues are related to where the tumor is. In fact, people who work in neuro-oncology often say that the field of neural tumors is the equivalent of real estate. It's all about location. It's the location of the tumor that means, can it be surgically resected? Location of the tumor is what can cause different side effects. And so looking at general statistics, in the United States, there are about 2 million people diagnosed with cancer each year. A little over 100,000 are people between the ages of newborns to age 39, and really are less than 2% of all the people that are actually diagnosed. If we look at central nervous system tumors, that includes tumors of both the brain and spinal cord, there are about 25,000 people 16 and older who are diagnosed, and about 3,500 that are less than 16. And the incidence of brain tumors is about 15% in the AYA population. It is predicted that there are about 12,000 AYAs who will be diagnosed this year, and that there are about 32,000 AYAs who our survivors are living with a brain tumor diagnosis. So I'm going to focus a little bit on endocrine health. When we look at the issues that occur for people, some of the most common ones are related to the endocrine system or the hormone system. And then cognitive issues is the other area that's extremely large that for having an impact on people's lifestyles based on their brain tumor. So the endocrine system basically is a system that secretes hormones and chemicals that tell the body what to do. So it says, we're going to regulate the activity of cells and organs. Endocrine hormones can help control your mood, your metabolism, the way your organs work, growth and development, as well as reproductive and sexual function. The pituitary gland, which is, you can see on this diagram, is kind of in the middle of the brain, is called the master gland. It basically tells all other glands what to do and how to work. But the pituitary gland secretes hormones, and it depends on, tells them how much of each hormone should be released. And the hormones that we really think about with the pituitary gland are growth hormone, the thyroid stimulating hormone, because our TSH, it tells the thyroid gland to make thyroid hormone. The antidiuretic or water hormone called ADH, the adrenocorticotropic or stress hormone called ACTH, gonadotrophin are puberty hormones. Those have to do with sexual development, called the luteinizing hormone and the follicle stimulating hormone. And then there's the prolactin and oxytocin hormones, which I'm not really going to discuss at all today. When you have injury that can be either by surgery or by radiation to the pituitary gland, you can develop something called hypopituitarism. And that's when you have 2 or more pituitary hormones that are not functioning properly. Panhypopituitarism is when all hormones that are produced by the pituitary gland are no longer functioning properly. And this is some of the examples of pituitary or hypopituitary issues. The ACTH causes adrenal insufficiency, and people who have adrenal insufficiency may have things like fatigue, dizziness, low blood pressure, and their body can't respond to stress. So the people who have abnormal ACTH or adrenal insufficiency need to be on a cortisol hormone and have replacement for replacing what's not being made by the body. And since this is related to stress, when you become ill, you need an increased dose. And this is something that you work very closely with your primarily endocrinologist on monitoring and maintaining appropriate levels of your ACTH. The thyroid stimulating hormone often leads to insufficient production leads to a hypothyroidism. And hypothyroidism can cause depression, lethargy, thinning of hair, weight gain, and a thyroid supplement that you take orally is how you treat hypothyroidism. The gonadotrophin hormones cause hypogonadism. So that can lead to infertility, it can lead to decreased sex drive, but it can also lead to osteoporosis, which is a thinning of the bones that puts you at greater risk for fractures. Treatment for this is hormone replacement therapy. In males, it's a testosterone supplement, and for females, it's a combination of estrogen and progesterone. The hormone deficit of the antidiuretic hormone leads to something called diabetes insipidus. And there are some people with brain tumors who, how they get diagnosed is the symptoms of diabetes insipidus or DI. You have excessive thirst and excessive urination, and your blood sodium level is very low. And the treatment for this is a medication called desmopressin that can either be taken orally or in a nasal spray. So with thyroid issues, actually hypothyroidism is the most common thyroid issue. And as I mentioned before, depression, dry skin, hair, cold intolerance, weight gain, puffy face, and frequently low energy and muscle weakness. And treatment is a thyroid replacement medication. Hyperthyroidism is less common, but it does occur. In fact, in my patient population of survivors that I follow, I only have a handful of patients that have developed hyperthyroidism, and I have a fair number that have developed hypothyroidism. With hyperthyroidism, though, you have heat sensitivity. You may have a swollen thyroid gland, or your neck may look very large. It can cause anxiety, agitation, mood swings. And frequently people with hyperthyroidism will have a rapid or a very uneven heart rate. And they may have palpitations. And the treatment for this is antithyroid medication. So the opposite of hypothyroidism. With hypothyroidism, you need thyroid supplement. With hyperthyroidism, you need to take away some of the production of the thyroid. Sometimes it involves giving radioactive iodine to knock out the thyroid glands so it won't produce thyroid hormone. And sometimes you do have to have your thyroid gland actually removed in order to treat this issue. And then growth hormone deficiency is another problem that occurs. And it occurs again when either the tumor or radiation affects the hypothalamic pituitary axis of the brain. The higher the radiation dose, the greater risk of having a deficit. And what you can see, if you have low dose radiation in children who have not gone through puberty, they may actually develop premature puberty and go into puberty too early. And then they can then have growth hormone failure. High dose radiation leads to growth hormone failure and actually puberty delay. And in females can cause premature ovarian failure, or which is basically premature menopause. The risk of growth hormone deficiency is related to the dose of radiation to that hypothalamic area of the brain, but it's also related to the age of the patient. Children less than 10 years of age, when they get the radiation, are much more likely to develop growth hormone deficiency than children who are older. But we also have to think about growth hormone deficiency in adults. It's not just about growth hormones, not just about getting tall. It has a lot to do with overall brain function, your muscle mass, your bone health, and it actually impacts your cholesterol levels. The LDL, which is the bad cholesterol, is more likely to be elevated. The HDL, which is the good cholesterol, is more likely to be suboptimal. And triglycerides, which are often associated with the development of type 2 diabetes if they are elevated for a long period of time. Those things can all be abnormal because of growth hormone. And sometimes, unless someone goes on growth hormone supplement, you cannot get good control of those cholesterol levels. And then growth hormone deficiency also impacts how our body collects fat. And when you have growth hormone deficiency, you're more likely to accumulate fat around the trunk of the body, which then puts you at greater risk of problems related to heart disease, strokes, etc., because you have fat around the very important organs in your abdominal cavity. Some of the symptoms we see for growth hormone deficiency in adults include intolerance of either heat or cold, frequently decreased sexual function or decreased interest, anxiety, depression, feeling socially isolated, having less muscle mass with less strength, less stamina, increased fatigue. You have decreased bone density. So that gives you an increased risk of fractures when you age. And again, a higher level of body fat, especially around the waist. So again, as I said before, the causes are related to damage or injury to the pituitary gland or the hypothalamus, and it can be from either surgery or radiation. It may be from the tumor, especially if the tumor is not resectable. And you might need to have an MRI to really look at the appearance of the hypothalamus and pituitary gland. And then frequently you'll have something called a growth hormone stimulation test to see if your body can make growth hormone. Treatment can be growth hormone injections, routine monitoring to check growth hormone levels, also monitoring of the bone density as well as the cholesterol or lipid levels. I personally feel that an endocrinologist is one of the key members of the team, and I recommend all the patients that have brain tumors that I follow in my clinic have at least a baseline endocrinology consult if they have not had that done before. So now I'm going to switch gears a little bit and talk about issues related to survivorship and survivorship care plans. In 2005, the Institute of Medicine came out with a book called From Cancer Patient to Cancer Survivor, and really started looking at this focus of transition and how important that survivorship care needed to be for patients. So we do consider cancer survivorship care now a separate phase. So we look at new diagnosis, treatment, and follow-up care, but survivorship care actually is no different than the actual treatment you receive. So it's an extremely important part to maintain the best quality of health for yourself. And how we do survivorship care, we look at what are your risk factors based on the treatment that you had. And we do different tests depending upon your specific treatment. It's very important to look at both the physical health and the psychosocial coping when we monitor and assess health. It's important to manage late effects, and it's important to have health promotion and education. And one of the reasons survivorship care is so important, it may help identify a late effective treatment early on, and the earlier something is identified, the better evaluation and treatment that you can provide. And as I mentioned earlier, the endocrinologist is one of the key members of your team. And depending upon your situation, depends on who your follow-up with. Are you still seeing your oncologist? Are you following up with your neurologist? Are your neurosurgeon? Or even your radiation oncologist? And an important part of assessment for a person who is a brain tumor survivor is neuropsych evaluation, because this may be very helpful for giving you information related to educational and vocational programs. But again, that's going to be discussed in a different situation. But when we look at cancer survivorship, we look at it being basically the tip of the iceberg. A brain tumor diagnosis and treatment is that tip of the iceberg, but underneath that tip are a lot of implications for your long-term future health. So what are survivorship care plans? How do you use them? How do you develop them? Well, survivorship care plans should have a summary of the treatment you received, and it's often referred to as treatment exposures. What significant complications did you have during treatment, if any? And it identifies actual and potential health risks related to your diagnosis and treatment. And it should be used by all members of the team. And when we're talking about the team, we're talking about everyone involved, the survivor, family members, as Nick mentioned, how important that social network, that family network is to your well-being and healthcare. The oncology team, which may include a whole variety of people, the oncologist, a nurse practitioner, endocrinologist, late effects people, but it also might include physical therapy, occupational therapy, speech therapy. So all the members of the team that help improve your healthcare and the quality of your life. And then your primary healthcare provider is also an extremely important part of the team and needs to be kept into the loop. So the purpose of these care plans is to really help with coordinating care and surveillance. What's the appropriate monitoring? What's the appropriate health promotion for the individual person? And a care plan should hopefully enhance communication between all the members of the team. So you want to be able to identify and manage any type of long-term effect and refer to the appropriate specialist if needed. And again, it can be a medical person, it might be school people, it might be vocational rehab. But one of the key things for a team, so there needs to be a captain of the team. So you don't have fragmented care. You need someone who can make sure that all of the members of the team are on the same page, are getting the same information, and see the patient as a whole picture and not just one small entity for each person's specialty. So the value of a concise treatment summary is it gives very good information about your diagnosis, your staging, where was the tumor located, what was the type of surgery, was the tumor completely removed or was it not able to be completely removed? What was the age at the time that you were diagnosed in treatment? Because age can have a factor on what late effects that you may be at risk for. What type of treatment did you have? Did you have chemotherapy? What were the cumulative doses of the chemotherapy is if the cumulative dose impacts a late effect risk? What was the radiation field? So the area of the brain that was radiated. What was the cumulative dose? What was the type of radiation that was delivered? What was the location of the surgery? Do you have a shunt? Did you have a shunt? Is a shunt still in place? And what significant complications of treatment did you have? So this is just an example of a treatment summary. And in the pediatric world, we use something called Passport for Care. We follow the Children's Oncology Group long-term follow-up guidelines to give us information about what we do, screen and how we screen, and we screen specific to the patient's treatment. And even though this is put out by the Children's Oncology Group, I use the same guidelines for all of our patients, regardless of whether they were diagnosed as a 15-year-old or a 35-year-old. And it's very helpful in giving what recommendations so that we don't overscreen and do tests that aren't needed, but that we don't miss tests that should be being done so that we can provide the best quality of healthcare for you. It's important for survivors to choose the right provider. And I tell people when they're looking for a primary healthcare provider, go when you're healthy and do an interview. Is this someone you can talk with? Is this someone who's willing to be a member of the team and participate as a member of the team? And when you choose insurance, what are your needs? Do you need a lot of medications? Do you need rehab? How often do you have to see a healthcare provider? How many specialists do you have to see? And I think it's extremely important to be proactive and not reactive. When patients turn 21 in California, they lose their Medi-Cal and their CCS. Patients across the country who are covered by their parents' insurance lose their insurance at age 26. If you're treated at a pediatric facility, often when you turn 18 to 21, you're considered aged out and you have to have a new provider. So moving forward, it's important to look for your future, but you have to use your past to help provide for the future. There are resources that can help. There's a nonprofit called Triage Cancer, which is excellent at giving people recommendations on how to figure out the insurance world and how to figure out what insurance that is going to best meet your needs, as far as, do you need a plan that's very comprehensive, or do you have limited needs for insurance? There are other survivorship resources that are really helpful. The American Society of Clinical Oncology has very good information about survivorship plans. Journey Forward, Live Strong has care plan recommendations. And again, the Children's Oncology Group Survivorship Guidelines, which are publicly available at this website. So in summary, I think it's really important for the patient and family to learn to be their own healthcare advocates. It's important to utilize the resources that you have in the community, whether they're actually local or web-based. Just like the ABTA has the mentoring program. It's important to feel empowered and to be able to make choices regarding healthy lifestyle practices and your ongoing health care. And Julia Rowland, who used to be the director of the National Cancer Institute Office of Cancer Survivorship, says, being cancer-free is not the same as being free of cancer. And then Grace Monaco started an organization in the 1970s called Candlelighters. And she was the mother of a patient diagnosed with cancer, not a brain tumor though. But she said, life is a hollow gift unless cancer survivors emerge from treatment as competent and worthy individuals, able to obtain insurance, equipped to earn a living, and prepared to participate in a medical surveillance program to keep the life they have won. And so my challenge to all brain tumor patients and patients who are survivors is do what you can to have the best quality of life and the best quality of care as you move forward in this journey that you are on. And thank you very much. We will have questions at the end of the next speaker.
Wow, thank you so much, Carla. That was just incredible. Thank you for the important information and the guidance for patients diagnosed as a child who transition into young adulthood. We appreciate it. As Carla said, please enter your questions in the Q&A so that we can address them. We'll have a special session for those questions. Thank you. So I'd now like to introduce Dr. Jayshree Blakely, a really great colleague of mine and a neuro-oncologist and clinician scientist with research expertise in the development of clinical trials for central nervous system tumors with a particular emphasis on neurofibromatosis. And Dr. Blakely's research and programmatic efforts are all in the service of improving outcomes for people living with central nervous tumors, for whom she is honored to provide the care. So please welcome Dr. Blakely as she shares about the transition between young adults to adults. Thanks, Jayshree.
Thank you so much. What an honor to be here. I need to say thank you in particular to Mr. Stump for such wise, authentic, and truly resonating reflections, and then the wonderful job by Carla. It's an honor again to be here. So I'm going to switch gears a little bit at the start of this talk to give some definitions. I'm going to go back one. Sorry about that. So just to mention that when we talk about brain tumors, that is a global 50,000 foot term that describes many, many things. And those individual diagnoses occur across an age spectrum. And so this is from a wonderful resource, the CB Trust, which provides the epidemiologic data about brain tumor diagnoses in the US. And what this graph is showing from their 2021 report is the top row and the red bars are any brain or nervous system diagnosis by age group. So 0 to 14, 15 to 39, and greater than 40. And I think this is really helpful because this is one of the things we consider as a branch point of ages for pediatric and the 0 to 14, young adult, adolescent, and adults. And what you'll see is that the overall brain tumor diagnosis is incredibly high. The leading number type of diagnosis in children drops a lot when you get to adolescent and young adult, and one of the most rare diagnoses to have in adulthood. And I do want to point out some positivity in that this lower row is the mortality from tumors related to brain or other central nervous system. And you can see it really is a low bar across all of the other tumor types. That doesn't mean it's not our number one priority is to both prolong and improve quality of life for people with brain tumors, but just to give a sense of the frequency and range of diagnosis by age group and then mortality by age group. And then I'll zoom in a little farther to show what's inside of those red bars. And this graph from the same report shows the type of tumor that is present by age group. And this is linked by 0 to 4 years old, 5 to 9 years old, 10 to 14, 15 to 19. And then these are the adult years in quite small increments, 20 to 24 years, 25 to 29 years. This is all epidemiologic data. And what you'll see is a list of names. These are all names of tumors. And actually, all of these tumors can occur in any person at any age. And there are implications about how old you are if one of these tumors show up, like Carla was talking about, in terms of how we think about whether there might be an underlying genetic cause or what that tumor might be susceptible to in terms of treatments. So this dizzying slide is one step farther down into Zoom to show you our current diagnostic criteria for central nervous system tumors. Actually, the full report has not yet been published, but the summary of the report came out just this past summer. And this shows you how many individual terms there are for any type of central nervous system tumor. You are not meant to know that, but we have to know that. And one of the things we use this for is to figure out which tumors are most common by certain age groups. So you'll see that these in the official diagnostic criteria, they're listed by adult type or pediatric type. This is a change. We didn't used to distinguish these by age, and we didn't used to say type, because what we mean by that is absolutely an adult can have a medulloblastoma, but in general, we consider that a pediatric diagnosis. So it's a pediatric type tumor. And one of the reasons this is coming about is you'll see all of this mumbo jumbo, this alphabet soup, like MYB or MAP kinase or H3K27. These are all molecular or DNA-based markers of a particular tumor type. And in a large part of oncology, these molecular markers are already defining subtypes of diagnoses in lung cancer and leukemias. This is a relatively new development in neuro-oncology, and it's a really important development because suddenly, instead of having one term medulloblastoma, we have 5 terms depending on what the genetic or molecular markers were. This slide is just simply to show the similarities and differences between adult and pediatric tumors in both panels. A is the location of the brain tumor. As Carla was saying, brain tumor diagnoses have a lot to do with real estate in terms of function. And the B panel in both is saying the type of brain tumors. And you're not meant to read this. My only point is to say both, there are similarities and differences across pediatric and adult and adolescent populations. And we just have to keep that in mind as we're thinking about the treatments, but not to say, oh, this never happens in a child or this never happens in an adult. Okay, so now on this slide, I'd like you to try to find the pink bars. The pink bars are glioma. All of the other colors represent different cancers, like the blue bar is ovarian or the brown bar is thyroid cancer. And so you'll see that there are different types of cancers that are present in children versus adults, first of all. But gliomas are true across both. And what's I was mentioning, our new diagnostic criteria, that dizzying slide of terms, is now being flavored and nuanced by these molecular or DNA features. And what you'll see here is a really strong representation of something called BRAF and something else called FGFR1. These are important because they might help us think of very specific treatments for a tumor that has this change in its DNA. And these are shared between adults and children. And you'll see here in BRAF is a very important mutation for many cancers in adults like melanoma, but it also happens to be an important mutation for some types of adult tumors. And this is what we're learning is that these molecular findings are part of the equalizer between pediatric tumor types, adolescent and adult tumor types. And this was a constellation of several papers that reflect this, but I really like this table in particular from Ferguson et al., because what it speaks to is if you're talking about gliomas in particular, low grade or high grade, or medulloblastoma, ependymoma, or craniopharyngioma, these are the subtypes of brain tumors where we have very specific knowledge about molecular changes. I mentioned that BRAF, here it's showing up as a diffuse astrocytoma, which can be seen in both pediatrics, adolescents, and adults. Medulloblastoma, I mentioned those subtypes that we are now using to distinguish what treatment should be given based on the molecular subtype. We are learning a lot more right now about ependymoma, and the location of the ependymoma is associated with different molecular features. And these features are important because they are potential targets for very specific treatments. So for example, this TRK fusion that shows how very unlikely an adult glioma is to have that, but a high percentage of high-grade gliomas, or a higher percentage of high-grade gliomas in young children, will have this fusion, and there are very specific and effective TRK fusion inhibitors. So with that in mind, just thinking about the similarities and differences between pediatric, adolescent, and adult gliomas, how does one organize that information into how to coordinate treatment? Well, the first is, it's a great idea and worth the effort to find a neuro-oncology center. My preference, for all the reasons Carla just mentioned, is a place that has both pediatric and adult experts, because there again is a continuum, and we all are trained as physicians and nurses and occupational physical therapists in different areas, and we work together to give the best comprehensive view. So a comprehensive center that has all of those needs, or you don't have to be a comprehensive center, but you want to think about pulling together that comprehensive team yourself if you're not in a center. I mentioned all of those molecular findings. How does one get that from their tumor? Well, it's a platform and a technique called next generation sequencing. This used to be extremely expensive and take forever, but after the National Genome Project, where the entire human genome was sequenced, every year there are increased efficiencies. And so now you can sequence a tumor's entire genome in probably a day for probably $700. And that is now covered by insurance because it has true impact on treatment decisions. And what I'm showing you here is this is just a screenshot from clinicaltrials.gov, where all of us find our information about what clinical trials are available by region, by tumor type. And these clinical trials are specifically listed under a particular mutation subtype. So I would put in NF2 and vestibular schwannoma and find a clinical trial for that specific mutation in that tumor. So if you have a new diagnosis tumor, I'm a big advocate of next generation sequencing on that tumor tissue. It can be done on stored tissue, on fresh tissue. There are many private companies that do it, and most hospital centers do it. And then, as I was mentioning in the clinicaltrials.gov, once you have that data, you can search by mutation type, the tumor type, all those names that was showing you in that long list, age, and where they are in enrollment status. And then Carla mentioned this, and you see that since we're both saying it, how important it is. It really matters that you have a team that each member of the team knows what their role is, and there is a captain of that team, and that you are comfortable with that team. And you don't have to stay with people you're not comfortable with. And you are absolutely probably the core captain of the team in saying, I want things to move this way or that way. And hopefully there's an open dialogue with your team so that when a provider says, I can or can't do this thing for you, that feels comfortable and expected. Every person who has ever had a brain tumor needs a primary care provider. That's either internal medicine, pediatrics, family medicine. That is not your oncologist. And the reason for that is that oncology is not set up for the normal routine health maintenance. Did you get your mammogram? Did you get your pap smear? Did you have your flu shot? What happens when you have strep throat? And the oncology team will often coordinate with the primary care team. I do this universally to make sure that the rest of their health is optimized, blood sugar control, thyroid management, like Carla was mentioning, so that we can focus on what has to happen on the oncology side. Someone has to be the master keeper of medications. I often ask that to be in my case, our team, the oncology team, with the patient and their caregivers. A core thing is having your own imaging. One, basically what you're going to hear me say is the medical system is completely disorganized. And if there is very little streamlined communication, there are a lot of dedicated people who will make it happen, but you will be in better position if you keep your own records. Fortunately, with electronic health records, now many of the physicians release their notes openly. It's called the Open Note Act. So once I finish a clinic visit with you and I close my note, you can read whatever I said and you can share it with whoever you'd like. It's yours to have. The images, the actual pictures of your brain MRI or your CT are not available in the same way. So it's worth keeping a copy of your CDs. Carla already mentioned having your treatment plan, the detailed history. One of the things that I want to mention to people is when people have radiation for any given tumor, there is a short summary that's given that says the dose and the dates and the fields. And then there's a picture, it looks like artwork, of the radiation field. And that picture is really important to have if you're going to be transferring centers, because that shows what part of the brain was exposed to what dose of the radiation. And that can't be understood from a written report. You have to have the pictures. And then very importantly, it's important for the patient and their care team at home and within the medical system to have created a statement of advance directive. I don't mean the legal document, that's helpful too, but I really mean, what are our goals of care? What do we want to be happening now, next year, 5 years from now, 10 years from now? And that is that, so we're all on the same page. Are we a group that is a risk averse? We're not going to pursue therapies that might have a lot of side effects. Or are we a group that says we want everything that can possibly be done? Of course, we have to discuss the risks and benefits, but more likely we're going to say yes to an experimental therapy, things like that. Flowing from that is defining this is legal. Who is your healthcare proxy? And the legal term for this is a durable power of attorney. Powers of attorney can be made for both medical decision-making and financial decision-making. The thing that we will ask about is who is the healthcare proxy? Who do you want us to talk to? And now I'm speaking to caregivers. It is really important that on the caregiving team, we have one person who's the captain, who is the main go-between for on that triangle that Carlos showed between the medical team and the patient and the rest of the world who cares about the patient and has a million questions. And in particular, people are blessed to have many caring people and not always with the same viewpoints. Or I bet if we ask people participating today, how many times do they get an email saying, oh, I saw this study about mouse treatment and it was curing medulloblastoma. I thought you should have this. That can ultimately be a great burden on the person who gets those emails and is in their treatment already. So that's where I think a single communicator, the healthcare proxy, can really be a huge asset to the patient to be a buffer for some of that constant intake, and also to make sure that there's a clear message of communication between the patient caregiving team at home and the caregiving team in the medical system. And then please ask questions and clarify. And I love emails or my chart messages within the electronic health record that say, you told me about these options, and then you gave me the stuff to read, and I read some more, and I have some more questions. Perfect. That means we are both working together to make the best possible informed decision. If you're in a situation where you feel uncomfortable going back to your care team to ask more questions, we might have to re-explore that caregiving team. And I think an important thing that Nick mentioned that we have to think about is when you're making a decision, what is the physical and time burden of that decision? Are you going back every 2 weeks, every month, every 6 weeks, every 8 weeks? How does that work in terms of being in school, being in work, and make those decisions together as one of the variables for the benefits and risks of a given treatment? So I thought this quote was really important because, you know, the other quote, of course, is the best laid plans, but really these interruptions are the things that make life interesting. And in fact, what we will are the substance of our existence. And this is now echoing part of what Carla was speaking to, and certainly what Nick gave us such an amazing example of you have plans, you're on your way, and then there's a huge barrier put up in front of you, and how do you manage that? And it's can happen either because there was a diagnosis in youth and you're carrying that into adulthood, or because there's a brand new diagnosis like Nick described. And I don't need to speak to all these things. You know what this means. This means that you know, your plans are interrupted because you now have medical appointments you didn't plan before. You now might need support physically, emotionally, financially that you didn't need support. And that's coming at a critical time where people are otherwise seeking to be more independent and have to acknowledge and take advantage of the support that somehow diminishes that independence. So how do we manage that within the healthcare center? I mentioned the need to create your healthcare team and pull all of those people together. This was a very nice paper just summarizing for long-term survivorship what type of healthcare team you might need. And I don't think every single person needs each of these specialties. That would be, you'd be a full-time patient. We should compensate you for never doing anything but go to the doctor. But it is important to have these things on your list to be thinking about. And actually when I'm seeing patients, I have a specific review of systems that says any bone symptoms, any respiratory symptoms, any heart symptoms, any symptoms related to the sinuses that could have been because of late effects of treatment, kidney symptoms, the risk of infection, like Dr. Chang and Nick were talking about with COVID being a real concern. Anytime someone's had radiation, and certainly with some chemotherapies, there's a risk of a second malignancy in that region. It's a tiny risk, but it's our job to watch for that. Optical side effects, dental side effects, particularly with radiation given to certain parts of the skull base. And as Carla mentioned, endocrinology and psychiatry and psychology. I just want to echo everything Carla said about please be your own advocate. Please keep a notebook with your images, with the digital images of your radiation field, with a one-page summary of I had this treatment here to here, there to there. And that notebook sometimes is the bridge between medical systems that otherwise don't speak together. It is really important to be a informed consumer when you're choosing which hospital system you want to be in, and then that will directly influence what healthcare coverage, what third-party payer you have a contract with. Sometimes you're required to be on a Medicaid or a Medicare plan. Those are wonderful plans. It's just important to know what the limitations are within your state, going out of state, and build your team based on those limitations because they flow together. This part of this was already mentioned, but I do want to just mention a few things that the groups that I'm going to show on the next page can be really helpful for. And this image comes from the Ullman Foundation, which is one of the foundations created specifically for adolescents and young adults, either fighting cancer or surviving cancer. And as mentioned, this whole issue of survivorship is one title. There are a lot of things inside of survivorship, including health, but also emotional well-being, psychological well-being. There are huge financial needs. The reason we're mentioning insurance so much is because I wish we lived in a world where we had no consideration of cost, specifically out-of-pocket costs to the patient and their family as they receive the appropriate surveillance. But there are huge costs associated with this. And in fact, it can result in bankruptcy in many patients with cancer. And so we have to be very thoughtful, particularly when we know we're looking at a long-term trajectory. How can we minimize those costs while optimizing care? Another issue is fertility preservation. Sometimes I'm an adult doctor, so I meet people in adulthood. And sometimes the question is assessing fertility in the first place, just seeing where we are with that fertility. Sometimes we're starting chemotherapy and we need to be thinking about egg harvesting or sperm banking. And these are challenging things to think about, particularly if that's not on someone's horizon, that's not on their clock otherwise right now. And so that takes extra time and consideration, both at home with your own care team at home and with the care team within the medical system. And then I'm closing on social isolation because I think this is one of the things that we can really be most proactive about. We can be thoughtful and work through all of these other things, but this social isolation is very common. You know, it's hard to be a 22-year-old where all of your friends are going out every night and you're not going out every night because you're exhausted from dealing with chemotherapy or doctor's appointments or trying to keep up with work, school, and treatment. And how can we address that? And I'm really thrilled about all of these organizations. They are irreverent and fun and well-informed and very impactful. And so I encourage anybody who is a young adult living with brain tumor to look up these organizations. The first is Stupid Cancer, and they have these stupid cancer meetups, and, you know, just the term that it's stupid cancer. Like who wants cancer? Nobody wants cancer. It's in the way. But they have these wonderful programs to support young adults who already get it. They might not get your brain tumor, but they already get it. And then this is taken from the Ullman page. And one of the things they do is Cancer to 5K. So if anybody has seen that app, Couch to 5K, which is a pretty good app, I have to say, this is to give people the confidence and the support and the coaching to get physical and really take pride and ownership of overcoming the many things that they've been through. So with that, I will say thank you. I am delighted to take questions and to continue the discussion. And truly, it's an honor to be here today. Thank you.
Thank you so much, Jayshree, for your compassionate approach to caring for patients and really highlighting the importance of survivorship and resources for our young adult patients. Really appreciate it. So now I'd like to ask Nick and Carla to join Dr. Blakely as we transition into the Q&A portion of the session. Please don't hesitate to enter your question into the chat box. Thank you.
Thank you all so much for your wonderful presentation. As Dr. Chang mentioned, if you have a question that you'd like to ask, please type and submit it using the Q&A button at the bottom of your screen, and we'll answer questions as time allows. So one of the first questions we have here is regarding the care team that's supporting patients and survivors. Dr. Blakely and Carla, you both mentioned the importance of the primary care physician in that team for the patient. Do you have any advice for patients who may be experiencing or having a primary care physician that is more hands-off? What can they or what can other physicians and team members do to help keep the primary care physician more involved and engaged?
I'll take a stab at that. I agree it is a tough problem. And that's why I tell patients, especially when they're transitioning, is to review what primary care healthcare providers are available to you based on your insurance as the jumping off spot. And then go see that person and talk to that person and tell them you need them to have this type of involvement. I actually do a lot of letters for my patients, for them to take to a primary care person saying, this is what this patient needs. This is what we need you to do. Are you willing to do that? I do think it's a challenge. I have some patients who have amazing primary care providers that are so engaged and so helpful and so willing to stay up to date and follow the recommendations. But then I have others that are exactly as the question describes. They don't want to have any involvement. And so I think if that person doesn't want involvement, then you need to look for a different person.
I'll echo a lot of what Carla said, and I'll say, unfortunately, if you are in this position where you have the gift of being a long-term survivor and looking to coordinate this care, because it's wonderful, right? That's what we're aiming for. But it also means you will become an expert in the inefficiencies and foibles of modern medicine. And I'll just point that we have to have compassion on both sides. Many, many primary care providers are asked to see 60 patients in one day. Mm-hmm. Don't go to that practice. That's not their fault, but they're never going to be able to pay attention in the way that you're going to need. So you're going to want to think about practices where they either have a construct in place where it's a full team, nurse practitioner, physician assistant, nurses, social worker, case manager, and physicians all together so that different needs can be met by different members of the care team. Those are pretty rare practices worth looking for. Sometimes, there are these boutique practices where you pay a little extra, something like $1,000 a year to be in a smaller practice I think it's worth it. I think you'll have more attention. Sometimes the academic centers, the physicians or the care team in those centers have a little bit more time because we're less fee-based, and so we're not getting pressured. But there's a business model of medicine that's not good. And you are seeking care in a business model that we don't like either, by the way. And finding a practice, like Carla said, that is more likely to meet your needs is important. I think being in a practice structure that doesn't meet your needs, you know, what did Einstein say? Repeating the same activity and expecting a different results, it's not going to work. You'll have to move to a different practice.
Another thing that I recommend to all patients, and electronic medical records has really opened this opportunity up, is to make sure at your primary center that you enroll in your patient portal and that you pay attention to what's on your patient portal. And in our program, we have now set up that a section on the patient portal where we put their treatment summary, we put all of their recommendations, we put the types of screenings they need, et cetera. So as a patient, in order to be a better advocate for yourself, make sure that your portal has that information, and ask your providers to put information into your portal that's going to help you provide information to your primary care providers.
Thank you both so much for that wonderful insight and advice. Another question, Carla, this one is directed towards you, is asking again about the team that's supporting you. You had mentioned that to help support some of the long-term effects that patients and survivors may experience, there's a variety of professionals that they may have to reach out to. One example being an endocrinologist. Is that a consultation that the patient has to set up themselves? Is that something that an oncologist would address and set up on behalf of the patient?
It's very dependent upon the program that you're associated with. Prior to coming to Survivorship, my focus in the last years was working with kids with neurotumors. And I started doing that in the 1980s, when it first became that kids with brain tumors were sent to oncology. Prior to the 1980s, they typically were taken care of only by the neurosurgeon and the radiation oncologist. And I found that some people were really good about referring patients to endocrinologists and other people weren't. If I have a patient come to Survivorship and they have not seen an endocrinologist, I always do a referral, but it may be that a patient, again, has to be proactive and ask for that referral. I have some patients who do not need to be followed by an endocrinologist, but I still like that initial consultation for the endocrinologist to overlook and see what are the issues for this patient and do they need long-term endocrinology follow-up.
Thank you so much. You know, an issue that many AYAs may experience is going from being an independent young adult to now being a patient where we have to once again be dependent on others for support and help. And Nick, you had mentioned when you were initially diagnosed, you ended up moving back home with your parents and they were helping you. How did you adjust to that change, to being on your own and now living back at home again?
Kind of taking things one day at a time. Meeting people in the middle can be a really difficult thing, or knowing like it's being able to give yourself a break, trying to take care of those around you. It can be sometimes difficult by simultaneously being a patient and then also trying to make sure that other people's needs are getting taken care of, or that when I might have an issue that is the request I'm making reasonable, kind of things like that. It can be really difficult to try and find that right balance, because as much as it's good to be able to center the patient, that support network is what keeps everything afloat. I'm not sure if that quite answered what you were.
No, I think it did. Thank you so much for sharing your insight from your own personal experiences with that. Another question we have here is regarding treatment centers and programs for patients and survivors. As a young adult patient, majority of the time, or a lot of the time, depending on the patient's age, they are either put into a pediatric treatment center where the patients are much younger than them, or an adult treatment center where many patients are much older. Are you noticing, or are we seeing an increase in treatment centers or programs that are specifically dedicated to AYAs to address that isolation that they may experience?
There are many institutions that are really focusing on AYA and AYA programs, but then there are significant limitations as far as the space, the clinics, the inpatient hospitalization. Less people in the United States actually have dedicated, say, inpatient AYA units than Australia, Great Britain tend to be more leaders in having specific AYA centers. But I do think, at least from, again, the pediatric oncology world, we often now do AYA, and there is a huge focus. We have AYA committee as part of our children's oncology group. A lot of the protocols now go up for, they don't stop at age 21, they go up to age 39 for treatment, especially as was Dr. Blakely had discussed, as far as maybe a 30-year-old might have a classic pediatric tumor. And so I think there is a focus. There isn't necessarily separate clinic space, separate inpatient space, but at least it's on the radar for most treatment centers, at least in the pediatric AYA world, that to recognize these differences. And I will be honest, I'm a very big proponent, and I'm biased. I think anyone with a brain tumor needs to be treated at a specific center with a pediatric, with a brain tumor team, where you have all of the specialists and you have that team. And I don't really feel that patients should be treated in community centers when they have a brain tumor. And I think the evidence shows that quality of life and survival are increased when patients are treated at a specific brain tumor center. And I would ask Doctors Chang and Blakely if they agree with that.
1,000,000%.
Good.
But to be clear, there's a burden to that. There might be travel involved.
Yes.
I'll just speak to I think, one of the benefits, a silver lining that we saw with COVID and the emergency regulations, is that telemedicine across state lines was more feasible. And it's a wonderful way to be able to see people without them having to fly or drive long distances, and make sure we're managing whatever symptoms, pain, GI symptoms, toxicity from medication. So you definitely need an expert center. It sometimes, definitely, I don't think there's a way around it, sometimes comes at a cost. And so building contingency plans, like finding that good primary care that will interact with the specialty center to minimize the burden of that travel, or reach out to your state legislators and make them open up the boundaries for licensure so we can practice across state lines.
Yes.
I think your point is a really good one. I think too, we have to think of it as partnership, as you said, Jayshree and Carla. It's what are we able to provide, knowing the complexities of the patient population that we deal with, right? They're cancer patients, but they also have all of these other cognitive, emotional changes, and the treatments, the classification of tumors are changing every year, as Jayshree pointed out. I mean, what we call glioblastoma a year ago is not what we're calling glioblastoma now. I mean, it even for us, it's very challenging. And I can imagine how difficult it is for community oncologists who only see, 5 or 10 patients a year, how hard it must be for them to be able to really understand the complexities and the nuances of the types of care that we provide. I think Nick pointed out as well the importance of clinical trials. We know that the only way we're going to make a difference with this disease is to look at new treatments. It's what about the discoveries? What about the basic science? And so partnering with our community oncologists to let them know about the resources that we as a center provide, but also how if we keep the patient at the center of every decision we make, how that allows them to have not only the resources, but also the access to clinical trials, which is so important as well. So I think that really is also the other major point about the centers of excellence and the centers that have a brain tumor emphasis. So. Nick, I don't know if you want to speak to that as well.
Yeah, I agree with everything that Dr. Chang and Blakely and Carla Wilson were all saying about. I think there has been an increase from my first to second treatment for the folks that I've known within my age range, or it's, you know, I think part of that's me getting a little bit older on that, but being able to have the focus, yeah, on both like the specific types of tumors people are dealing with, having specialists as opposed to generalists can make a huge difference, even though that's not always an available resource for people. I was very fortunate with one of the best places in the country being in my backyard. Very fortunate to have care on that. I think, yeah, I 100% agree that sometimes trying to have that partnership between primary care doctors and the specialists, or knowing kind of what's the right questions to be able to ask people that aren't either way too broad or way too narrow, because yeah, the high demands on a lot of primary care doctors.
Thank you all so much for your insight and for answering that question so thoroughly. I think we have time for one more question, and this one is about mental health. As we know, in survivorship, we're not just focused on the long-term physical effects that the tumor and the diagnosis may have had on us, but also on the impact it has on our mental health. Can each of you maybe just spend a minute or so sharing how you would address mental health in the survivorship care plan as physicians? When are you linking in therapists or support for that aspect? And Nick, I would love to hear your experience with how you've coped yourself with mental health as a survivor.
Yep. Where I've received care, it's been very positive. They've been open with asking questions and trying to connect people to the kind of group resources that they have with organizations like the Gray Matters Foundation, and just wanting to, if I ever have questions with the like oncologist or that's the primary specialist I see, it's being able to have open conversations about that. After surgeries both times, there were recommendations or to be able to have like neurotherapy or other, being able to see if everything's right. It can really depend on different organizations on that, but it's something that's addressed and needs to be, even when it is asked by specialists, it also needs to be brought up by the patient standpoint to make sure that there's an open conversation, or if people are having issues, that it is addressed within the clinics.
In our survivorship visit, we do a consult or have the psychologist do an initial assessment. And then if the patient needs ongoing care, then they're referred to an outside person for follow-up care. The other thing that we do, and we're very fortunate in our program, it's a grant-funded program, so there's no billing to the patient or their insurance. And so I refer just about everybody for neuropsychology evaluation, because that can bring up a lot of issues. What's your learning abilities? What are your strengths and weaknesses? But it also has an assessment of what's your general mental health status. Once there's a problem identified, then the referral for the care has to be through the patient's insurance, but at least we have the ability to do those initial assessments. And I know in general, most insurances don't pay very well, if at all, for neuropsych evaluations. So we're very fortunate that we can refer our patients for that assessment. Once there's if there's a problem identified, it's a little easier then to get the treatment that they need for that problem when we have that documentation.
Thank you so much. Unfortunately, that is all the time that we have for questions for this session. Thank you again for taking the time to share your insight, expertise, and advice with our audience. I will now turn it back to Emily, and we'll move forward with the rest of our program.
Thank you.
Yes, thank you so much, Dr. Chang, Dr. Blakely, Nick, and Carla, for this really wonderful, interactive, and informative session. I truly appreciate your time and commitment to the brain tumor community. Our next session will address what is often considered the elephant in the room, palliative care. Palliative care is not end-of-life care. Instead, it offers relief from symptoms and stress of a life-threatening diagnosis and should be integrated early on. The goal of palliative care is to improve quality of life for both the patient and the family and is appropriate at any stage of the brain tumor journey. Our speaker, Dr. Tobias Walbert, is an associate professor of neurology at Wayne State University and co-director of the Hermelin Brain Tumor Center at the Henry Ford Cancer Institute in Detroit, Michigan. Dr. Walbert's research focuses on finding new treatments to end brain tumors, but especially on quality of life, palliative care, and symptom management in brain tumors and neurological diseases. Please welcome Dr. Walbert.
Thank you. All right. Well, it's a pleasure to be here. I would want to thank you, like the ABTA, Dr. Chang, for inviting me, because it's a big honor, because of all the great work you do, and because I really am passionate about what I do and about talking about the other part while we are finding a cure. So, all right. So, yeah, here, these are my disclosures. Nothing really is relevant to this talk, just some work I do helping some companies. And yep, here we go. So, so we have a clean slate here. And before really diving into it, I want to really take this as an opportunity and just to give it a thought. It's like, what does quality of life look like? And then I'm just going to show you some pictures here, and some might relate more than others. And when we look at this, yeah, there we go. So yeah, just look at these pictures. Some of them, and I hope all of them, reflect some kind of what quality of life might look for you, might have looked for you, and the different phases too, where people are in their lives, in their journey. And like this next one, that's one of my favorite restaurants. And the next one, that's one of my favorite addictions. And this one is just being there. So what I want to get you to is to really ask yourself, what's your quality of life about? Because quality of life changes. It changes every day, and it changes while we evolve in life. While like ice cream was maybe the most fantastic thing for this little girl, like the coffee probably was back then not. And while we might be thrill-seeking in our 20s and early in life, then later maybe family or just being is more important. So when we think about that in brain tumors, we have to come to think about it that it's not just one thing that defines us, and it's not one thing that defines our quality of life. So the most obvious might be the physical function or social function, cognitive function, and emotional function. But then there is spiritual well-being, which goes way, way deeper than that. And when you put this all together, you have like two big areas. You have health-related quality of life and symptom severity. And if we can work on these, that can define and redefine and alter our quality of life. So in that regard, it's important to keep certain things in life because in mind, because it's like, for example, there's the physician's perspective. What clinicians are often concerned about is the physical manifestations of the disease. They look at your MRI, they measure the tumor, we look at overall survival when we evaluate new therapies, and we look at progression-free survival. These are our measures, but that might not be what the patients, you as a patient, are concerned about. Of course, you're concerned about survival, but there's much, much more. There's like vitality, role limitations, what am I able to do, what can I not do anymore, the emotional problems that come out of that. All that leads to the questions about mental health, about maintaining hope. Where does this all go? Because things all of a sudden they did change. And the bottom line is that overall survival and progression-free survival, while they're certainly important, they do not fully reflect what I would describe as the clinical benefit. So the big question is like, when we look at this, it's like, and this is like really is getting back to the last session too, is like, how do we modify, how do we approach this quality of life, how do we approach brain tumors? It's really a whole team that's involved, and that's coming down like what we just heard from the prior speakers, from Dr. Blakely, Carlo, is like really there's a whole team involved. There's radiation oncology, neurosurgery, there's neuro-oncology, and there's medical oncology in some places. But then there's way more. There's nursing care, physical therapy, rehab, social work, behavioral health, and then there is palliative care. And that is one part I would like to talk about because it's often not fully appreciated. So this is where palliative care comes in. And this is what I tell my patients. We cannot change the direction of the wind. We cannot change what is given to us, but we can always adjust our sails, and we can make an effort to respond in a way. And in that regard, I like this. One of my mentors, a very accomplished palliative care physician, they prepared this little cartoon, and they said there's different ways, like a tumor, our lives, it's a journey. And one approach are the unprepared, and I freely admit that that was me, or still is me at times. It's like fully enthusiastic, it's like hopeful, and I don't want to hear it, but my wife is probably right, unrealistic at times. Let's go for this. And ignoring that for sure, there might be extreme heat, a bumpy road, and accidents. And yeah, maybe let's get, it's not the best way to go with the old car and being unprepared, because it's much better to go on this ride, the prepared journey. To think about it is like, let's take the car with the comfort features. Is the air conditioning working? Do we have the AAA? Maybe a blanket in the back, or just some cool drinks. Because yes, realistically, if we're going to drive down to Texas, it's going to be hot at some point. And in the same way, you are on a journey, and a lot of it is about preparing for the things that might or might not come, or what we say a lot in palliative care, hope for the best, but be prepared for the things that might happen on the way. So what is palliative care? What is that magic or supportive care in some places is what it's called. And when you look at it, of course, like the WHO, the World Health Organization, they have all these fancy definitions. But what really sticks out for me, and what I hope for my patient, is like, it's an approach that improves the quality of life. And for not just for cancer patients, for families, for patients and their families. So this is not just about patients facing problems associated with life-threatening illness. And the big part is on prevention and relief of suffering and identification. So that is really one big piece, and to focus not just on the brain tumor, but treatment of pain, which fortunately is like not as big of a part in our brain tumor patients as it is in other cancers. but other problems too, psychosocial and spiritual. So you see, we're all coming back to this little cartoon that there are all these different dimensions. And that's what palliative care hopes and is intended to address. A lot of times it's still in people's idea that palliative care is hospice, and it's not. And I will explain shortly the difference, because they are very much in one boat, and physicians who are licensed in palliative care are licensed in hospice as well. Yeah. So hospice is, I describe hospice as palliative care at the end of life. And in the US, and this is truly like a US definition by Medicare, is like hospice is for patients with a life expectancy less than 6 months. It's very important to understand that neither hospice nor palliative care shorten life. Palliative care, hospice, and especially hospice, is not about giving up. It's not about doing nothing. It is about focusing what's most important. It's about focusing on the patient and quality of life. And how do they do that? That can happen, hospice can happen at home, at nursing homes, and long-term care facilities, hospice inpatient units, and the hospital. But really, mostly these days, it's at home or at nursing facilities because, and again, we follow the money. It's very difficult to get reimbursement for these inpatient hospice units, which can be very helpful. Where did this all start? This is nothing new. So I thought it was very fascinating when you look at this archaeological picture here. So this is one of the first hospices. So this was like, it can be found in Old Jerusalem. And it goes back about over 1,000 years, or about 1,000 years, when the Crusaders came to Palestine, now Israel, Jerusalem. And a lot of times they didn't make it back because it was a hazardous journey. And so these first hospices were developed there. It's like in Old Jerusalem in Malta, where for these Crusaders who couldn't make it back. And palliative care really evolved from this hospice movement. And that's where we are today. What hospice can do for you. And again, it's important because there's some overlap. Hospice does not provide, unfortunately, does not provide like a full care, cannot provide caregivers. So a lot of the caring burden is still on the families, informal or formal helpers. But what hospice can provide is like that there's someone there 24 hours a day, somebody you can call, the families can call in when the rubber hits the road. Because let's face it, the crisis does not happen on Tuesday morning. The crisis happens at Friday night, at Saturday, and when you call, and the first thing you're going to hear is, if this is a life-threatening emergency, call 911 or hang up. But this is not what we want for our patients. So this is, in that regard, hospice is important because it really can be a segue to keep patients at home, even at times of crisis. And hospice has a social work, a counseling component. It can have physical therapy, occupational therapy, nutrition. So you see, this is not about giving up. It's really focusing on the person, the patient. Sometimes it can allow for respite care, for admitting patients for some days to give somebody a break. And hospice, as well as palliative care, they can help with advanced care planning, and they can help with bereavement, which a lot of families struggle. And palliative care does many of the same things, because as I said, hospice is like palliative care in the end of life phase. But it really is focused on these symptoms, which can be pain, shortness of breath, fatigue, nausea, other distressing symptoms, and the psychosocial suffering, and the discussion of goals of care and what decision to make. And palliative care can happen as inpatient, because a lot of time crises trigger palliative care involvement, but more and more it is available in the outpatient setting too, so that patient can see palliative care specialists. And it happens parallel to the standard of care. So you can have chemotherapy and palliative care. You don't have to choose anymore. So this is how I imagine palliative care. When you look at this, palliative care is like the umbrella you take into the storm, and it really protects your quality of life, your symptom severity, hope, and health-related quality of life. That's what palliative care is all about. How did we get here? So there are different models. And as I said, a lot is coming from other cancers. And this is how it used to be. That's like, it was like, you'll see that orange box here. That's what we call the aggressive care. And then all of a sudden they said, oh, can't do this anymore. And there is nothing we can do for you anymore. And then palliative care or hospice. And when I talk to my patients, I warn them in a certain way, because it's like in our medicine, with the options we have today, it's like there's still a lot of times it's this expectation that one day the doctor tells you, says, we do not have anything what we can offer you. But in reality, most of the time, there might be always another drug, another thing we can do. But it's really important to reflect on that, because it's important to put that into the bigger context. Is that what we want to do? Is that really where you want to be? Because I tell my patients too, we just built a new cancer center and it's fabulous. It is so nice, but it never will replace a day at home with family, or when instead of spending a day at Henry Ford. Out of these ideas and this big sense of abandonment, when basically people graduated from their oncologist who they knew for a long time, all of a sudden into hospice, new models evolved. And what is called the integrated approach to palliative care. And basically, while we go that journey of life prolonging care, palliative care is along and gets more and more important. And that gives the opportunity to really have better symptom management, increased quality of life, build a new meaningful relationship for the palliative care team to work with patients, and go from there. So palliative care is like similar to hospice. Remember, hospice as being basically palliative care at the end of life. It's a team approach. It integrates the psychosocial, spiritual aspects of patient care, behavioral health, a support system, and it uses an interdisciplinary team. Neither intends to hasten or postpone death, and it can be done while receiving full care otherwise. When, as physicians, it's like always important to look, is like, do things really work? And the same is with palliative care. And this is like, I just want to highlight that is a little bit, because this was like, so the New England Journal of Medicine, that's like the biggest thing where you can get your get your article published, and that makes the big splash in the world. And this was about 10 years ago. So this was a trial, unfortunately not for brain tumors, but it was for patients with metastatic lung cancer. And early palliative care is maybe it's a little bit of misnomer, because these patients, if it's metastatic, they don't have a long time to live. But basically what they did for this study, they had about 150 patients with where the cancer had traveled to other places from the lung, and they got this early palliative care. So basically parallel to their visits, one group got a visit with the palliative care team in regular steps, and the other group just was like the regular. They said, okay, if you want to, we can send you to palliative care, but we're not going to schedule it for you right now. And so these patients, what happens is, and I'm going to give you a little bit insight here, this is how we look at this. These patients did better, yeah. And I show you here, there's something called the HADS. So that's a little scale that looks at depression and anxiety, and that PHQ-9 looks at depression too. You might have answered that already, like in your intake forms, like it was like on our intake form for a long time. It says, it asks like questions, do you have less interest in doing fun stuff? Is your appetite decreased? Is your sleep worse? And so what they found is that patients that had that early palliative care, which is this, I don't know, salmon pink colored bar, they had less depression. D stands for depression here than the standard of care. They had a little bit less anxiety. So, and here on this other measure as well. And one thing they actually hadn't looked for, these patients lived longer. So this is another outcome they looked at. And again, what you see here is there's the standard of care, and here is the early palliative care, and here the mean change in that function score. This time it's better to be high up here. They did better. So based on that, actually the American Society of Clinical Oncology recommended that palliative care should be an early part for patients with a cancer diagnosis and that have a limited expected survival. So the big question, however, is, and we know that as practitioners, is like, how are brain tumor patients different? And that's really how we started out, like with my group, like already probably now 10 years ago. We looked at that. It's like, and we looked at what's in the literature, what do people describe, and what we found is like here you have fatigue, weight loss, appetite loss, and this is the stuff that the cancer doctors, the medical oncologists, the general oncologists really looked like. We're looking for, but we couldn't find really any data for glioma patients. And then you have drowsiness, communication, speech, focal deficits, weakness. This is the stuff the brain tumor doctors looked at, and we couldn't find any data in the general cancer population. And based on that, we did a study where we looked prospectively. So these were patients and caregivers or families at our institution. And when their chemotherapy didn't work anymore, or like the second line therapy didn't work anymore, and they were not, and their function was getting worse, we asked them to participate. The patient and the caregiver, and we had like 52 patients and their caregivers, and we called them every 2 weeks or when they were coming in and asked them how they were doing and what symptoms they had. So here we go, we talked about that. So what we found is like that the really symptoms got really worse and in week 12, 14, so the last 3 months prior to death. We saw more fatigue, we saw more drowsiness, we saw more decrease in concentration, and patients have had a really high symptom burden. And patients couldn't make decisions anymore. They couldn't participate because of everything that was going on. And so we looked at all these symptoms, and here you see the 7 highest ranking symptoms. When you look there, there's weakness, concentration, concentrating, drowsiness, fatigue, speaking, remembering, and understanding. And what you see here is like, I want to highlight these 6 ones. And what 6 out of these 7 have in common is that they all involve patients' ability to control their life, to control their decisions, to make a choice. And the big challenges at the end of life that we found were like these seizures, but actually not as high than what we've seen before. But when patients had seizures, that was challenging communication, and that things very fast declined. And patients were not able in the last 2 weeks, most of them at least, were not able to really help making decisions. And one of the big questions that came out of that, when is the right time to address these issues? And in which way? So this is like one of the cartoons that I use a lot of times, like talking to my colleagues, trying to sensitize them to talk to their patients about, yeah, what do we want? I always say, it's like, look, think about how much time do we spend preparing coming into life. It's like there are like a nursery set up. There's a baby shower. There's all these things going on. But if there's one thing for sure, is that at one point we come into this life, and at one point we will go out of this life. And the question is like, while society has a hard time embracing that, and there's like some really good new approaches to that, but it's still, the focus is mainly on coming into life, and maybe not enough on how to get out of this life. So let's talk about the elephant in the room. And in physician language, this is what we call advanced care planning. And we put a lot more focus on that because of the symptoms. And what I tell patients, or what I tell my trainees, is that advanced care planning is a process. And it's a process where you want to look at, you want to share your illness, your understanding of it, and then it's very personal. It's about personal values, life goals, and preferences regarding the future of your medical care. And the goal of advanced care planning is really to ensure that people, that patients, that we as living beings, we receive the medical care that is consistent with our values, in our goals and preferences during serious and chronic illness. And the important part is why I really stress this with my patients as well, is there is a default. Like if we do not set something up, there's a default what happens. And so what does a lot of time happen, and which really pains me for my patients, for their families, is when you get this phone call and you try to reach your clinic, your doctor, and you get that, if this is an emergency, then yes, they hang up, they call 911, and then the machine starts, and all of a sudden patients who didn't want to be in the hospital, who didn't want to be on a breathing machine, they end up exactly there because that's what the system is built to do. And the interesting part about this advanced care planning is it's like there's a lot of talk about patient-centered care, about patients. And patient-centered care is advanced care planning. When you read through here, it's about respect for patients' values, preferences. It's about coordination and integration of care. It's about information communication, education about physical comfort, emotional support, and involvement of family and friends. So this is advanced care planning. This is palliative care. So here we come. So palliative care, advanced care planning, it's about hoping for the best and planning for tomorrow. And it's a process. So a lot of times I say it's like, yes, it's fantastic. A lot of us, like even when we're young, when people get married, they have a child, and then you go through this almost like a rite of passage. You meet with an attorney, and then yes, you set up this basically and like advanced care plan in the broadest sense, but you hope that it never comes to that. But it's a conversation, because the decisions might be very different for a patient in the 40s or 30s who are young parents, and might be very different than for somebody with more advanced age and more different experiences. So it's important to talk about that and to keep that conversation going, that it is a process. It's about challenges. So what do I mean by that? Or what are the challenges to it? Serious ill patients rarely communicate end-of-life preferences to their physicians. And there were different studies were done. So for patients, clearly, they do expect the physicians, and I do expect from a physician to talk about this and what are the plans, or to encourage families to talk about who's in charge, who's making these decisions. And patients fill out advanced directives and consider end-of-life care options, but a lot of times that is not communicated to the physician, even if they exist. So it's all about being in control. It's like the last session. Have your discs, have your medical records, and advanced care planning is a practical step to be in control, even if you can't articulate it anymore. It's about making decisions about healthcare you won't want to receive, and if you're unable to speak for yourself. It's about recognizing that patients with brain tumors can lose their ability to make plans and decisions early on. And specifically, like with my patients, if for most people, you might know, it's like the speech center is, for most patients, is on the left side of the brain. And it can be one of the most devastating parts when patients have a hard time communicating. And if that is at risk, it's even more important to have a conversation and have this conversation early. So this is very interesting, I thought. It's about like a non-for-profit that works on decision making. And they said here, consider the facts. 80% of people say that if serious ill, they would want to talk to their doctor about end-of-life care. But the reality is that only 7% really had this conversation. And the next one is like 82% of people put their wishes into writing, or they want to do it. That's their intent. But we know life is busy and things come in between, and it might not be the most comfortable thing to do. That's why only 23% have done it. But I want to show you that it is actually not that hard. And these are triggers really for advanced care planning. And I encourage you as patients, as families, even if the thought is like, this is something we don't want to plan for, or that might make us uncomfortable. These are like triggers where we say, it's like, all right, maybe it's time now. Make sure the plans are all, we had the conversation or have it again. What do we want? It sometimes patients request it or the family requests it. And I think it is very courageous. And because I do believe that it should come from the physician, but as empowered patients and participant, it's your life. It's about your choices and about speaking up. And it's about this, dysphagia can be an issue, because dysphagia is when you have a hard time swallowing, coughing, getting things into the wrong pipe. Pneumonia. It's about not having issues processing ideas and thoughts. It's like when there are more and more infections, more and more hospital visits, all the things we want to try to avoid. So all these can be triggers to really get things into gear. And hopefully you're not going to end up meeting this cheery guy here who says, first, the good news, we all got to go sometime. But so what does it really take in steps? So people really focus on that. They looked at it. It's a structured discussion. So really to think about is like in different, what do I want if I can't breathe? What do I want when my heart stops? What do I want if I can't drink anymore? And it's important because it's different. It's like, it's called exploration of goals of care. Because you don't want to have a family. I think that like in my training, there's like these situations when the heart all of a sudden stops. And it's one of the hardest things under pressure to decide what for a family, what their loved one really wanted. And so in an ideal state, you have this conversation, you write it down and you have it in your chart. But I actually tell you, it's like the more important part for me is actually to have that conversation. So, and when we look at that, like different studies, they have actually looked at it and showed that when people had advanced care planning, there was a better patient and family satisfaction with end-of-life care because it was just what they wanted. There was an improved understanding and compliance between the physician and the family members and the patient's wishes in the end-of-life care, because families knew what their loved ones wanted and the physician knew it. And there was an increased likelihood of patients dying at their preferred place, wherever that might be, because it takes a plan to put that into place. There was more increased hospice care and there was reduced hospitals. Because again, especially now in the times of COVID, where there might be restrictions of who can be with the patient in the hospital, a hospital is not a good place if you can avoid it. If you really need to, yes, we will take care of you, but it's a dangerous place. And people who had the conversations and recorded it, they had lower stress levels, they had less anxiety and depression in their surviving relatives. So how does it work? There are paper forms, there are wonderful electronic resources, and you have a conversation with health professionals, with your loved ones, whoever can help you. And you document it, you put the healthcare power of attorney in place. There's a certain legal form for that. And yeah, it can include a last will and a testament, but that's not the important part. So what's driving these documents or these conversations? And there are certain online tutorials. 5 Wishes is one of them, or the conversation project, I have a slide on that, is like, what types of treatment do you want or do you not want? Who do you choose to speak for you? That's really important, because a lot of times, naturally, if somebody's married or has been together with someone for a long time, it can be that partner. But sometimes patients decide that somebody else is a better person, a good friend, somebody with a healthcare background, somebody who's a little bit out of the inner circle, because let's face it, it's never easy. Yeah. But it prevents issues. The worst is like if there's no one assigned and nobody found that can make decisions, or what it prevents that these wishes are not followed. So how can you do that? And again, you can talk to your social worker in the hospital. You talk to your physician. You ask them for the booklet. I'm not as fond of our booklets, so I send, and I think there are some amazing resources, as like in the conversation project, where you can watch videos about certain situations that give you a better idea, because it's like, the other reality is, this is not emergency room. This is not where people undergo, life is not like where people undergo where the heart stops and the next morning they wake up again and flirt with the nurse. This is not how it works. So these stories, like these resources, help you to guide you through the process and to make the right decisions. And in some states, there's certain forms that can be filled out that basically is like you keep at home. So if like the emergency crew comes in, you can tell them this is what we want or this is what we don't want. And in addition to that, there are some really good books, or if you're the book kind of type, or listening to it, or this was like got an Oscar several years ago as a Netflix documentary. Atul Gawande is a fantastic writer, and he has written for the New Yorker, and here he writes in Being Mortal, he writes about his family story, and you can get an idea how difficult it can be, even for the most educated, to make the right choices. And here, this is called The Conversation by Angelo, who does an amazing job. So all of these are good resources, and go out there, read and talk to your doctor, talk to your social worker, talk to your team, because the evidence shows that people do better with palliative care and eventually advanced care planning, and that people have better symptom, can achieve better symptom care. A lot of it can be done by the physician themselves, but sometimes it just needs a little bit more sometimes out there. And with that, I think I'm at the end here. And I think, Emily, do we have some questions? And
yes, we have some questions. Brain Man is going to come on right now to share some of the questions we have from our audience.
Thank you so much for your wonderful presentation. As Emily shared, we do have time for questions. If you have a question that you'd like to ask, please type and submit it using the Q&A button on the bottom of your screen, and we'll answer questions as time allows. All right, so one of the first questions we have here is asking, how do patients know when it is appropriate for them to receive palliative care? Is this something that they themselves would be requesting? Is it recommended by their physician?
It depends, and again, it comes down to the team approach, like we work very hard, and I know Dr. Chang, like at UCSF, they have been on the forefront of that. It's like in an ideal good setting is you have social workers, or like we have a cancer distress screening, and where you pick up on these issues, and ideally it is the physician team, the clinician team that introduces palliative care early on when they feel it's a good time, or if there is a need for it. Because it's like a lot of the palliative care, especially in neuro-oncology, a lot of the issues we are trained to work with, like headaches, that's like a bread and butter for neurologists. So a lot of times I truly believe we're in a better position to treat that than the palliative care doctors. But then there are other things. It's like where patients could benefit from a referral. But at the end of the day, it's like when patients feel it's like, you know what, we're not getting anywhere, this is still not good. It's like patients always can ask, you know, Dr. Walbert, would it be good to have if I would see a palliative care specialist? And then we can talk about it, because like sometimes it's just like a psycho-oncology visit is with a behavioral specialist is more indicated, or to have the complete assessment. Yeah. And so the other part was if hospice is palliative care at the end of life, what constitutes palliative care prior to hospice need? So it's symptom management and supportive care. So a number of cancer centers or hospital systems, they have changed the name to supportive care, because really what they do is they support the primary team with some of the things they might not have the time or the training to do as well.
Thank you so much. Dr. Chang, did you want to add something to that?
Yeah, I think one of the difficulties with discussing this is it is hard. It is a hard narrative, right? We're talking about an illness that is very serious. And what we're trying to do with this session is really try to balance what we want to be able to provide to you in terms of resources to help address the symptoms that you experience throughout the course of your illness. So for example, I think some of the concrete things would be, for example, if you're having a really difficult time with nausea, the neuro-oncologists are really expert at giving you medications to help with nausea, but there's some times where it can be very refractory and very difficult to control. And this is where we can engage with our palliative care colleagues, because they have so much experience with that. I think the symptoms that a survivor with a brain tumor, so if we think about the phase of after treatment and you're in the phase of surveillance, there are still things that you struggle with that we can help with. For example, this ongoing fatigue. You heard very eloquently from Nick this morning how that level of fatigue can persist. And so we can focus on what are some strategies to help you with that symptom. And that's what palliative care is all about, is just dealing with those kinds of things. So even though I know, Dr. Walbert did a great job with focusing on end-of-life care and advanced care planning in terms of the trajectory of what we do, I think, we wanted to make sure you understood that the term palliative refers to the whole journey and not just at the end. And so psycho-oncology as a way to help with emotional, which a lot of patients, have symptoms related to changes in personality or changes in behavior. Those are things that we can also engage our palliative care team with. In addition, you'll hear, we have a special session on neurocognitive, because that is such a big part of what our patients can experience and the impact of that on themselves, but also their families. And so it's really about focusing on quality of life, thriving, living your best life, even though you have a brain tumor. That's really what this session is really about. And also to give you tips about how to plan. So I think, as I said, it's a difficult discussion, but I think it's an important one to really convey to you how we want to help you along the entire journey and not just wait till the end to try to help with symptoms. So that's really the focus here.
I think it's like, you're so right. It's about empowerment. It's like about looking at, it's like life is not about survival. And this doesn't change with being diagnosed with a brain tumor. And it's about living life at the fullest. And this is what really, like, if there are stubborn symptoms when there is, and most people, they know if something is not going right there. It's like giving them extra help. That's what palliative care is about. And that can happen. There are some places where it's like introduced like right in the beginning, patients have a visit, or after radiation, or depending. But you can always ask, and it's about knowing your options. Yeah. So even if I focused more on the advanced care planning, I think that is really important. It starts. All my patients are survivors from the day of diagnosis, and it's about survivorship. It's about making the best of what we have. So that doesn't change with the brain tumor diagnosis, but there are certain issues, and there are specialists out there who can help with that.
Thank you so much. And Dr. Walbert, I think you framed it so perfectly. It's not just about surviving, it's about living and how we're living. And that's how palliative care can really impact the quality of life and how patients and survivors are living beyond the diagnosis and beyond the treatments and side effects they might be experiencing. So another question we have here is about the cost of palliative care. Is palliative care something that's covered by insurance? Is it an out-of-pocket cost? And if it is there financial assistance or resources available for that?
It is part, it's a specialty like any other, and it's a referral like any other. Hospice is a little bit different, but a lot of the insurance companies have recognized that too, that they even like integrated more earlier. So yes, that is covered. It's just like a specialty like any other, and where you're set up with that. Yeah.
So I wanted to, Ambreen, address a question in the chat, if that's okay. There's a question about from Patty saying that she realizes that there's been a discussion on palliative care, but she did also want a question about hospice and how can we get sort of the individual care for the hospice team to be able to tailor the treatments. So this is something that I think is really important question and topic, because most of our patients with brain tumors have different types of challenges in that period of hospice. And recognizing that our team at UCSF has actually put together a palliative care or hospice booklet for providers that highlights the changes that our patients experience, whether it is related to the medications like steroids or seizures or other changes. And so this is something where we're happy to post that and provide as a resource. But it's really about education as well. And that's on the neuro-oncologist to liaison with the hospice team. So don't hesitate to reach out to your neuro-oncology team who took care of you to say, these are things that we're having challenges with, and that way we can help to coordinate with the hospice team. Yeah. So I just wanted to address that particular question that was raised in the question and answer. Thank you.
It's a very good point, and I'm very clear that there's one thing I feel very strongly about when I first meet patients. I tell them this is a journey, and if there's one thing I promise you, I'm going to be there with you and with your family. And that does not, I don't care if like hospice steps in and I'm there, because like I'm still the specialist and I'm glad to help. And that goes actually to another question that was mentioned in the chat. It was about the quality of hospice. And unfortunately, I have to say, hospice is like everything else in medicine or care, car repair, or whatever you want to. There's some they are brilliant, and there's some they're good, and then others are maybe not as good. And I offer, like, I trust our hospice team, but then I always ask people to, is like said, it's like, well, if you know someone in your family, if you had hospice before, someone else in your family or in your community, in your church, yeah, like, it travels by word of mouth, because it's like, if you have a good experience there in your community, then we're more than glad to refer you to a specific provider. Yeah, so that's unfortunately, yeah, that's part of it. And sometimes, like, hospices, they use order sets too, where it says like, and I counsel patients on, and their families on that too, where it says like, a lot of times, like, hospices, like, oh, they all want to give morphine, and because, like, if somebody is calm, and I say, it's like, well, talk to them about it. What's important. End of life care is about choices like everything else. Yeah.
Thank you both so much for your insight on that question. Another question we have is asking just about interventions that is provided during palliative care. Can you give an example of what type of support palliative care provides to improve quality of life for survivors?
Yeah, it can be, it's like what, like during therapy, palliative care is just like what we talked about, nausea management. It's like we're all good at it, but these are the real true specialists. Some people are just like so much more sensitive to their nausea centers in the brain, and where it needs a specialist. It's the same like with seizures. Like, for example, I'm very comfortable treating seizures, but sometimes if it's getting too complicated, we send them to special epilepsy neurologists, one of my colleagues, to help with that. And it's the same with that. It's the same with fatigue, where they're trained in that, and they can have extra resources, and it might be other things like referral to integrative medicine, like acupuncture, special interventions. So these are the special interventions, and again, it's more about, like, palliative. It's about a comprehensive approach. It's about the measuring, bringing psychosocial help in as needed, and to bundle that. Like a lot of that can be done by a good comprehensive brain tumor center, but it's a matter of resources and what the focus is. Yeah.
So I wanted to, I know we don't have much time, but I do want to address a couple of other comments in the Q&A, and I think it's from a provider, and it really highlights the importance of education. So I think some of the questions that were brought up is, how do we engage as providers in the conversation of advanced care planning or about palliative care? And I think this is where, frankly, I feel the Society of Neuro-Oncology is really important to share with our providers how this has to be a priority in terms of symptom management for our patients. And talking about goals of care is just part of what we should be doing as physicians and providers. And so I appreciate that question very much. And I think that hopefully with time and with more educational opportunities, for example, at an annual meeting, that these types of issues can be brought to the forefront. So I appreciate your question on that.
Yeah, no, that's very important. And there's more education now for younger physicians, and to bring it to like we're working on with some research to look what is the best time, like, to make this like a hard stop at a certain point where we say, okay, this is the right time just to talk about it, because it should come from the physician, and society is changing. And I encourage my colleagues as well, because it's like what we find out is, it's like, you know what, When you bring up this question, most patients, they're not surprised. There's a lot of times there's a sense of relief afterwards that we talked about it, we plan about it, that you hear them. Yeah. So society is changing, and you see that with these books and more popular documentaries and as well within our physician community.
Thank you both for addressing these important questions and topics. Unfortunately, that is all the time that we have for questions for this session. Thank you again, and I'll turn it back to Emily.
Thank you so much.
Thank you so much, Dr. Welber, for addressing such a sensitive topic and sharing so eloquently about how we could utilize palliative care and introduce it at any stage and at any age. We really appreciate your time today. For those of you who need a break, please take this opportunity to stand up, stretch your legs, use the restroom, or grab a snack or beverage at this time. We invite the rest of you to stay on to hear from our sponsors, who will share about the resources they offer to patients. We will resume the program at 1 p.m. Central Time. Thank you so much.
I had my daughter, and now she's 19 months, and she's a little human that we created. So we pretty much watching her grow up.
Can you say hi to the phone?
Hi.
Here we are at our turnaround point, and you see I'm totally alone. Aha! We found him. He's a shade seeker.
Sonny and Dottie and Laura graduated from medical school.
We didn't know that we would have the opportunity to sit there in the audience and hold hands. Well, they recited the Hippocratic Oath. So that was pretty special.
I've got a daughter and I've got some grandkids and a husband, and every time we get to celebrate one of their birthdays, it's just one more time that I'm here for it. And I'm so thankful for that.
Happy birthday, dear Pierre. I gave Pierre a really special 60th birthday party last year, which also happened to fall on the day of his diagnosis anniversary 1 year. There were 55 people there, and they came from all over. Friends came from Texas, from Chicago, from Oregon, from Washington, and it was really special for him because it was all his friends really celebrating his life.
My wife and I were able to go to Ireland this year, and we spent 8 days there, and it was a great time.
This thing called a 5-peak challenge. You basically do the 5 highest peaks in San Diego in one day. I'd been training for that before, and I kind of took a break because obviously I had surgery. And I built myself back up. I accomplished the 5-peak challenge, which was a big feat for me.
Pierre is a major football fan, being from Texas. So I bought tickets to a Chiefs game at Arrowhead Stadium in Kansas City and flew us out there for a game. During the halftime, the cheerleaders came and found us and gave him a signed ball by Chris Jones. So that was really amazing.
I'm an avid guitar player, so I got back into doing that, and I played a couple live gigs and just doing that with the Optune on. So I wasn't going to let cancer or the thought of cancer and the diagnosis kind of take away from living my life.
Each year on my craniversary, I send a note to my surgeon and to my doctor and just, tell them how appreciative I am that I'm still here to be able to send that note.
Pharmaceuticals was founded in 1998 and is headquartered in Beijing with more than 3,000 employees. Our vision is to build a global leading pharmaceutical company. In 2014, Gannon Lee established a U.S. subsidiary in New Jersey. Our mission is to provide the highest quality products and improve patient lives around the world. At Gannon Lee, we are committed to seeking scientific solutions across a range of complex diseases. Our research and development team comprises of more than 595 scientists who are investigating new chemical entities and biologics to treat cardiovascular diseases, metabolic diseases, cancer, and diseases in other therapeutic areas.
As mentioned, Gannon Lee is investigating treatments for cancer, such as glioblastoma and other solid tumors. Globally, an estimated 1.7 million people are living with brain cancer and other cancers located in the central nervous system, or CNS. Glioblastoma is the most commonly occurring primary malignant brain tumor, accounting for nearly half of all patients diagnosed with a CNS tumor. Glioblastoma is also one of the most aggressive primary brain tumors, with a median survival of 12 to 15 months, despite advances in surgery, chemotherapy, and radiation therapy. Therefore, a significant unmet medical need remains evident in this patient population.
Here at Gannon Lee, we are pursuing scientific solutions for these patients. We have an investigational compound for the treatment of glioblastoma and other solid tumors. The investigational compound has been granted 2 designations by the U.S. Food and Drug Administration. It received orphan drug designation, which indicates the investigational compound is intended for the treatment, prevention, or diagnosis of a rare disease or condition. It also received fast track designation, which is a process designed to facilitate the development and expedite the review of drugs to treat serious conditions and fill an unmet need. Furthermore, the European Medicines Agency has also granted orphan drug designation for the investigational compound. These designations are important steps in allowing us to collaborate closely with regulators while we continue to investigate this compound. Our clinical trial program is ongoing and will be able to assess the safety, tolerability, and efficacy of our investigational compound. We thank the many patients and families who have and will participate in our clinical trials. We look forward to the future as Gannon Lee sees many more opportunities to collaborate with you, patients, caregivers, and the medical community in the hope of making a meaningful difference. To find out more about our clinical trials, write to us at info.medical@ganlee.us.
Hello, my name is Dr. Jatin Shah. I'm the Executive Vice President and Chief Medical Officer at Karyopharm Therapeutics. Karyopharm is proud to be a sponsor of the American Brain Tumor Association National Conference and proud to sponsor ongoing research in GBM. Karyopharm is a small pharmaceutical company based outside of Boston, Massachusetts, started in 2008 by our founder and Chief Scientific Officer, Sharon Chackham. We've been focused exclusively on developing selective inhibitors of nuclear export, and specifically a drug named selinexor. This is an oral therapy that's given once or twice a week. We were recently granted approval for this drug for patients with 2 different types of blood cancers, including myeloma and diffuse large B-cell lymphoma in 2019 and 2020. As you can see in this slide here, there's lots of ongoing research that we have right now with selinexor, both in various blood cancers, including myeloma and lymphoma, as well as various solid tumors, including in patients with sarcoma, endometrial cancer, other solid tumors, as well as GBM, which we'll be focused on today. How does selinexor work? So selinexor specifically and selectively inhibits XPO1. And XPO1 is a protein that shuttles tumor suppressor proteins from the nucleus to the cytoplasm. These tumor suppressor proteins should be inside of the nucleus where they'll normally be activated and where they function to suppress tumors. Now, cancer cells will overexpress XPO1, and they do this to bypass the mechanisms of tumor suppressor proteins. So when they overexpress XPO1, then these cancer cells will shuttle these tumor suppressor proteins into the cytoplasm where they're no longer active. So by inhibiting XPO1, which selinexor does, it leads to the nuclear localization of these tumor suppressor proteins. So these proteins then live inside the nucleus where they can function and kill cancer cells. Importantly, selinexor also combines very nicely with radiation therapy and temozolomide, which are 2 commonly used treatment modalities in patients with GBM. In our initial experience with selinexor in GBM, in recurrent GBM, we learned 2 very important things from this King study. Number 1, we know that selinexor crosses the blood-brain barrier and then gets into the space around the brain where it's important where it can actually work for patients with GBM. And we showed in patients with GBM, that selinexor does have single agent activity. We saw patients with both a partial remission as well as a complete remission for those patients with relapsed GBM. Based on that, we've launched this new study called Export GBM.29. In this study, we're adding selinexor into the current standard of care. So whatever you'd otherwise get as a standard of care, we're adding selinexor on to see if it improves it. For example, in patients with newly diagnosed GBM, we'll add it either to radiation or a combination of radiation and temozolomide based on if your disease has MGMT methylation status. And importantly, for patients, unfortunately, with recurrent GBM, we're combining it with lomustine, which is another important standard of care, to see if we can improve outcomes with a combination therapy. This trial is currently open now and enrolling at these various centers that you see here, and more centers to come soon. Our contact information is here for any questions or information. Thank you so much for your attention.
Welcome back. Our co-chair, Dr. Chang, will introduce our next session and speaker.
Thank you, Emily, and welcome everybody back. Going along with the theme of taking control of your journey, I think integrative oncology offers patients and survivors this empowering approaches to taking control of their health and well-being. And in this session, attendees will learn the benefits of suggested integrative therapies such as nutrition, cannabis, supplements, and yoga. And an integrative approach to brain cancer care can support treatment outcomes by enhancing your strength, stamina, and quality of life with evidence-informed therapies. So it is my great pleasure to introduce Dr. Donald Abrams, who's a colleague of mine, an internationally renowned integrative oncologist with a consultative practice at the UCSF Osher Center for Integrative Medicine. He is a professor emeritus of medicine at the University of California, San Francisco. He is also the co-editor of the Oxford University Press textbook, Integrative Oncology, co-written with Andrew Weil. Please welcome Dr. Abrams.
Thank you, Dr. Chang. It's a pleasure to be here. So I do have some disclosures to just report. I'm a consultant to a number of different firms and groups. Integrative cancer care, I think, was described really centuries ago by Moses Maimonides, the Hebrew sage, but William Osler sort of said it similarly, that it's more important to know what sort of patient has a disease than what disease a patient has. So, oops, if I can go back. This was a recent quote from ASCO Post, the American Society of Clinical Oncology, in an article that talked about the patient we see and the person we may not. Although we treat the patient in front of us proficiently, we sometimes can be oblivious to the person behind the patient. While the patient carries the diagnosis, it is the person within who carries the patient. This becomes important because it is the person and the vicissitudes of his or her life that determine the patient's presence, absence, and behavior. I thought that was really nice. So I define integrative oncology myself as the rational, evidence-informed combination of conventional therapy with complementary interventions into an individualized therapeutic regimen that addresses the whole person, body, mind, and spirit with cancer. And Dr. Chang emphasized evidence-informed as well. As you all know, medicine in the 21st century is very strongly evidence-based. And particularly oncologists, we are the most demanding of evidence in the medical literature from randomized placebo-controlled clinical trials, because we deal with a serious illness and we use pretty toxic treatments. So we really want to see the evidence. But if I'm going to tell you to get a massage twice a month or eat more blueberries, you know, how much evidence do I have to support that other than what's informed from the general literature? Integrative oncology provides relationship-centered care. I usually ask my patients to tell me the story, and they start and I listen. The average physician waits 17 seconds before interrupting the patient. You're not going to tell me a whole story in 17 seconds. So just by listening, I establish a relationship. It's patient-centered relationship based. Integrating conventional and complementary methods of treatment and prevention, aiming to activate the body's innate healing response using natural, less invasive interventions whenever possible. Integrative oncology engages the mind, body, and spirit, as well as community. Rarely does a person come to see me by themselves. They're always bringing a spouse, a parent, a child, a friend. Cancer always involves more than just one person. It encourages providers to model a healthy lifestyle for their patients. And even though we're not supposed to be consuming food in patient care areas, I'm always drinking my green tea in the morning when I see my patients in clinic. Focusing attention on lifestyle choices for disease prevention and maintenance of health, and maintains that healing is always possible, even when curing is not. So when I see a patient at the Osher Center, I am doing, as mentioned, consultation, and I am not dealing with their cancer per se. I tell my patients that cancer is like a weed, and other people are taking care of the weed, and it's my job to work with the garden and make the soil as inhospitable as possible to growth and spread of the weed. So when I'm talking about these interventions, it doesn't really matter what particular type of cancer a person has, because I'm not working on the weed, dealing with the garden and the soil. So who do I see in my practice? Very rarely do I see people who are seeking alternatives to the cancer therapy that they've been offered by their conventional oncologist, because we let it be known that I am an oncologist. I've been an oncologist for 38 years, and I believe in our conventional therapies. But about 5 to 10% of the people I see are refuseniks who don't want conventional therapy. Most commonly, I'm seeing patients who are seeking complementary therapies while undergoing conventional therapy to helpfully mitigate the symptoms of the cancer or its treatment and to prolong their remission. The other group that I see most commonly are patients seeking optimal survivorship care. Rarely again do I see people who have run out of all sorts of options and think that I might have a magic bullet in my drawer someplace, which I don't. And then again, as the prior speaker mentioned, integrative medicine I think is very useful in patients at end of life. Next slide. So my goals when I see a patient, number one is to increase the patient's sense of control. Very often I see people who say that, you know, when they heard the words, "you have cancer," their locus of control was ripped out from underneath them, and they're now at the mercy of the surgeon, the radiation oncologist, the medical oncologist, or even the chemotherapy nurse. And what we do in our consultation is to give the patient back a sense of control. I also, one of my goals is to decrease ongoing inflammation. We now appreciate that inflammation contributes to many of the degenerative diseases of aging, including dementia, heart disease, and cancer. Next. Increasing the body's innate immunity in the fight against cancer, of course, is what we're doing now with our immunotherapies, but I've sort of been doing it for a number of years before those by, again, decreasing inflammation. You allow the body's immune system to kick in and help attack the cancer. And then there are also other things that we do to help boost immunity. When I ask patients to tell me their story, many patients weave a story as if stress itself caused their cancer. I don't think stress itself causes cancer, but stress is not good for cancer or anything else for that matter. Stress is epinephrine or adrenaline, which kills lymphocytes, the building block cells of the immune system, and stress is cortisol, a steroid hormone, which is an immune suppressant. So decreasing stress is important. And then all of these things together, I think, serve to increase hope. Many a person leaves my consultation and says, "Gee, Dr. Abrams, you're the first person that's given me any hope." And it's not like I have said you don't have cancer or it's not a serious illness, but just giving the patient a menu of things that they can do themselves is very empowering. Next slide. And so what are some of those things that people can do to increase their sense of control? Well, we now believe that about 40% of all cancer in the United States today is related to overweight or obesity. So certainly controlling weight, as difficult as it is something that people can do. And you do that by altering your diet and increasing physical activity. We then talk about the appropriate use of supplements to help support patients while they're undergoing treatment or in survivorship mode. The breath is very important as a key to mind-body interventions, because until I mentioned breath, we were all breathing autonomously without even thinking about it. But now that I've mentioned it, maybe you're becoming more aware of your breath, and you realize that you can control the rate of your breathing, the depth of your inspiration and expiration. And that is sort of the link to hypnosis, to yoga, guided imagery in a way, and even meditation. As I mentioned, very rarely does a patient come to see me by themselves, and I remind them that they do have their family and friends as a support system, and they should call upon that. I ask all my patients if they were raised with any religious beliefs. Often they were, but sometimes they've lapsed. More often, patients do consider themselves to be spiritual. Next slide. Before, so in that vein of working with the garden soil and making it as inhospitable as possible to growth and spread of the weed, I say, let's see how you're fertilizing your soil. That is, what do you eat and what supplements do you take? And I actually spend about 20 minutes of my new patient consultation talking about diet. And I think the people I see are really happy to see an oncologist who doesn't say, eat whatever you want, it doesn't really matter. Because in fact, I think it does matter. Next slide. And this shows a little bit what I'm talking about. This is from the Journal of the American Medical Association, an article on the state of US health, 1990 to 2016, burden of disease. And this graph shows you the contribution of a number of different problems to mortality, death in the United States today. And the number one cause of mortality is actually dietary risks, which surpasses tobacco use and high blood pressure, and does not even include high body mass index, which is number 4, and decreased physical activity, which is further down the chart. Next slide. Unfortunately, this article in JAMA didn't tell you what they mean by dietary risk. So they refer you to an article previously published in The Lancet. And dietary risks are diets that are low in fruits and vegetables, whole grains, nuts and seeds, milk, fiber, calcium, seafood, omega-3 fatty acids, and other polyunsaturated fatty acids, and diets that are high in red and processed meats, sugar-sweetened beverages, trans fats, and sodium. Next slide, please. So I call upon the American Institute for Cancer Research, World Cancer Research Fund recommendations, and I review these with my patients. Now, as you can see on the header, these are recommendations for cancer prevention. But guideline number 10 down below says, after a cancer diagnosis, follow our recommendations if you can. And as you can see, number 1 is to be a healthy weight. Do that by being physically active. And then it starts to talk about various food recommendations. Next slide, please. So the new guideline in 2018 really was a shout out against fast foods. They previously had not had a guideline that says limit consumption of fast foods and other processed foods high in fat, starches, or sugars. And this is, again, the major contribution, I believe, to the obesity epidemic that we see in the United States today. Next slide. This gives a nice quote about what the problem is with fast foods. Processed foods high in fats, starches, or sugars embody a cluster of characteristics that encourage excess energy consumption. For example, by being highly palatable, high in energy, affordable, easy to access, and convenient to store. Whenever I gave a lecture on nutrition and cancer to the medical students at Zuckerberg San Francisco General Hospital, our safety net hospital here in San Francisco, always a student would raise their hand at the end and say, what about our patients here? San Francisco General serves a socioeconomically disadvantaged patient population. And I would always tell them that it is true that my organic apple costs as much as that double cheeseburger, fries, and a milkshake. And that is a problem with how we subsidize food in this country today. Next slide, please. In my opinion, the ideal diet is organic, plant-based, antioxidant-rich whole foods, and this describes an anti-inflammatory diet, which is what I believe is best to consume. Next slide. The anti-inflammatory diet that I recommend is very similar to the Mediterranean diet. I ask patients to increase plant-based foods, including heavily pigmented fruits, such as the berries, and cruciferous vegetables, flowers that grow in the shape of a crucifix. Broccoli, cauliflower, and Brussels sprouts jump to mind, but there are also cruciferous roots and green leafies, cabbage, kale, collard green, bok choy, and arugula. These all contain a chemical so potent at reducing the risk of cancer, we started to look at it as chemotherapy. I recommend increasing whole grains, decreasing animal fats. I encourage patients to eliminate dairy products, red and processed meats. Poultry should preferably be organic. Eggs, if they are consumed, should be organic omega-3 eggs. My favorite animals are deep cold water fish, salmon, black cod, albacore tuna, herring, mackerel, and sardine. Those are very rich sources of marine omega-3 fatty acids, which are anti-inflammatory, a little antidepressant, and probably good for the brain. Decrease refined carbohydrates, white sugar, white flour, white rice. Season with ginger, garlic, onions, and turmeric. The Mediterranean spices are also good for you: basil, thyme, rosemary, and oregano. For beverages, I say think about Christmas, green tea, and red wine. Actually, the guideline was changed in 2018, and it now says for cancer prevention, no alcohol is best. If you are drinking alcohol, however, red wine would be the safest beverage. Next slide. So this slide gives you a little bit of a guideline of the macronutrient composition of various cancer diets that are popular. And on the left is the Institute of Medicine recommendation that about 60% of our calories should come from carbohydrates. I often hear patients say, I'm on a low carb diet. Well, fruits and vegetables are carbohydrates, and we should have 5 to 9 servings or 3.5 cups of fruits and vegetables each day. What they really mean is low processed carbohydrates or simple carbohydrates, not complex. 20% of our diet should be protein, and 20% of our calories should come from fat. Unfortunately, the standard American diet, well abbreviated SAD, shown just to the right of the Institute of Medicine recommendations, is higher in fat, lower in protein and carbohydrates. Notice the ketogenic diet, which many of my patients with brain tumors like to follow. The ketogenic diet was developed in the 1920s before we had any treatment for epilepsy to help children with epilepsy. Why would a diet that helps people with epilepsy be useful in people with brain tumors? Sort of unclear to me. And if you look at the composition of that diet with the percentage of fat and protein and the absence virtually of carbohydrates, it is not a healthy diet. I don't espouse the vegan diet necessarily because I think we do need animal products, but it does have a decrease in fat, which I think we need for producing hormones, as well as probably not enough protein. Next slide, please. So does any of this really matter after one has been diagnosed with cancer? Next slide shows some data from a study that was done in patients with colon cancer. And again, it doesn't matter what the weed is, we're trying to make the soil as inhospitable as possible. The people on the left side in group 1 there had the lowest percentage of a typical Western dietary pattern. The people in group 5 had the highest percentage of a typical Western dietary pattern. I think if you can click again, it's going to show you the difference between those two groups. Yeah, and one more. So the group on the left had meat twice a week, 2 refined grains a day, and sugary desserts 3 times a week. Whereas the group in column 5 had 1 serving of red meat a day, 5 refined grains, and 2 sugary desserts. So the reference group number 1 compared to group number 5, The people in group number 5 had 3 times the risk of recurrence of their colon cancer and twice the risk of death compared to the patients who ate a more prudent diet. So yes, it does make a difference after a diagnosis. Next slide. What about physical activity? Much of this, again, has also been done in patients with common breast and colorectal cancer because they are so common. The most active breast cancer survivors had lower rates of death from both their breast cancer as well as other cause. And the colorectal cancer survivors had similar 30 to 40% reduction in death from their cancer and 50% reduction in death from other causes. People who report an increase in activity after their diagnosis also lowered their risk of death significantly by 40% compared to those who did not. Next slide. We know that many patients would like to get advice about physical activity from their oncologist itself. However, oncology is such an explosive field today, it's very difficult in the short amount of time we have for a visit in conventional oncology to talk about nutrition and physical activity. But in this study of patients with lung cancer, 92% preferred hearing about exercise from an oncologist working at a cancer center. A survey of Canadian oncologists showed that 2/3 agreed that physical activity was safe and beneficial. Less than 50% ever recommended it, and only 1/4 within the past month. If an oncologist recommends physical activity, it results in an increase of 60 minutes of vigorous walking a week, which certainly can impact on survival and outcomes. Next slide. So this was a study that looked at the benefits of aerobic versus resistance versus both. And I often recommend that patients do develop a program of aerobic activity, but not just to get your heart rate up and sweat, but to also do some resistance work, because that's good to keep your muscles toned and your bones mineralized. And you can see the differences in outcome reported in this study if you do aerobic versus resistant versus both. We're very fortunate at UCSF that our neuro-oncology survivorship group has an exercise physiologist that works with our patients and gives people regimens to pursue. Next slide. Personally, I am a big fan of yoga. I came to yoga fairly late in life at age 60. Yoga is about strength, flexibility, and balance. And those certainly are all things that we need as we age. And yoga is about, as I mentioned, moving with your breath. So you do this on your inspiration and you do that on your expiration. And when you're thinking about that, it sort of eradicates any other thoughts you might have in your mind during the course of your practice. And I always say that Jewish boys can't meditate, but at the end of an hour-long yoga class, when we do Shavasana or the corpse pose, and they say, you can come back now, I really feel like I've been someplace. Next slide. So there have been studies of yoga in cancer patients, and this comes from a meta-analysis of 9 non-randomized and 13 randomized controlled trials of yoga in patients undergoing treatment for cancer. The results consistently support the efficacy of yoga in improving psychological outcomes such as depression, distress, and anxiety, as well as improved quality of life. Sleep and fatigue were the most commonly measured non-psychological outcomes that improved. There were no adverse effects reported among patients doing yoga while receiving active treatment. So yes, many of my patients said, I am too tired to do exercise. And actually, that's wrong. Keith Block, who runs the Integrative Oncology Center in Evanston, Illinois, actually has his patients on a treadmill while they're getting their chemotherapy infused, because he believes that that oxygenation delivers more chemo to the tumor. And when you exercise, you actually release endorphins or endocannabinoids, which make you feel a little bit high. And then, as mentioned, you sleep better at night. So you do actually decrease fatigue if you do physical activity, even when you're tired. Next slide. So one of the biggest questions I always get from my patients are, can I take this? And patients often bring me a shopping basket or a shopping bag full of supplements that they've been advised to take by their next door neighbor or their grandmother or their sister-in-law's best friend. Next slide. So interestingly, I share this to let you know how patients rank the evidence that they're going to use in deciding to use a complementary therapy. This was a study of 34 men who happened to have prostate cancer in the United Kingdom, and they were asked what criteria they used. The number one hierarchy in this as for evidence was personal stories of people that had been helped by the treatment. And number 5 was scientific evidence. And I think it's important for us as healthcare providers to appreciate that our patients may have a bit of a different hierarchy in ranking the evidence in deciding when to choose a treatment intervention. Next slide, please. So when patients are asking me, can I take this? They're really asking 2 questions. Number 1, is this going to potentially interfere with the chemotherapy that I've been assigned? Now, we know that cancer drugs are broken down in the liver by a system called the cytochrome P450 enzymes. And some botanicals can ramp up that metabolism so that the drugs that the oncologist has prescribed are going to be broken down faster and reach lower levels and perhaps be less effective. Other drugs, on the other hand, such as ginkgo, might inhibit the enzyme system, so the drugs are not going to be metabolized as rapidly as we expect, and their levels are going to build up in the bloodstream and they may become more toxic. So we don't know the status of all of these different agents interacting with all the different chemotherapies because such studies have never been done. So we have to sort of rely again on evidence-informed recommendations as opposed to evidence-based. Next slide, please. The next question that patients are often asking about, can I take this, is what I call the great antioxidant debate. Radiation therapy works by generating free radicals of oxygen. Oxygen usually exists as 2 molecules linked together. That's we breathe, that's how we live. But when those oxygen molecules separate, they create free radicals or reactive oxygen species, which knock into our DNA, causing damage, leading to aging or cancer. Antioxidants take those free radicals out of circulation so they don't do damage. Well, it turns out that radiation and some chemotherapy are producing those free radicals of oxygen to knock into the tumor DNA. So maybe we shouldn't take an antioxidant supplement while we're getting radiation or chemotherapy that works via that mechanism. Next slide. So these are some of the strongly oxidative chemotherapeutic agents, the platinums, the alkylating agents, some of the anti-tumor antibiotics, and those are some antioxidants that patients might find useful and might be interested in taking. Next slide. So my recommendation with regards to antioxidants is to not take them when you're getting radiation or when you're getting chemotherapy that works that way, unless the treatment is not meant to be curative and only palliative. My frequently recommended supplements include vitamin D3, the sunshine vitamin. This is the only blood test I ever order on patients that I see in my integrative oncology practice, because people with low vitamin D levels are at greater risk for cancer, and people with cancer whose vitamin D levels are low don't do as well as people whose vitamin D levels are normal. So I like to bring the vitamin D level, the 25-hydroxy vitamin D level, to 40 to 50 nanograms per ml. The Institute of Medicine, in all of its wisdom, lowered the lower limit of normal for the 25-hydroxy vitamin D level from 30 to 20 because so many Americans are insufficient. I like calcium and magnesium because I often recommend patients stop drinking milk and eating other dairy products, which are the main source of calcium in our diet. Both calcium and magnesium are good for bones, as is vitamin D3, and they also may help protect against colon cancer. I mentioned omega-3 fatty acids. People are not going to eat deep cold water fish every day. So I say, let's supplement with an omega-3. I'm a big fan of medicinal mushrooms. Mushrooms have a cell wall that resembles the cell wall of a bacterium. And when the body ingests some of these medicinal mushrooms, for example, turkey tail or reishi, the body responds by mounting a non-specific immune response to fight off the bacteria that's not there, and hopefully will also attack cancer. Turmeric has been found to be a potent anti-inflammatory. First I ever heard about turmeric was at our American Society of Clinical Oncology. Investigators at Ohio State have a mouse model of colon cancer where the mice are genetically programmed to develop colon cancer. And if they fed them a turmeric-enriched diet, not only do they not develop colon cancer, but they survive longer than the control animals. Chemotherapy I consider to be a very potent antibiotic. So I advise patients who have been treated with chemotherapy to consider taking a refrigerated probiotic. I like a probiotic that contains lactobacillus and bifidobacterium. Next slide. This is a quote that I live by to an extent. Paracelsus was an alchemist who spanned alchemy and medicine in the Renaissance. And basically he said there's poison in everything. The difference between a remedy and a poison is the dose. Hence, I'm not a big fan of resveratrol or quercetin. I say eat grapes, eat apples. You know, I think we need to be careful about not taking too many highly concentrated substances. Best to get most of what we need from our food, except for the supplements that I supported in the last slide. Next slide, please. So another botanical that I'm particularly fond of is cannabis. Next slide. And I think cannabis has great potential for dealing with symptoms that cancer patients often experience: weight loss, loss of appetite, pain, anxiety, depression, nausea, vomiting. You know, we can write prescriptions for 4 or 5 different pharmaceuticals, or I can recommend one botanical, and that would be cannabis. Next slide, please. When I started to be interested in studying cannabis, my colleagues from the Cancer Center said, gee, Donald, you know, in these days of nanotechnology and targeted therapies, why are you interested in a plant that's so imprecise? And it does contain over 400 compounds. The highest concentration of the bioactive compounds is found in the resin exuded from the flowers of the female plant of Cannabis sativa or Cannabis indica. The main psychoactive component is believed to be delta-9 tetrahydrocannabinol, or THC. There are at least 100 other cannabinoids that are identified in the plant. For example, delta-8 THC, which is becoming very popular in dispensaries nowadays, is similar in potency in a study done in Israeli children with cancer as an antiemetic to delta-9 present in the plant in small concentrations. Cannabidiol, or CBD, has jumped to the top of the most favored cannabinoid list because it's felt to be non-psychoactive, but does have reportedly analgesic, anti-inflammatory, and anti-convulsant effects. Because it doesn't get people high, it's sought after, but it is psychoactive because people claim it reduces anxiety, and for other people using CBD, they get a little bit depressed. So it is psychoactive, but it doesn't get you high like THC. Next slide. So I was a member of the National Academy of Science, Engineering, and Medicine committee that wrote the volume on the health effects of cannabis and cannabinoids published in January of 2017. And in the chapter on therapeutics, we concluded that in adults with chemotherapy-induced nausea and vomiting, oral cannabinoids are effective anti-nausea medicines. In adults with chronic pain, patients who are treated with cannabis or cannabinoids are more likely to experience a clinically significant reduction in pain. So certainly 2 symptoms that cancer patients are frequently experiencing. Next slide. What I see very often are patients coming to me to ask, should they use highly concentrated oils of cannabis to treat their cancer? Well, really, where does this notion that cannabis has any activity against cancer come from? In 1975, investigators at Virginia Commonwealth University reported that delta 9 THC, delta 8 THC, and cannabinol inhibited Lewis lung adenocarcinoma cell growth in the test tube and in mice. CBD, interestingly, did not, and CBD actually led to enhanced growth of those tumors. Since that time, there's been an increasing body of preclinical evidence, that is, in the test tube in mice, suggesting cannabinoids may have anti-cancer activity. And cannabinoids, or cannabis, is an antioxidant itself and also anti-inflammatory. And these are good effects that I look for, again, in treating people with cancer. The anti-tumor activity really comes mainly from the laboratory of my friend and colleague Manuel Guzman at Complutense University in Madrid. Manuel's laboratory studies the effect of cannabinoids on metabolism, and the most metabolically active cells in the body are the brain cells. So they would grow up rat brain and add cannabinoids and do their research. And they said, maybe we can do this faster if we use a brain tumor. So they grew up a rat glioma and they added cannabinoids and everything died. And they said, ooh, we must have done something wrong. So they did it again and everything died. They said, well, maybe this is a bad batch of cannabinoids. So they went back to the normal brain and everything lived. The brain has a high concentration of what we call the cannabinoid 1 or CB1 receptor. And what the Guzman lab has demonstrated is when you add cannabinoids, they complex with the receptor on the tumor cell and invite the cell to commit suicide or undergo apoptosis. Similarly, they've also found that cannabinoids inhibit vascular endothelial growth factor, which allows new blood vessels to form, very similar to what bevacizumab does. So in addition, they've demonstrated that cannabinoids block the enzyme matrix metalloproteinase 2, which allows cancer cells to become invasive and metastasize. Next slide. But this is all in the test tube. What do we have in humans? Well, Manuel Guzman actually went to the Canary Islands and he dripped THC via a catheter into recurrent glioblastoma in 9 patients and reported that there was no real difference in survival compared to those receiving chemotherapy alone. However, a more recent report looked at a drug called nabiximols, which is a whole plant extract with a 1-to-1 ratio of THC to CBD, licensed and approved throughout the world except in the US for treatment of spasticity associated with multiple sclerosis. No studies conducted in the US have shown any benefit to this cannabis-based medicine. But an early phase study of nabiximols or placebo in patients with recurrent glioblastoma multiforme was conducted. A very small study. This is an under the tongue spray whole plant extract THC to CBD ratio of 1-to-1. 12 patients received that, 9 received placebo. Progression occurred in 2/3 of the group by 6 months. However, despite the fact that the progression rates were the same, the survival in the group using the nabiximols was 83% at 1 year compared to 44% to the placebo group. And although the study was not large enough or powered for survival as an endpoint, this was a statistically significant difference. And the survival benefit persisted at 2 years as well, with 50% of the nabiximols group versus 22% of the group receiving placebo. Next slide, please. So just with regards to that, when my patients ask me what ratio of THC to CBD should I use, especially my brain tumor team, I suggest a 1-to-1 ratio on the basis of that evidence from that clinical trial. So what about stress? There is not much evidence that stress itself directly causes cancer. But as I mentioned, stress is epinephrine or adrenaline, which kills the lymphocytes, the building block cell of the immune system, and stress is cortisol, a steroid hormone, which is an immune suppressant. So decreasing stress is important. Next slide. So how do we recommend stress reduction? Support groups. Ironically, some people get more stress participating in support groups because they feel that the patients participating are more advanced than they are, and they don't want to have to go there. But other people do benefit from participating in support groups. just writing down at the end of the day your experiences, your feelings is another good way. Telling other people what you're going through does provide some support. I like guided imagery, listening to a CD-ROM or MP3 of a calm voice telling you to go to Maui and think about your lymphocytes eating up your cancer cells is a nice thing. Hypnosis, the breath, psychotherapy, and mindfulness-based stress reduction is an 8-week program where you're taught some yoga poses, as well as to be in the moment and be here now and not dwell on the past or the future. Let your thoughts come and go without judging them. An 8-week online current program that does end with a 1-day silent retreat. Not sure how that works online. And again, I like yoga as a good mind-body intervention as well. Next slide, please. I am a big fan of Chinese medicine, traditional Chinese medicine. The tenets of this practice are that the human body must be perceived and treated as a whole, as part of nature. Health itself is the result of harmony among bodily functions and between the body and nature. Disease occurs when this harmony is disrupted. Traditional Chinese medicine therapeutic interventions restore the harmony that's been lost. Next slide. The modalities that are used in traditional Chinese medicine include acupuncture, as mentioned by the previous speaker, is very useful for pain, nausea, vomiting, fatigue, stress, sleep. I love acupuncture for pretty much everything. They also use botanical therapies. Tui Na is massage in traditional Chinese medicine, and exercises that are mind-body interventions are both Tai Chi and Qigong. And in traditional Chinese medicine, there is also dietary modalities and dietary therapies that are recommended. Next slide. So people are well aware of the meridian theory. It's felt that the internal organs reflect onto the body surface in lines, and these are the lines in which the acupuncture points exist. And when a needle is put into a particular acupuncture point, the whole goal is to redirect the flow of energy or qi to restore the balance that's been lost. Next slide. So the National Institutes of Health in 1997 had a consensus conference in which they all agreed that acupuncture was useful as an antiemetic during chemotherapy. It's also been demonstrated to be useful in pain, including peripheral neuropathy, which many people develop after treatment with cancer treating interventions. Anxiety and depression, people getting radiation therapy to their salivary glands have much less dry mouth if they get acupuncture. Hot flashes in patients who are getting hormonal therapies, sleep disturbances, immune enhancement. It even, something was just published which supported my belief that my patients getting acupuncture are able to maintain their blood counts throughout their courses of chemo so that they don't have to have delayed cycles or dose reductions. And that has recently been demonstrated from a meta-analysis of studies conducted in China. Next slide. So working with the whole person, I think, is what we're doing in integrative medicine. And there are many layers to each individual. And I think it's important that we remember as providers to ask what matters. Next slide. When I was seeing patients in person, more so than I do currently, before I would examine them, after I asked them if they were raised with any religious beliefs or if they consider themselves spiritual, I would ask them 3 closing questions. What brings you joy? What are your hopes? And where does your strength come from? And although one husband asked me while I was asking his wife this, what is she being interviewed for Miss America? I saw a woman a few years after her husband died at a conference, and she came up to me and she said, you know, when we came to see you, you asked him those 3 questions, and he realized that even though he was where he was on his journey, he still had joy, hopes, and strength, and that really changed the rest of his life. So thank you. Next slide. So in closing, I ask to remember that the role of the physician is to cure sometimes, heal often, and support always. And with that, I'll thank you for your attention, and I'm happy to answer any questions if there's time permitting. Thank you.
Thank you so much, Dr. Abrams, for really sharing with us how to incorporate integrative approaches to one's care and sort of taking control of that. So appreciate it so much. I will hand over to Ambreen, who will coordinate the question and answer period.
Thank you so much, Dr. Chang, and thank you, Dr. Abrams, for your wonderful presentation. We will take questions. As a reminder, please type and submit your question using the Q&A button on the bottom of your screen, and we'll answer questions as time allows. Dr. Abrams, you shared some wonderful integrative and complementary approaches to symptom management through survivorship as well. We have a question asking, how can somebody find an integrative medicine physician that can provide them with more insight about what might be appropriate for them? Is there a database, or should they ask their doctors for referrals?
Well, asking the doctor is a good one if there are people that exist in the area or at their institution. The Society for Integrative Oncology, I believe, has the opportunity to search it to see if there's somebody that belongs to the society that's working in that place. But it can be rather hit and miss. I think one of the benefits of the pandemic is that I see patients that are in Washington, D.C., in Idaho, in Southern California, Hawaii, from all over. But it is a good question, and it is something that I'm often asked, is there somebody close to me? Many medical centers have integrative oncology departments. MD Anderson has a whole integrative oncology program, as does Memorial Sloan Kettering, the Dana-Farber. So some of the larger cancer centers do provide integrative cancer care.
Thank you so much for that answer and your advice. Another question we have here, you had talked about some of the different forms of cannabis and CBD. Is there or are there specific forms of cannabis that are recommended for specific tumor types? For example, this attendee here is asking about glioblastoma in particular.
Yeah, no, I mean, so one must understand that cannabis in the United States today, despite being approved in many, many different states, continues to be a Schedule I substance per the federal government, which means high potential for abuse and no accepted medical use. So the only legal source of cannabis for research is the National Institute on Drug Abuse, and that's NIDA. And they have a congressional mandate that they can only study substance of abuse as a substance of abuse. So if you want to study the potential health benefit of cannabis, you must use NIDA cannabis, but they cannot fund such a study. That's why in the National Academy of Science, Engineering, and Medicine book that we published, there's one chapter on therapeutics and 13 on potential harm, because the National Institute on Drug Abuse spends $150 million a year studying the potential harmful effects of cannabis without finding too many, I might add. So the only information that we currently have is on nabiximols, which is not the whole, well, it's a whole plant extract with the 1-to-1 ratio of THC to CBD. Personally, I believe CBD detracts from the benefits of THC. And certainly CBD changes the shape of that cannabinoid receptor so that it can no longer bind THC. And THC is what binds to the receptor and probably causes the brain tumor cells to commit suicide. So I would like to see research done with THC alone in glioblastoma and not THC CBD 1-to-1, which is all the information that we currently have in the published literature. So there's no answer to that question because that research has not been done. I will say that in Australia, they did a study of 1-to-1 and 4-to-1, so higher THC, less CBD, and they found that the patients didn't tolerate the 4-to-1 as well as the 1-to-1, because CBD does detract from both the effectiveness as well as the adverse effects of the THC. So, I don't know. We don't know the answer, but I tell my patients, if they're interested in using, maybe a 1-to-1 ratio is what should be looked at.
Thank you so much for sharing that insight. Another question we have here is about visiting with an integrative physician or at an integrative center. Are these visits covered by insurance, or is this going to be an out-of-pocket cost for patients?
I think it depends on the integrative center. The Osher Center for Integrative Medicine is totally covered by insurance.
Thank you so much. And along the same lines, you had mentioned that you're a big fan of Chinese medicine, things like acupuncture. Are those also out-of-pocket costs, or do you know if some insurances would cover something like that?
Totally. Many insurance companies do cover acupuncture. They may have a set amount of sessions that they're going to provide coverage for, but acupuncture is covered by many insurers. The key is finding an acupuncture provider that takes that insurance that the patient has. And depending on where you live, you might not have the ability to find such a person. In the Bay Area here, in our 9 Bay Area counties, we have many acupuncture providers, and hopefully somebody would find one that would take their insurance.
Thank you so much. And just now you had briefly mentioned, how there's not a lot of studies regarding THC and brain tumors. Are you aware of any studies or clinical trials that are being done for alternative treatments, maybe aside from cannabis, aside from THC?
Well, again, so complementary means it's done in conjunction with, alternative means it's done instead of conventional therapy. I certainly wouldn't recommend anybody seek an alternative therapy to conventional therapy for a brain tumor.
Thank you so much for making that important clarification between complementary and alternative medicine.
And then integrative, what we do in integrative is we integrate complementary therapies into conventional cancer care.
Thank you for that.
I do want
go ahead.
Yeah, I do want to say that unfortunately, I do see a lot of patients that think that they're treating their brain tumors by taking highly concentrated oils of THC or CBD. And, as yet, there's no evidence that that is going to have any benefit at all. And most of the patients I see doing that, especially if they're ramping up their THC dose to the point where they can't get out of bed and eat, I don't think are doing themselves a service.
Thank you so much for that important advice. Kind of along the same lines, we have a question about reading information online, finding information about supplements or diets or other complementary methods that someone might recommend online on a forum. Can you provide advice for patients on how to decipher what is right and wrong, or how to bring up these conversations with their physician?
Yeah, I think social media is a big detriment. I personally don't do Facebook, I don't tweet, I don't do any of that. So I'm pretty old school, but I think there's a lot of what used to be called fake news out there. And I think it's unfortunate. The National Cancer Institute Physician Data Query, NCI PDQ, has an integrative, alternative, and complementary therapy component to it. And we review a lot of information on the NCI PDQ IACT website that people might find useful. There's a provider site and a patient site where they sort of, condense the information into smaller portions with the smaller words so that they're more understandable. But that's a site that I like. Memorial Sloan Kettering in New York has a good botanical site telling you about different supplements. But I think, as I showed, those men with prostate cancer in the United Kingdom, they rely on personal stories of other people to, guide them in selecting their complementary therapies, and not necessarily on scientific evidence, which I think is, understandable, but unfortunate.
Thank you. And, part of integrative medicine you had mentioned is the spiritual aspect. can you talk more about how you as an integrative physician bring in spirituality or incorporate a patient's spiritualness into their healing and complementary treatments that you'd recommend?
Yeah, I mean, there aren't any complementary treatments for boosting spirituality. How do I do it? I think, by just asking them those three questions, what brings you joy? What are your hopes? And where does your strength come from? I think it helps guide people towards getting in touch with their spirit and the importance of something greater that is still with them, even though they're on a journey that may feel difficult at the time. And then when I see patients in follow-up, I tell the fellows and students that sit in with me on my Zoom visits or even in person that when I see a patient in follow-up, I'm more like a health coach or a counselor, trying to make sure that they're adhering to the recommendations that I gave them. And because integrative medicine is relationship-based, I do all sorts of things that I recently took a little online course that we had to take in professionalism that I realize are now totally unprofessional because I share my life with my patients as well, so that it's a two-way street. And, I don't know if that's spirituality, but I do also tell them the things that are important to me and that make me aware of where we are in our journey. And, for me, for example, my husband and I have seen 17 total solar eclipses around the world. And for me, seeing the moon efface the sun so that all that's left that you can see is the energy of the sun radiating off the black side of the moon, that's nature's greatest spectacle, and it takes my breath away. And, most of my patients, when I see them again 6 months later, have you been to a total eclipse? I said, well, no, there hasn't been one. But, so I get people aware. Even something as simple for me as going to the ocean, because I live in San Francisco. And when I lose an important patient or a dear friend, I often make a trip to the beach just to look at the waves come in and out and know that they're going to continue to do that ad infinitum, whether I'm here, they're here, or not. And that provides me with some solace.
Thank you so much. I think we have time for maybe one more question. Dr. Abrams, you had mentioned mind-body interventions like breathing exercises, doing yoga, etc. And this patient or attendee here is asking about where they can find resources to do these at home, maybe videos or an app that they can use to find some guided imagery or guided meditation or mindfulness exercises?
Yeah. So there are all sorts of things. So for yoga, I like personally myyogaworks.com. It's a library of thousands of videos, and then they also have live classes. For men who often find it difficult to get into those same flexible positions as women do, there's something called manflowyoga.com, which is also very good. For meditation, there's Calm and Insight Timer that are good apps that my patients like to use. Healthjourneys.com has guided imagery, MP3s and CD-ROMs that you can download. So those are just some. I think if you go online and Google that, you'll find probably others, but those are the ones that I like and I recommend to my patients.
Thank you so much for your time in answering all of these wonderful questions. I will go ahead and turn it back to Emily and Dr. Chang for the rest of the program.
Yes, thank you so much, Dr. Abrams, for being with us today and sharing how to incorporate integrative approaches to one's care. I'm going to hand it over to Dr. Chang, who is going to introduce our next session and speakers. Thank you.
Thank you, Emily. And thanks again, Dr. Abrams. Wonderful, wonderful review. So in this next session, titled Coping with Cognitive and Behavioral Changes, we will review how brain tumors or their treatments can affect one's thinking and problem-solving abilities, and can even alter one's personality and behavior. So we'll learn about the role of cognitive testing and rehabilitation, and some of the recommended coping tools to optimize how we function and our independence. So our speaker, Christina Wayajimura, another colleague of mine, is a licensed psychologist with a specialization in clinical neuropsychology. She's also a registered nurse. And in Christina's clinical practice in neurological oncology, she works with patients to help them understand the cognitive challenges, provide cognitive rehab, and reduce the impact of thinking changes on daily functioning. She also has a significant research portfolio. She addresses rehabilitation for brain tumor patients. And I think what's really important for the way that Chris approaches the care of our patients is the incorporation with the caregiver as well. And so, in fact, one of her patients, Julio, along with his wife, Liz, are here with us to share their personal experience coping with the cognitive behavioral changes and how a brain tumor may change their relationship and the roles within the relationship. So I'd like to welcome both Christina, Julio, and Liz. Thank you so much for taking the time to spend with us today.
Thank you so much, Dr. Chang. And I'm so excited, Liz and Julio, to be talking with you today. I always look forward to our time together, and this is no different. And thank you so much for the wonderful gift of imparting your journey to others, so they also can learn some of the ways that you've found to manage and thrive in this in the context of the thinking changes that you've experienced. So thank you so much. I really appreciate it.
We're happy to be here.
So maybe both of the three of us can talk a little bit about how you came to see me, and just so that way kind of orients people a bit to our work together. So maybe I'll start, and then I'll pass the baton to you. Does that sound okay? Perfect. So I had the pleasure of meeting Julio and Liz after he had some surgery, and was really looking forward to returning back to work, but there had been some changes that he had experienced through his treatments, and so maybe perhaps we can start there. In terms of how, can you tell us a little bit, Julio, about your history as it relates to brain tumor and diagnosis, and maybe what was life like for you during and after treatment? And I know that's a lot, so you can start wherever you want.
Well, thank you, and thank you for this opportunity. So I'm Julio, and this is Liz, and in 2018, I was having difficulties speaking. And there was this one defining moment where I was teaching a 3-day course, and through the lesson plan, as I'm speaking, mid-sentence, I stopped and I couldn't speak anymore. So I excused myself from the classroom and I went to another room and I tried speaking. I tried doing the alphabet and counting, and it was very difficult. I tried writing down anxiety on a paper so that I can show it to another facilitator, but I couldn't spell the word. It was difficult. So I got a CT at the VA, and then that turned into an MRI for a follow-up. And then, well, I had one tumor on the left parietal lobe, and I did surgery at UCSF. And after surgery, I felt good. I did radiation. I felt good with the radiation. I went back to work and I started working with Dr. Jamora, and we worked on some of the small deficiencies that I had recognized after the first surgery. And then I was off treatment during that time. And then I had 3 tumors later on after about 2 years of being cancer-free. I had surgery again. I went to a clinical trial, and then I ended up doing chemo, and I went back to work. And I'm at work still, and I am still doing chemo. And Dr. Jamora helped me battle that different type of challenge that I had.
we're definitely in this together, right?
Yeah, for sure.
We're stronger as a team. And
Yeah.
and Julio, what are some of the thinking and other challenges that you've noticed? What are some things that are just a bit harder now?
Staying focused. It's difficult. I still struggle on finding words and math. I struggle with math and spelling. So I had to learn how to overcome those struggles. And when I worked with you, you helped me find different techniques that will get me to the end result that I wanted.
And I love that you're using one right now. You're using your paced speech. So, and you're talking with your hands. So got to tell you, you're making my heart sing. And how about you, Liz? What are some changes that you noticed and how was this for you?
So definitely in the beginning, after his first surgery, he had noticeable issues finding words, mixing up words that sounded similar, even if they didn't mean anything close. And basic math was actually really difficult for him. So maybe if he was trying to add, he would multiply. So maybe the answer would be correct, but not the correct answer he was looking for the proper method of solving that problem. So that it was really hard for me not to hover because I just wanted to help him and take care of everything and not let him stress, and backing off a little was tricky. And then after the second surgery, actually even leading up to the second surgery, when he was doing the clinical trial, he definitely had a different type of problem with language after the surgery, and then especially with, like he said, his attention span. Now that he's gone back to work, but he's still in treatment, this is a completely different ball game. I think his symptoms after the recurrence have been different, and so navigating those issues, trying to reorganize his day differently to make sure he can still be productive at work and not feel like a failure just because things are different now. That's the kind of support that I need to give him, but also it's really great to have you give him that support because it's an outside person. It's not like your mom telling you look good. Yeah.
I think that is so true, that it does take many voices for us to, and also a lot of coordination. It wouldn't be the same if, Julio, you and I were just working together and we didn't have Liz's valuable input, right? So we are definitely, like we've said before, it's a team sport. Working in terms of managing this as a team sport. And so in terms of what are some things so how did you talk with your providers about some of the changes that you were experiencing, some of the thinking changes, and how did then they kind of talk with you about my services or cognitive rehabilitation? Because I think that sometimes folks don't know how to talk with their doctors about that or where to start.
Well, I've become an open book, and I express my feelings, and I'm not shy to express them with others. And I feel like that is what is important, because those feelings are research. And it's important to speak with your doctors about how you're feeling, because they have a vast knowledge of the subject, and I also they have connections. And that's how I got to meet with Dr. Jamara. I was talking to my oncologist, and she said, you know what, there's someone who can help you with that. And so being open just opens up more doors for you.
I think that's so true. And Liz, what are some things that have helped you manage the challenges you both face, both together and separately?
Well, the not hovering thing is helpful. But yeah, so in the beginning, I would always try to jump in with the right word and try to help him solve the math problem. And especially when he was having conversations with other people, just try and smooth it over so that maybe it wasn't so noticeable if he was having an issue and I didn't want him to get stressed out. But realistically, this maybe with the first tumor, we thought he had the surgery, he had the radiation, he had the cognitive therapy, and things were going well, and that was it. But that was not it. And this is a part of our lives, and I needed to think about the long term. So backing off and giving Julio the time to search for the right word or find a different word that means the same thing, which is one of the things that you talked to me about doing. And asking if he wants my help before I jump in, which I don't necessarily do in front of other people because it's a little awkward, but if it's just us having a conversation, I'll let him go and see, what does he need from me, rather than just try to fix everything. I think that created a better circumstance for our own interactions, because I was stressed out trying to fix everything, and he was getting annoyed that I was maybe jumping in and cutting him off. And so it helped not only Julio
communication.
Not only helped Julio deal with the issues himself with my support if he needed it, but it also helped us communicate better.
Yeah, absolutely.
It's key.
Yeah. So what was it like in cog rehab, Julio? Well, what do you think was helpful? And if so, how do you think it was helpful? Or is there one thing that you feel like that was most helpful?
Well, I felt like I was losing my mind before I spoke with you after the second surgery. It was just such a different feeling from the first time. Those deficiencies that I felt, they were minor after the first surgery. Now I really recognize them, and I enjoyed the sessions that we had because you helped me feel accomplished at work. Because for a time there, I was going through a pretty hard transition from starting work again after 4 months of treatment. But then when I was starting the work again, I started chemo again, or for the first time, and that I didn't know how I was gonna react with it, and you led me down the path to make me feel more successful. I know to not stay in the red, take breaks when I need them, get some fresh air, eat often, and that helps me concentrate more and get back into the game.
And Liz, is there anything in particular that you noticed that whenever during the course of cog rehab, because we also, you and I also would have time together, and which again, lots of fun and lots of laughs, and also lots of hard times. We're talking about things that can be painful, and so anything on your side as a caregiver or as a spouse that you felt like that was helpful in terms of the way what we worked on in cognitive rehabilitation.
I don't know what your relationship is like with your other patients, but I definitely feel like you are a therapist part of the time, maybe most of the time in some of the more recent sessions. But for me, the immediate important piece of cognitive rehab was validation. So all of the things that we were noticing with the language and the math, and even just like
his emotional state. That sounds a little more extreme than I mean, but it's kind of like, am I going crazy? Are these things really happening? These things weren't being monitored before he was diagnosed. Like, we weren't paying attention to how well he could add or whether he mixed up words, because we all do those things sometimes. And so going through the different issues that people have that you've treated, things that are normal, things that are expected, it definitely made, I think it was like a little weight off of both of our shoulders. Like, this is happening. We're not crazy. Some of these things can be fixed and some of them we can work around. And I feel like that for me was like the most important piece, and it happened right away. But there are a lot of really valuable things that Julio learned and still uses, and maybe hopefully he doesn't even get into the red.
And we'll talk more about what that red is, I promise, for others, so that way they can kind of conceptualize what we're talking about. It's our shorthand for some and managing fatigue, cognitive fatigue. And I think you're right that it's the person within the context of what's going on, right? And we really have to both think about what are the changes, what does the literature say around managing those changes? I see a cat behind you. And then also that managing the changes, as well as how you're taking that in, and how do we make sense of that? Because in my experience, that is important to think about. Where the juice is worth the squeeze. You know, what are the things that are important to you, and what and how can we utilize certain techniques and strategies, but not also forget that this is hard. We're talking about painful things, and sometimes having some support around that's really important.
Yeah, it's true. I feel like you're an ally, and it makes me feel good.
Yes, we're in this together. So what advice, so are there, and in terms of what advice for both of you would you give to other people or other providers that, that are in a similar position, or other people that are thinking about engaging in cognitive rehabilitation or testing, and and kind of beginning to think about managing some of these slip-ups and other changes over time? What would you tell other people? And you've been telling them, but maybe if you can kind of the highlights of the most important things that you feel are other people should know.
So I would say that first of all, changes aren't necessarily permanent. There's a lot that your body goes through during treatments, surgery, radiation, chemotherapy, immunotherapy, like all of those things are really hard on your body, and that can manifest in other ways that may go away, but some things may not. So for me, I would suggest, first of all, if you regularly see your oncologist and you have a good relationship with them, ask them what kinds of things could be helpful for the types of issues you're having. We give way more information than probably anybody ever wants, but we take a lot of notes when things happen, how long they happen for, what Julio was doing before, if he was going for a run or if it was really hot outside and things like that. We've even taken quite a few videos, because things don't necessarily happen on demand either. And this kind of reaches outside into like seizure activity and things like that. But if you're not communicating with your medical team everything that's going on, then they don't know which resources to direct you toward. Yeah. And if you don't see your oncologist that often, or you don't feel comfortable sharing all of that with them, usually there's either a caregiver support program or a social worker. We've had a lot of really great nurses in our lives over the past few years, or even somebody at an organization like this who might be able to point you in the direction of resources. Everybody has different things that are available. We're very lucky that UCSF has everything in the same place for us, and we're close enough to drive up there. We're like 3 hours away, so a lot of our appointments are through video, but
Yeah, UCSF has like connections with NIH, and I did a clinical trial there, and they have connections with the Clovis Community Institute, the cancer center, and that's where I went and did my radiation. So I mean, you got to just be open. You got to talk, and try to find those gifts, and really put the effort in to do it. I mean, the VA has helped me, and I do acupuncture, and I've spoken to Dr. Abrams many times. So our diet is on a good level, and it's just we are taking advantage of everything that has been put in front of us.
One thing, Julio, I know that you and I have talked over time a lot about is that your values about, contribution and being a hard worker and, doing your tip-top best. And that's at some point, we also needed to think about workplace accommodations. And that was a big shift for someone that has those really strong values around just being so stoic and moving forward, not complaining, just doing your tip-top best. And sometimes that ultimately that can be a barrier to people getting some of the workplace accommodations or other kind of implementing certain strategies. And maybe you can talk a little bit about that.
Sure. So the second time when I came back to work, I was struggling. I couldn't remember things. I have a hard time telling a story. I have a hard time following a story. If there are multiple steps that I need to take, it's difficult for me to go down that path. And I learned how to work around it. And it's made my work a lot more pleasurable, because it was pretty bad for a while, and I wanted to quit, but I don't quit. So I had to suck it up, and just try to just find what works best for me. And the training that we did helped me find that. And now at work, I'm good. I'm doing good.
So proud of you.
If I can just add to that something, so the accommodations request didn't go quite as we had hoped. Some of the things were denied, and that's fine, but simply submitting the request alerted his supervisor that Julio and his supervisor were on completely different pages about his capabilities at the moment, especially because he's been working from home. And so something as simple as his supervisor restructuring his workday so that he worked on one type of task in one day, and then the other type of task he needed to do, he did on a separate day, made a huge difference. And that wasn't something necessarily that we would have thought was a problem, but it just putting it out there that there was an issue and having your backup made it more official and made them take it more seriously, I think.
That's good.
Yeah, I think that one thing that you touch on that is so true is the importance of tracking what works, not just symptom collecting of what is when things are going down the tubes or when things aren't going well, but actually, oh, well, I felt a bit better when I did these service requests, for example, for this many hours, and then I still had a little gas left in the tank to do these other things. So again, that strength-based symptom tracking, and we'll talk a little bit more about that, time and time again, both can validate that, yes, I'm seeing this, but also not get stuck in the helplessness and the futility of all of the challenges and, take you down for the count, right? Oftentimes we talk about how the answers are in when things are working. And in the strengths, which is a bit of a different spin sometimes than what we hear about and think about with cognitive rehabilitation and or even testing, right? We sometimes think like, oh gosh, it's going to be, I'm going to have to face the big bad, challenges, and oftentimes thinking about, wow, look at this. This is a place of real strength. How can we harness that for your work in other places?
Yeah. One thing that I took away was that 52%, about 52% of people who have surgery, they don't go back to work. And if you have a second surgery, that number is even greater. So that really motivated me to continue doing what I'm doing so that I can, I believe, have a purpose to share my story with others, to let them know that you gotta put your feelings out there. You gotta reach out.
And one thing I really appreciate about you is that you're continuing to be open to adjustment over time, right? That yes, sometimes you need to have a reduced workload, or yes, maybe it is, workplace accommodations, or at some point, maybe work is something that you pivot away from to something else, right? But that's how we, and I know that, again, these are all changes over time that we'll continue to work on. So thank you so much, Liz and Julio. I really appreciate you sharing your personal experience, and I know that it really, it's so crucial for us to continue to learn from each other, and especially me learn from you. And thank you for sharing so that other way people can learn that as well.
Opportunity, y'all.
Well, again, thank you so much for joining today for our chat a little bit more about ways to cope and manage cognitive and also behavioral and emotional changes in the midst of brain tumor. And, I'm a neuropsychologist, I'm a rehabilitation neuropsychologist, and I really work and study with families that are with individuals that are trying to find ways to thrive in the midst of their course. Today, we're going to talk about some typical changes with individuals with brain tumors and how we think about those changes, and maybe the role of neuropsychology and rehabilitation, and learning some strategies to be able to manage some of those challenges. And some of these may not be fully applicable to your situation, but the good news is that even after today, if you want to learn more, you can talk and have a conversation, as Julio and Liz talked about, with your care team to learn more. And then, of course, at the end, we'll have some question and answers to be able to continue to answer some of the concerns that you have. So I have no disclosures. I am on the advisory boards for the Schurig Center and the American Congress Rehabilitation Medicine, and I have some clinical trial and other support through the Loglio Foundation and the Silicon Valley Foundation. So today we'll talk a little bit more about how brain tumor treatments and brain tumor can affect your thinking and problem solving, your personality and behavior, review the role of cognitive testing and evaluation and rehabilitation, but then also talk about some strategies that we're finding that the literature supports, that we're also finding that can optimize day to day and help you manage some of the challenges that you may be experiencing. So all of us from time to time have an experience of forgetting a word, or that we're trying to say, or we forget our keys, or going into the other room and forgetting why we went there, or even sometimes where we parked our car. These are common lapses that most people experience from time to time, and there can be factors such as stress or feeling fatigued that can make it more common. The time when you don't need those challenges, or sometimes the time whenever they come up because you're feeling already stressed. But more so, these are whenever there's changes to the brain. These, as Julio was saying, can be that much more common, especially more and more so as you have multiple surgeries and also radiation and chemotherapy. Cancer-related thinking changes are very common across different types of cancers, but even more so in brain tumor. So this is a research done by Schmidt and Tusha that really outlines that individuals with brain cancer far outpace their other cohorts from breast cancer and other types of cancer in terms of their experience of cognitive changes. And these changes, and we say cognitive, what we mean is thinking changes, so memory, attention, concentration, can happen at the time of tumor diagnosis. It can happen during treatment. It can happen before you even get diagnosed. Those are some things that that a lot of the folks that I work with will look back and say, you know, I think I was experiencing some changes way before I got diagnosed. And this makes sense now, why now I'm having these changes, as Julio and Liz were saying, oh, I felt like I was losing my mind. And sometimes just having that sense of, oh, no, this is a thing, and this is a thing that a lot of folks go through, and can be quite helpful as a starting point. And how severe those changes can be, or they can, some changes can be, thinking changes can happen, for example, right after surgery, and you're on some medications such as dexamethasone or other kind of seizure medications, and there can be spikes in some of the thinking changes. And then for some, and then there also can be persistent changes that don't necessarily get better over time either. And so it's a bit of a dynamic sense of how people experience some of these thinking changes. And I think that oftentimes Margaretta Page, she's our wonderful colleague who oftentimes works with the caregiver team. She talks about how this doesn't just impact the patients, but also impacts the individuals with brain tumor, but also impacts the caregivers, spouses, and family, and loved ones of others. There's been some research that suggests that thinking changes and behavior changes can be some of the most stressful parts of the tumor course, and individuals struggling to be able to live their lives in the context of this medical issues. So day-to-day activities that were once automatic now take much more time and effort. And moreover, these changes may not be readily apparent to other people. So for example, a lot of the folks that I work with, they'll say, yeah, people after the surgery, they're like, oh, you're doing great. You seem fine. Tumor's all gone. You're good. You're back to work. And there can be this invisibility sometimes that comes up where, individuals that have the diagnosis, they can feel like, well, I might look okay, but I feel different. And there can be a little bit of a double-edged sword that other people say they're doing great, when in fact, it's a bit more complicated than that. And so finding ways for folks to be able to, providers to ally with them to make sense of that and then know what to do about it is now we're finding to be a really important part of what folks are wanting and finding that it's important to do. So these are some of so when we say cognitive or thinking changes, this is what oftentimes the folks that I work with talk about experiencing, that they don't feel like me, that they feel alone and scared, and they've always been a really great multitasker, and they can't do that now, and they're not getting as much done, and there's a big frustration around that, and what that sense of identity and the loss that they feel around that. And then again, the idea that there's this public-private split there, and privately they can feel like they're really struggling, or it takes a lot more effort cognitively to do things, but other people might not always pick that up in the same way. And that since we know that over 82% of people will experience some sorts of cognitive changes through their course, that's all the more reason that we should be thinking about ways to provide a space for them to be able to work on this, think about it, and also their loved ones as well. So even, like I said before, even before the surgery and thinking changes and behavior can start to change. So for example, one of the folks that I work with, one of the things that they said is that, slowly but surely, I noticed that before the surgery, I was having more tip of the tongue. I had a phenomenon where the word was right there, but I just couldn't get it. Or they noticed that they couldn't multitask as well. So they would become more and more irritable when they were driving, when other people were asking them questions, and it was just too much overload. And they noticed that they were forgetting things and just seeming distracted. And so all of those changes are really common. And about 92% of individuals can have changes in their mood and behavior during their course. And then additionally, issues such as insomnia, fatigue, substance use, and other sorts of medications and stress can have their impact as well. And so this is a way that this graphic is some of the way that we're thinking about the impact that cognition can, that the tumor course and other aspects of the illness can impact our cognition. We can have tumor effects. There can be prior medical history, can be fatigued. Seizure medications and steroids can also really wreak havoc in terms of our attention and concentration and being able to do things in our other aspects of it. Sometimes the tumor location and the biology can also impact the types of difficulties that we have in terms of thinking. And then environmental influences and also having other emotional distress that was there even before you were struggling with brain tumor is also can contribute to the expression of having some challenges on the cognitive side of things. So this is a graphic that I oftentimes will spend some time talking with folks about because of the parts of the brain can oftentimes give us some sense of, where the tumor location and or treatment effects are, can really give us a sense of, oh, so that's why maybe there's some issues around motivation. It's one of the individuals that I was working with. He was always a real big go-getter and was had been kind of top of his game for a really long time. But after his surgery and after his treatment, he noticed that he didn't have as much motivation as he did before, and that a fair amount of that actually was because of the tumor location and the effect that had in terms of his biologic ability to be able to provide that motivational kind of that area was no longer working as it had before. And additionally, I think some of the more challenging, we do know that a large proportion, especially of certain types of tumors occur in the frontal and the temporal lobe areas. And so all the more common are these changes in emotion and behavior and verbal expression, memory, oftentimes the parts of us that we feel like are us, making decisions about social relationships and all of that, and detecting certain things going on with other people. All of that is really more likely to be someone that has a brain tumor to have a hard time with. And oftentimes it can be that much more challenging for individuals and caregivers to sort out, well, he seems really different, but he seems like he was always like this, but it's really obvious now. What is that about? How do we understand that brain and behavior relationship? And ultimately, what can we do about it? Because this is really challenging. It's really hard on our relationship. So I showed you this slide as a talking point and thinking, as a reflection point of, in terms of the location of one's tumor can matter, but also to think as well that there can be network disruptions. There can be disruptions within the whole networks of the brain that, and there's also neuroplasticity. So it's a bit complicated to say that form always meets function, that just because it's in one place that it absolutely there'll be something that that will be, because we know that oftentimes is not the case with brain tumor per se, because of the nature of the slow growing nature of the tumor. So all the more reason to have someone with you that can, a partner in care, such as a neuropsychologist, that can help you understand it better, that, well, I have a brain tumor. It was taken out of the front part of my brain. I think I'm having some symptoms associated with that, but can we do some testing to figure out if that's the case? And then, it's going to have been kind of hard on my relationship. So can we figure out then what to do about it, and how to manage that? So where do you start? Where do we start, right? So oftentimes we're trying, the first steps are, just as Liz and Julio said, talking to your doctor about, gosh, I'm experiencing I feel different. I know that I seem like I'm doing things as I typically did before you met me when we did the surgery, but I feel different. And the tumor is out, but there's also we know that treatment effects can really influence, it can really influence long after the surgery and the tumor is being gone, for that time, the massive part of it. So we want to make sure and support that over time, because there can still be things going on, even though it's not showing up on MRI. So if you're experiencing difficulties with thinking changes, it's important to let your doctor know, and talking with your health care team about this. And also letting them know what's important to you. And also considering screening for modifiable factors as well. Oftentimes there can be some influence of other medical issues that can exacerbate or make cognitive thinking changes worse. So making sure that you're engaging with your doctor, talking with them about, is there any other condition that we're missing? Some of the major culprits are making sure your thyroid is checked, or making sure that any other medical issues are attended to, such as infection or other vascular risk factors, such as blood pressure or diabetes and other concerns. But then also we want to make sure and look at non-cognitive factors, but that can have an influence, such as fatigue. We know that fatigue is one of the major symptoms that most individuals will experience during their course, and it is one of the things that can exacerbate more symptom flares in terms of cognition. Additionally, anxiety and depression can contribute, and additionally can have an influence in terms of people's attention and concentration and other cognitive functions. So we want to make sure that that's fully treated as possible. And that diet and exercise additionally are important, as Dr. Abrams and others have discussed, in terms of really being able to overall support your health and wellness from a cognitive perspective. But maybe today we can talk a little bit more about cognitive testing and rehabilitation in the time that we have left, to be able to kind of dig into it more about what that is, and how that may be helpful, and maybe could be a part of your care, and how to think about that. So oftentimes whenever you're talking with your neuro-oncologist and or other doctors, some of the things to consider is what to expect. So, and what exactly is neuropsychological evaluation? So it really is a way to think about brain behavior relationships, and thinking about when we come up with a word, for example, there can be ways in which that it needs to go through various processes in the brain to then ultimately be able to be spoken. And that when there's a disruption in some way, in some part of that network or some part of that thinking in the brain, then it's really important for us to know more about that, get a better sense of what's that about, when's it more likely to happen, and what are some of your strengths, what are your cognitive strengths that we can pull in to offset that the expression or the challenge of that thinking change. So really neuropsychological evaluation is can sometimes be up to 8 hours of testing. It's paper and pencil testing, and it really focuses on memory, attention and concentration, behavior, planning, and also that the caregiver and or family members are also kind of talked in the context of this, because sometimes we don't always know everything and we can't always see everything about ourselves, and oftentimes other people can be really helpful in the midst of that, and they also maybe have their own needs and have their own gaps in terms of what they need support with to manage that. So we review the records, we interview, we'd have conversations with both the individual with the brain tumor as well as the caregiver, and then we do some testing, and then we do some treatment, and we do some treatment planning and feedback. And these are the testing oftentimes can be a bit I don't know. I think it can be a bit. I think a lot of the folks that I've talked about can talk about how it can just be so. It can be overwhelming to go through that process in some respects, because you're doing things and maybe you feel like some things are going well and other things are not going so well, and making sure that you're taking care of yourself in the midst of that is really important. Bringing snacks and getting a good night's sleep if you can the night before, and it's not necessarily something, for example, that you can study for, but what I think it can provide is an opportunity and some clarity around what's going on and then what to then do about it. So why is it good to see a neuropsychologist for thinking changes? Well, and why and when would you do that? So if you're experiencing some thinking and mood difficulties and you want to get a better sense of how to understand that and then perhaps manage it, and some skills that can help you with that. Big changes such as going on disability. Sometimes that's oftentimes the times I get involved if someone is considering federal disability, that they want some support for that, or return to work or school for accommodations. Again, those are really crucial times that I oftentimes can become involved and help shepherd and quarterback some of that care. And then also understanding what types of help that are needed at home. Is there in-home support services? Is there help with, is there kind of some need for maybe some help for cooking, cleaning, food shopping, accompaniment, going to appointments if that isn't something that the family is able to do. All of those questions are ones that I oftentimes am thinking about. Okay, cognitively, this is what I'm seeing. This is what I would expect. And then also just tracking those thinking changes over time. Sometimes folks aren't so interested in necessarily additional skills to manage some of their mood or thinking changes, but they do want to just kind of get a good sense of how things are going over time. And that's absolutely fair game. And those are some of the more common reasons why I oftentimes will begin seeing folks, but there's lots more as well. So, oops, there you go. So it gives you an understanding of your brain's strengths and challenges. It's information for your doctor and care team to help guide their treatment planning. For example, with medications and or other treatments, there can be an important understanding of, okay, how could this impact me cognitively, and or in refining their approach to that. Recommendations for your day-to-day life that can help, and then also accommodations and or ways to help you succeed in school and or do the things that you want to do in a more independent way. So get a good night's sleep before you go, and eat something before you arrive, because it can be stressful and can be a long time that you're there. And bring a snack or water even whenever you come, so that way you can just continue to feel supported, because again, you're burning a lot of calories with all that work that you're doing. Bring your eyeglasses or hearing aids or amplifiers if that's something that you use. And oftentimes it's important to take your medications as you typically do, unless the neuropsychologist says otherwise. But oftentimes doing as you typically would, it's good for us to see that process. And also consider bringing a loved one or caregiver with you. Sometimes you're pretty tired after all that testing, and having that additional person there with you, and or they can provide some additional information that can be helpful in just kind of giving a better sense of what's next and how to think about that for treatment planning. So after the neuropsychological evaluation, then we're thinking about, okay, for the folks that are wanting to do something about this or learn some more skills in terms of managing it. You know, one of the folks that I worked with recently said, you know, I think cognitive rehabilitation is not the right term, because it's so much more holistic, and then you're touching on so many other things besides just the cognitive component of it. And I think that's a really fair point, that oftentimes we are doing retraining. We're retraining certain skills, attention and concentration skills. We're also kind of giving strategies and learning strategies around workarounds. Like, how can I work around the fact that I have attention and concentration challenges when multiple things come at me at the same time? I get really distracted and I can't pay attention to driving while my husband's trying to ask me questions. And honestly, I have that same challenge. So I can really empathize with that, although my patients talk about it having on a much larger scale. And I think that that's very important to be able to navigate with them. Treatment planning and coordination, that I'm oftentimes coordinating with a lot of other providers. It might be their psychotherapist, it might be their physical therapist, their speech therapist, it might be their neuro-oncologist and or their palliative team. There's a lot of coordination that is crucial for us to all kind of support someone as they're managing some of the thinking changes. So it's not just going in, learning some exercises and then leaving and then doing that. It's really how we then ultimately manage all of what's going on in terms of all the environment that the patient is in that can cause some of the increase in thinking changes. So for example, if it's a really busy environment, really loud, and one of my patients has noise sensitivity, for example, whenever he hears a lot of noise and there's a lot of information coming at him at the same time, that causes more cognitive symptom flares. So it's both he internally will do strategies to make sure and reduce his contact with that, but then also he makes sure to pre-plan his day so that way he has less of a exposure to that as well in terms of that noise sensitivity, because we've predictably found that that's a part for him that really derails his ability to kind of remember and all of the rest. And then the cognitive and emotional piece, I think that Liz and Julio were talking a little bit about that there can't be, there's a certain part that we think about the loss that goes along with cognitive change over time, and that we're having to adjust and re-experience who we are and the challenges of having not necessarily be the same person as I've been before, and adjusting in some ways and finding ways to thrive in the midst of that is a huge part of what we do in cognitive rehabilitation as well, is finding ways to live well despite some of these cognitive changes, doing what we can to improve what we can, and then also helping other people to find ways to support you so that way you can live well. So it's all of those things. It's a lot of different things. So what are some of so we oftentimes are starting with thinking about, okay, let's track when you're doing well with your memory and your attention and concentration. And what are some of the factors that help you to do that? So one of the major components that we have found, and literature supports this as well, is that it takes a lot more energy and cognitive effort to do the same task oftentimes. And that in some ways that makes sense, because there have been changes to the brain, and that we want to make sure and be a really good manager of our resources whenever we're doing something. So getting overstimulated, going into a busy room where there's a lot of people talking and a lot of things going on, for a lot of the folks that I work with, can be really exhausting. So one of my patients said, my goal is to be able to go to my daughter's wedding. And I'm really not looking forward to it. I want to see her get married, but at the same time, I'm really not looking forward to it because it's going to be loud. There's going to be a lot of people there and it's going to last all day long. And I just don't know if I can tolerate that. Because he had before found that in our tracking that, oh gosh, yeah, that's a hot button issue for me. So being able to find ways to prevent that overstimulation or increase our ability to regulate stimulation, because again, if there's some changes, for example, in the front part of the brain and the frontal lobes, then that can be a challenge regulating that stimulation. So being able to regulate your sleep-wake cycle, limit the people and places and things that can be overstimulating, giving yourself extra time and increasing your daily structure, and reducing that light and noise when you can, and taking breaks can be an important part to just, again, these are all behavioral things that you can do to begin to think about in terms of why is it sometimes that all of a sudden I'll feel really wiped out. And then I close my eyes for just a few minutes in a quiet space. I have a brain break that I can perk up, I can feel a little bit better. And that's, I think, having that approach of being your own investigator, so to speak, or being your own manager as a way to think about that is really important. And managing fatigue, and that's one of the things that that Liz and Julio were mentioning in terms of the fatigue management is a core foundational piece that I think that most cognitive rehabilitation will address at the outset, especially if the evaluation finds that there's been some negative impact in terms of cognitive fatigue. And that could mean that you just run out of gas sooner and you start off with less, that you just can't hang in there to do all those complex tasks that before seemed to be pretty straightforward. And there can be a lot of reasons for that. And so Terry Armstrong and Dr. Gilbert in some of their work from NIH have talked about this in terms of being able to track your fatigue symptoms early on and intervene, and having physical exercise and getting good sleep. All of those things can really be important to managing fatigue. And that sometimes having also gratification. So if you're kind of feeling very fatigued and then all of a sudden there's something really exciting that you get to do, sometimes some of that fatigue will recede away a little bit. And that has to do with kind of some of the parts of the brain that have to do with the reward pathway, that can give us a bump in terms of our perceived sense of fatigue, because there can be a perceived sense of fatigue as well as a physical sense of fatigue. And there might be a mismatch. And in cognitive rehabilitation, we're oftentimes talking about how can we get better at detecting what's going on in terms of our fatigue, and then also how can we do some behavioral strategies to make sure that we're being good managers of that. Other things that's really important to consider is talking with your doctor about vitamin deficiencies and other medical conditions, such as thyroid dysfunction and or other vascular dysfunction that can also cause exacerbations in fatigue. So this is the red, yellow, green that we oftentimes are talking about. About 40 to 70% of people with brain tumor report having fatigue throughout their illness course. And although fatigue is really prevalent, that is really prevalent across the disease trajectory, that radiation in particular can be a big culprit as well, with greater than 80% of people after they've had radiation experience some fatigue of some type. And oftentimes when we're tired, we struggle to be that best version of ourselves. And particularly when you have had brain cancer, your brain has to work harder to complete a task. And as it works to complete this, it takes much more energy and effort than maybe other people understand that it takes. So as we learn how fatigue plays a role in our day-to-day experience of our thinking changes, we can then begin to understand what helps us in terms of pacing ourselves. So this is the Yerkes-Dodson curve, and so they came up with this many moons ago. And really what it is that if we have a certain amount of energy And that if we have too much stress or we're required to do too much, that we can end up tipping over into burnout. So we need a certain amount of, so over here, it's how much we need to do. And then this is how much then we can do. So, so the stress level and how much we can do, there's a relationship between that. And if we can begin to detect early on when we're beginning to run out of energy, that then we can begin to put together some restorative practices to be able to put into place early on. So I think about this as a stoplight, for example, and that green is go, and that I have good energy, and that, you know, I can continue on doing a bit more. And yellow is yield, like, okay, I'm starting to get kind of tired, and, you know, I think I've done I'm starting to run out of gas and I've done too much. At that point, I need to take a brain break, or I need to really get my, I need to do some of the strategies I know that work. So for example, with Julio, he noticed when he was in the yellow that he maybe would be more likely to make some mistakes. And that he needed a change of pace. So he needed to go take a walk, he needed a snack, he needed to kind of not talk for a little while. Those were the things that we found in his treatment that were really helpful to bring him back to green, so that way he could work a little bit longer. But if he kept pushing and not did those things, not tracked the things that helped him, he would end up tipping over into red, where that he would then be, it would take him much longer to recover. So it's kind of like an ounce of prevention is worth a pound of cure in this instance, where if Julio would be able to do that, then he would feel a lot better. So these are some of so when we think about cognitive rehabilitation, we also think about fatigue. We don't just think about fatigue, we also think about forgetfulness, and we think about and we also think about distractibility. And so being able to track over time what helps you in terms of being able to deal with your distraction. And these are some general strategies the research encourages use for. So breaking things into smaller pieces, setting alarm to keep on task. So again, so that way so you don't get off track, you're really focusing on what you need to do, and verbally self-talking yourself through the steps of a task. So for example, if I'm going to go into the other room and I'm having a hard time remembering what I need to do when I go there, sometimes I'll say out loud to myself, water, 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 if my intended thing is to go into the other room and get some water. So again, if you can get multiple inputs of information, for example, being able to say it out loud while you're talking, while you're doing something, that can really help to keep your focus and on track. And additionally, in terms of forgetfulness, creating that to-do list, not just a to-do list, a long laundry list, but clustered by urgency. So again, we use the red, yellow, green idea, right? So red is like, I need to get this done now. And yellow is like, well, it'd be nice if I got it done in the next week. And then green is, well, yeah, it'd be nice if I get it done, period. And being able to prioritize what you have to do by urgency can keep it live in your mind, but also keep it prioritized in a way that doesn't keep you from getting overwhelmed. Developing routines, and we talked a lot about that with the folks that I work with, is having a routine, and having a day-to-day routine can be really helpful. And of course, mnemonics and pre-planning to reduce multitasking is really important. So behavioral changes are a big part of what the folks that I work with experience, and that the more that we're able to understand what tracking the triggers of whenever they're on track, what do you notice, and reinforcing the behavior that you want to see is really important. So for example, if you notice that someone will become more and more impulsive, or kind of do things without thinking whenever they're more stressed, we would want to reduce that stressor in the beginning, the activating event, and being able to then look at how we can work through reducing that behavior. So if we track what behavior and the things that are more likely to lead to it, then we can begin to know what to do about it. So for example, if some of the pearls of that are delaying. So whenever someone is having a hard time with being able to, they want to do something right now. I want to go to the dealership. I want to buy that Cadillac right now. Being able to ask them to delay, well, maybe after breakfast we can go do that. or maybe delaying that impulse until they've had some time to let that urgency recede, especially whenever individuals are having a hard time with being able to kind of manage that urgency. Suggesting another activity, so distracting onto another task. Yes, I understand. I hear what you're saying, that that we need to go to the dealership, but I need to do this other thing first. Let's see if we can go back to that later. And realizing sometimes the attacks that people will say are not personal, and that really have to do with some of the brain tumor, and having someone help you think that through, and being able to detach and give some concrete options can, in a calm way, can be really helpful. So it's either this or that. Either we can have breakfast, or we can go and have a shower. Which would you prefer? And clustering in terms of how much stimulation tolerance is also really important. So coping with emotions is a huge part of what we do. And the more that we can understand the thoughts that lead to certain emotions, that can give us a better sense of then what to do about them. And if we can catch it, we call it catch it, check it, change it. So if we can catch those thoughts in terms of as they're arising and leading to more feelings of distress, then we can begin to think about it in different ways. And those are strategies that I think that are really effective and really helpful in the context of working with someone, and that understanding yourself in terms of what are some thoughts that are leading to more emotional distress is one way to begin to do that. So these are some coping skills that you can think about: exercise, taking a bath, working on managing your time, and establishing healthy boundaries, and creating to-do lists. And additionally, that being able to know that cognitive changes are common and multi-determined, and that managing fatigue and working on incorporating exercise and healthy diet are a really important part of beginning to do that. And then tracking what helps to manage your thinking and behavioral changes along with your providers can be a really good starting point from a strength-based perspective. And that cognitive rehabilitation has been found to be helpful in the midst of managing issues related to thinking, and that talking with your care team is all that much more important to be able to begin that process. Thank you so much.
Wonderful, Chris. Thank you for all your insights and sharing resources for patients and families as they deal with changes in thinking and cognitive effects. I also want to thank Julio and Liz. That was just fabulous to have their voice, which is so important, right? It's just about listening to really what our patients and families are experiencing so that we can leverage whatever resources we can to help them. So I'd like to ask Julio and Liz to join Christina as we transition to the question and answer portion of this session. And I'll hand it over to Abreen.
Thank you so much for that wonderful session. And thank you, Julio and Liz, for sharing your incredible story and your insight from your firsthand experiences with our audience. Just as a reminder, if you do have questions that you'd like to ask, please type and submit it using the Q&A button in the control panel on the bottom of your screen, and we'll answer questions as time allows. So one of the first questions we have here, Christina, you had mentioned several times in your presentation the importance of tracking changes in thinking and behavior over time. Can you share if there's a specific format or structure that you'd recommend for how to track these changes?
Yeah. And Julio, you can chime in because we did this over and over and over again too. So it's really about what the situation was. So I call it a memory action plan. So it's what the situation was, what did not work, what helped, what's a strategy you want to consider trying, and then afterwards, okay, how'd it go? Did it work? Did it not work? So it's really simple. And I think one of the things I notice, with the folks that I work with is that they're naturally doing this anyway. They're naturally trying to figure out what's going on. How can I? But I think that the tweak is that when it's going well, why is that? And so that's the thing I think can be very powerful, not just collecting the instances where things were going wrong, but what was a similar situation where it was a little better, and why was that a little bit better? And then what do I know about my thinking what I know about my cognition or my thinking that's really strong that I can then leverage to kind of fill that gap, because it's about that gap closure. So I'll cede the floor to Julio a little bit.
Sure. In my situation, I needed to write notes and put down how I felt, what was the situation, how I felt, what I did to correct it or not correct it. And then when I fill it again in the next day or a week later, I can go back to the note and be like, okay, yeah, I had too much coffee in the morning, and then the work day was really stressful in the morning, and I mean, just work around all those things. And I think note taking was pretty beneficial for me.
And we do have some examples on our UCSF Survivorship website of some of those forms. So again, these are ones that I've worked with many of researchers that have developed these forms. So they're not exactly mine, but they've given us permission to be able to share those best practices with others. And, and I encourage people to try it out. You're doing it anyway, to be your own investigator of what works for you. And so it's just adding a bit more structure around that.
Yeah, just listen to your body.
Yeah, don't try to continue to push, which is important.
Thank you so much for sharing that advice. Another question we have is asking more about the structure of these cognitive rehabilitation sessions. Is there, on average, a length of time that cognitive rehabilitation can take? How many sessions is usually recommended?
Yeah, so I think that this is it's really in the infancy for use in brain tumor populations. So I think that we're still learning a lot. This has been used in for decades in traumatic brain injury and stroke. But I can tell you from my personal experience in clinical practice that it's around 20 sessions, 23 sessions per course. So what happens is I'll see someone, and then we'll do a set of sessions depending on what the treatment plan says. Anywhere from, it can be as few as 6 sessions or up to 20. And then we meet those treatment goals, and then we pause. And then oftentimes there's like an episodic. So it's not one and done. I think that sometimes oftentimes it paces along with the surgery. So you have a surgery, you have cognitive rehabilitation, you meet your treatment goals, and then the goal is ultimately that you don't need me, and that you go and you do your own thing, and you're using these strategies on your own. And then there could be a tumor progression, or the tumor needs more treatment. And then again, there's the re-engagement and care. So we kind of follow people episodically throughout.
For sure.
Thank you for sharing that. Oh, did you want to add something, Julio?
No, I'm fine. Thank you.
Well, I do have a question for the two of you, Julio and Liz. Liz, when you were talking, you had mentioned, the importance of giving Julio his space, and, you mentioned about not hovering. That can be finding that balance can be difficult for partners and caregivers supporting their loved one. And you shared some tips on how you've navigated that, like allowing him to ask for when he needed help. Can you share any other tips on how to navigate that tricky balance of, allowing Julio his autonomy and self-determination, but also, your own need to provide support and trying to help him?
So one of the things, not necessarily related to cognitive therapy, but Julio likes to run. And one time he was running when he had just started taking his seizure medication, and it was hot. We live in the Central Valley of California, so it was over 90 degrees that day, and he passed out. So we have come to realize that heat is not his friend over a few different episodes of things. And So when he wants to go for a run for 7 miles or 8 miles and is going to be gone for a long time, that's a little nerve-wracking, but we just kind of adjust to what feels safe. Yeah. So he goes when it's cooler, he goes at night, he'll tell me like the area he's going to be in. We share our locations on our phone, so if like we can't contact each other for a while, I can go hunt him down. He actually even has his phone has like a screen, the display on his locked screen has my contact info in case something happens to him. Mm-hmm. But as far as like really with anything, whether it's cognitive or physical, I just have to trust that he's going to communicate with me when something's not right, so I can back off a little. And like he said earlier, being open makes that a lot easier. So if we can trust each other that we're not going to go down a path of something scary is happening and he's just keeping it to himself, it makes it much easier to back off.
Yeah. I listen to my body, and when I know that I'm in a bad zone in the red while I'm like running, I stop and I go home. Mm-hmm. So I don't hit my 1 hour goal or whatever it is when I try to run. So I think that gives Liz more confidence and reassurance that we communicate well, and that I recognize the struggles that might come on.
Yeah, I think we've talked about more is not more, right? And that trying to attend to the red, yellow, green, and it can help you propel you farther, faster.
Yeah.
Thank you for sharing that. I definitely hear how the open communication and trust has really been helpful, and also just that self-awareness of knowing what you're able to do and recognizing your limitations and what you can and can't do in that moment. I think we can take maybe one more question. Julio, you talked about returning to work, and you were able to get some accommodations that helped you adjust, and I know Christina played a role in assisting with that. Can you, maybe you and Julio and Liz, you can provide some advice, and Christina, please jump in as well, for someone who is now searching for a new job. So it's a little bit different from returning to a job you've already had, as opposed to looking for a new position and entering the workforce, looking for accommodations. How would you go about that, or what advice would you provide for patients who are experiencing these deficits and wanting to bring that up with, in an interview or with their new placement?
Yeah, there was a time when I was working and I just didn't want to be there anymore. And I thought about getting another job that's different stress than what I have at my job. But then I thought that I'm gonna have to learn again something different, and I don't know how I would react to a new position or at another job. So I mean, cancer just changes your life, and you got to just go with it.
Yeah, so I think something that came up in Julio's therapy was, yes, that he regularly was feeling for a good few months like he wanted to leave his job. That he wanted to leave. And so we were considering, what does that look like? He's a federal employee now, and that makes disability a little bit tricky. And so we were thinking, what does another job look like? And the discussion came up of, is it going to be very difficult to switch to something new? And so, yes, the answer is yes. So depending on the person, of course, but I think probably something to keep in mind is to stick to what you know. especially if you're re-entering the job market after being out for a while due to dealing with brain tumor diagnosis, treatment, issues that have arisen from that. And so, you know, you might want to start with something that feels comfortable, something that you have a lot of knowledge about, something that doesn't feel like it's overachieving, at least to start out, like get your feet wet. And then of course, when you're applying for a job, you can ask for accommodations at that time. I would say we have learned that not all accommodations necessarily have to be granted. So try to keep in mind what the core responsibilities are of that role and whether your accommodations would kind of knock you out of the running for that. Because something that comes up a lot is the juice worth the squeeze? Do you want to go through the whole interview process? And at the end, if you wouldn't be able to do that job, was it worth the stress? Is it going to be worth the disappointment of having a rejection when you could have kind of avoided that by choosing a job that fits your skill set, fits your capabilities at this time? Because a lot of accommodations can be made, and it just depends on the job and the type of adjustments that need to be made.
Thank you for that insight. Unfortunately, we don't have any more time for questions for this session. Those were great questions, and thank you all so much for your time and sharing your insight. I'm going to turn it back to Emily and Dr. Chang for the rest of the program.
And before sending it over to Emily, there are some really, really important questions that we couldn't get to. It really speaks to, right, the need for really educating ourselves and really getting neuropsychologists to understand the brain tumor patient population. This is really why we have Chris, because I think that it's one thing to just diagnose what's the impact is, but it's really about moving to the next step, which is how do we empower patients, to help patients to, again, live their best lives. And so I will make sure that Chris, you and I can work on making sure we provide the resources that people are asking for in the chat, in the question and answer period. But thank you all for being so engaged. Really incredible session. And thank you again. So I'll hand it over to Emily.
And just really quick, if anybody has questions that they want to ask us, any of you are welcome to connect them with us, and we're always happy to share more.
That's wonderful. Somebody did already ask, could they connect with you, Julio? So
yeah, it's fine. Okay. I'm okay with it.
Perfect.
Yeah,
Perfect.
Wonderful. Well, thank you all so much. And as Dr. Chang said, Christina and Dr. Chang, you're welcome to respond to some of the questions in the Q&A box. Although we're not able to get to them live, they can type responses back to you. And for those who want Julio and Liz's contact information, I'll be happy to share that as long as they're comfortable with it. But thank you all so much for this wonderful session. And Julio and Liz, thank you for being willing to share your experiences and wisdom for other patients and caregivers. We will now have a very short break and resume the program at 3:30 p.m. Central Time, so in about 9 minutes, and then we will finish out our program. Thank you all so much. Welcome back, everybody. Our last session is all about building resilience. Resilience, or the capacity to recover or cope with difficulties, is a powerful and useful skill that can be learned over time and can lessen the extent to which survivors feel overwhelmed, anxious, or depressed. In this session, attendees will learn the qualities of resilience and some associated tools that help manage uncertainty, gain a sense of control, embrace community, and move forward in a healthy way. Our speaker and good friend to the ABTA is Jean Arsbaker. Jean is an advanced practice nurse working in neuro-oncology at the University of Illinois at Chicago for the past 16 years. So we're like neighbors. She also facilitates a brain tumor support group in the southwest suburbs of Chicago that has resumed in-person meeting in May. So if you're in the area, connect with Jean and you can maybe be a part of this support group. And with that said, please welcome Jean.
So thank you to Emily and Dr. Chang and the ABTA for including me in this meeting. I learn a lot from people at these conferences, and thank you. So I also want to thank, all the survivors and caregivers I've met in my 16 years of doing this. A special thanks to current members of my brain tumor support group. The night before these slides were due, I had a support group meeting, and so I really asked them their opinions. And so some things you'll find in the lecture are quotes, and those are directly from my people in my support group. And this is my part of my support group at a walk, and the name of our team is Kiss My Astrocytoma, and we've been active for 12 years. So I'm going to talk real briefly about what resilience is. Webster defines resilience as the capability of a strained body to recover its size and shape after deformation caused especially by compressive stress, and an ability to recover from or adjust easily to misfortune or change. The U.S. Department of Health and Human Services defines it as the ability to withstand, adapt to, and recover from adversity and stress. It's basically bouncing back from difficult experiences, and it can involve profound personal growth. I'm going to talk a little bit about something called post-traumatic growth, which is positive life changes that result from life crisis or stressful events. And this comes about through resilience. What resilience isn't, it's not a personality trait that only some people possess. So if you're listening to this and think I'm not resilient at all, it's something that you can learn and you can work on. However, there are certain factors that might make some more resilient than others. It doesn't mean that a person won't experience difficulty or distress. In fact, the road to resilience is paved with emotional stress and strain. It's not static, but rather a dynamic mechanism that changes over time and can be affected by life circumstances, one's environment and situations. So I love this Tony the Tiger picture, but life is not about how fast you run or how high you climb, but how well you bounce. And I think that's a good description of what resilience is. There are traits and qualities and characteristics of a resilient person. They view change as a challenge or an opportunity. They're not resistant to change. They establish commitment. They're able to commit to people and things and opportunities. They recognize their limits. They engage the support of others. I'm going to overemphasize that. They have close, secure attachment to others. They're able to set personal or collective goals. They have self-efficacy. They have a realistic sense of control and having choices. They have a sense of humor. They're action-oriented. They have an action-oriented approach. They're patient. They're adaptive to change. They have optimism and they have faith. So these are all qualities that help you be more resilient. Why is it important for someone with a brain tumor to be resilient? Brain tumors are sudden in onset and often uncontrollable in nature. They result in dramatic life changes to which you have to immediately adapt to. This is more than other types of cancer. So when someone has lung cancer or breast cancer, their life changes, but their whole person doesn't necessarily change. Brain tumors often cause neurological and cognitive changes, which can force a change in roles and responsibilities. And you have to develop a new normal. Julio, I loved what he just said, so I wrote it down. He said, brain cancer just changes your life and you have to go with it. So that's a good way to describe it's a new normal. Whatever you resist will persist. So learning how to let go and adapt to change can help you develop resilience along the way. One of my survivors in my caregiver group, in my support group, she's an RN and is a brain tumor survivor. And she said, tell everyone, it's your choice, live to live or wait to die. What about caregiver resilience? So brain tumors do not only affect the person with the tumor. We all know that they affect the whole family and especially the caregiver. Resilience is a characteristic that helps caregivers bounce back from sadness, exhaustion, and difficulties. It can protect them from developing compassion fatigue and burnout. And then one of the people in my group talks about the caregiver dance. And he says, being a caregiver of someone with a brain tumor is like a dance. It's give and take, and you lead and follow, move together while moving in different directions, stay in contact while adjusting roles and distance between you. Sometimes caregivers take the lead. Sometimes caregivers have to let the survivor take the lead if they can handle it. So I thought that was very intuitive about how the caregiver survivor thing works. So I'm going to have you imagine, and this is virtual, so I guess I can't get audience participation, but imagine yourself taking a river raft trip. Along with slow water, you will likely encounter unavoidable rapids and turns. Many of these come on suddenly with limited warning. How would you make sure that you can safely cross the rough waters and handle any unexpected problems along the way? So what kind of things would you do to make sure that you're safe on this river raft trip? Some things you could do, perhaps enlist the support of more experienced rafters. So how does that tie into brain tumors? Enlist the help of someone who's been there. Rely on the companionship of a trusted friends and family to get you through the rapids. Pack an extra life jacket, get a stronger raft, make sure you've got all the support you need, make sure you've got all the expertise you need. With the right tools and support in place, you'll make it through the challenges of your river raft adventure. You will emerge a more confident and courageous rafter, and you will also emerge a more confident and courageous brain tumor survivor. So coping and resilience. Coping refers to the cognitive and behavioral strategies to handle and manage stressful events or negative psychological and physical outcomes. This was talked about in the cognitive lecture, which was very good. Resilience refers to the adaptive capacity to recover from the stressful situation in the face of adversity. Coping is the key mechanism toward adjusting to stressful events. There's a significant association between resilience and total coping ability. Adequate coping ability leads to increased resilience. And resilience helps an individual perceive that he or she may acquire the means and ability to adjust to both the positive and negative events. And there's types of coping. So problem-focused coping is managing the problem that is the cause of the distress. So an example in a brain tumor is, I just found out I have to go to radiation every day for 6 weeks, but I'm told I can't drive. So I have to figure out how I'm going to manage that problem, so it won't cause as much distress. So I'm going to go find people to drive me, or I'm going to talk to the American Cancer Society and get a ride, or how you're going to do that. Or side effects of treatment. Okay, I have nausea from my chemotherapy. I'm going to talk to my treatment team. I'm going to talk to the palliative care team, and I'm going to find out what things I can do in order to manage that problem. And then there's also emotion-focused coping. So this is controlling related stressful emotions. So it's more useful when little can be done about the situation. Optimistic coping strategies to achieve less anxiety and better psychological well-being. It's a way to seek a more positive reappraisal of the situation or get involved in distracting activities. Example in brain tumors is recurrence. It's something that happens. It's not a problem you can solve, but how you emotionally can cope with it is going to be how you get through it. And I think dealing with cognitive deficits, I think the last talk was very good at how you cope with that, how you cope with the cognitive deficits and what kind of things you can do. The deficits aren't going to go away, but how you cope with them and manage them. Then there's non-adaptive coping strategies that we've all used in the past and maybe currently use, such as substance abuse, self-blame, and anger. These are things that you don't want to use for coping, and you want to be able to effectively manage your feelings and impulses in a healthy manner. It's imperative to lead to resilience. Resilience with a brain tumor, it's the means and ability for effective adjustment. A person may overcome difficulties and be able to adapt better when you maximize your strengths and abilities. Developing resilience at diagnosis may help insulate you from distress during stressful situations. Resilient individuals can possess personal resourcefulness in terms of flexibility, bravery, and persistence. And promoting resilience should be a critical component of brain tumor care. This is something that you should think about and talk about through all aspects of your brain tumor care. So, if you develop resilience when things are stable and things are going well, then if you have a recurrence, you can pull on those strategies. So how do you build resistance? How do you become Popeye with the resilience? Like building a muscle, increasing resilience takes time and intention. And we're going to focus on 4 components: connection, wellness, healthy thinking, and meaning. The first thing is build your connections. I always say it takes a village. It takes a village to be a brain tumor survivor. So it's something that you need to find your connections. Prioritize your relationships. Another person in my group said, you have to ask if the person tires you or inspires you. If they tire you, kick them to the curb, is her exact words. If they inspire you, include them as part of your village. Join a support group, in person or virtual. I think I can't overemphasize that enough. Find someone who's been where you're at. I've witnessed people coming to group and having people say to a new person, I see where you are, but you're not going to be there in a year. You're going to be here because that's where I was. And just that helps, that helps your coping and your resilience. And find a mentor. The ABTA has the community project that they have where you can find someone virtually that has a similar experience to you. Foster wellness. Dr. Abrams talked a lot about this, so I'm not going to spend tons of time on it, but take care of your body, adequate nutrition, exercise, routine health maintenance. There was a man named David Bailey who was a singer, and he was a glioblastoma survivor, and he was told that he had 6 months to live, and 10 years later, he actually wrote a song that had something to do with, I guess it's time to go back to the dentist, because he hadn't been to the dentist in 10 years. So make sure you're doing your health maintenance. Practice mindfulness, and Dr. Abrams talked a lot about this and gave you some resources on that. And avoid negative outlets. Find some purpose. Maybe it's helping others who are in the same thing as you, people who are earlier in their diagnosis. Be proactive. So plan ahead and decide what kind of things you're going to do to find your purpose. Redefine your goals and then move toward them. We have one woman in our group who always talks about, when she was diagnosed with a glioblastoma, her children were in high school. And she says, all I want to do is see my kids graduate from high school. And then she said, okay, I want to see my kids, graduate from college. And now I want to see my kids get married. Now I want to have grandchildren. So keep redefining what kind of things you have to look forward to and then move toward those. Look for opportunities for self-discovery. What can you learn about yourself, about what may help you? And then maintain control over those situations that you have control over. This is important for caregivers. Allow the survivor to have control over the things they can have control over. Embrace healthy thoughts. Keep things in perspective. Stay away from flat prejudgments. Develop more flexible viewpoints. You have to accept change and learn from your past. I always say find humor in the tumor. Take the opportunity in support groups or with other people to laugh about your experiences and find funny things that have happened to you along the way. Be optimistic and maintain a hopeful outlook. Hope generates resilience. We had a person who came to our group and she was there for an hour and she went to leave and she hadn't said anything. And she stood at the door and said, I came here with no hope and I'm leaving with hope. So I thank you for that. And so that was very powerful. So she, from that point on, said she had hope and that helped her be resilient. How can you facilitate hope? Build and sustain meaningful relationships. Again, stay positive. We had a long-term brain tumor survivor who a neurosurgeon had said to him 20 years previously, be careful what you think because every cell in your body is listening. And he said that was his mantra and he woke up every morning and thought that. Live in the present moment. Promote your accomplishments. We do a lot of celebrations of days of diagnosis and birthdays and things like that. Promote the fact that you've had a stable scan or that you've got through chemotherapy or you finished radiation. Feel a spiritual connection and anticipate your survival. There's nothing wrong with anticipating that I'm going to be a survivor. No matter what this, the survival curve never goes down to zero, and I'm going to be one of the people that survive this. And then pursue help. You can get professional help with a counselor or a psychologist. Get help from friends and family, and look for resources like the ABTA and other resources. Get help from someone who is in the same boat, either through the ABTA Connect program or through a support group. Make meaning of the diagnosis and its impact on your life. When you're faced with physical, psychological, social, spiritual, and existential changes, they're imposed by the tumor. You often feel a loss of autonomy and a loss of sense of control. Search for new meaning in your life. Keep life going as before as well as you can. So distractions, still go to the kids' soccer games and still try to keep your life going as you can. Develop some hobbies. If you're not able to work, maybe you can take up painting or crochet or something like that. Have some hobby. And then deal with just everyday matters so that you're not concentrating 100% of your day on the fact that you have a brain tumor. Behavioral processes of adaptive adjustment. So think about what you have to do to be able to adjust to this. Evidence suggests that searching for meaning is only helpful if meaning is found. So find some meaning in your life and figure out what that meaning is. And this often leads to what we call post-traumatic growth. We've all heard about post-traumatic stress disorder, but this post-traumatic growth is a subjective, positive psychological change that arises when someone endures some major life crisis or traumatic event. It emerges when an event is associated with a level of stress sufficient to threaten or even destroy a person's belief or life expectations. The more a person reflects on the circumstances and consequences of the experience, actively tries to deal with it, and searches for its meaning, the more likely this post-traumatic growth will occur. The changes may include increased life appreciation. I've had a lot of people say to me, the best thing that happened to me was my brain tumor. I appreciate life so much more. I appreciate my family so much more. Renewed or altered life priorities, enhanced sense of personal strength. You realize how much you got in you, but you didn't know. Improved social relationships. There's a deeper sense of spirituality and personal meaning. Increased bodily care. So it's okay, time to start taking care of myself. And augmented feelings of personal control. I'm going to keep talking about control because you have to control the things you can and accept the things you can't. And then finding balance between resilience and non-resilience. So what kind of things contribute to resilience? Managing stress and coping strategies versus inhibiting factors would be overwhelming stress, worries, and fears. Having goals and a sense of purpose versus not knowing what to expect. Staying positive versus stuck in the negative. Benefit finding and meaning making as opposed to negative emotions, anger, sadness, shame. Connection and social support versus isolation. Being normal versus being different. So you want to try to weight the balance toward the resilience side, knowing that there are going to be times where you're going to have things in the non-resilient side. So I'm going to give you a little bit of homework for resilience building. Recognize your signs of stress. Where do you feel stress in your body? Sometimes, people will call me and say, oh, I had a focal seizure. That's the way they know that they have stress. Or, oh, I have headache or neck pain. That's how they know that they're feeling stress in their body. What are some of the bad habits you engage in when feeling this stress? So know what you're going to do. Understand that you're gonna drink too much alcohol or you're gonna overeat when you're having stress, and try to figure out how you're gonna manage that stress, not doing maladaptive things. Then focus on building hardiness, small changes that you can invest in to improve your health. We talked previously, but make sure you're getting enough sleep, adequate nutrition, get out and exercise every day. That will help fatigue, and it will also help your overall stress. Think about what is one small change that you can make right now in order to be a more resilient person. And then strengthen the relaxation response. I think calm body and calm mind are good for your own mindfulness. List some activities that help you relax. So think about things that help you relax. And then self-soothing activities. Tactile, so that would be holding something comforting, maybe a puppy or a stuffed animal, something that feels good on your skin, even just a fleece blanket. Think of something that tactily gives you comfort and helps you to relax. Olfactory, think about scents, lavender. Now with all our times of wearing masks, I find that if I put a little lavender in my mask when I've had a long day, it kind of relaxes me and gives me a little bit of chance to relax in a busy day. Fresh air, again with the mask, go outside, take gulps of fresh air. That you can smell that. You can smell when there's rain in the air or when it's fall. Take the time to smell a rose, buy a flower and put it in a vase and walk by and smell it when you feel like you need to do something for self-soothing. And then visual, look out the window, look at photos, watch the sunset, watch the sunrise, think about what beautiful thing you can do and look at that and find a place, your most beautiful place in the world and have a picture of it. And when you feel like stress is starting to get to you, pull out that picture and just look at it and put yourself there. Auditory, listen to music, sounds of nature, noise machines, things like that, things that make you relaxed. And then taste, drink tea, eat chocolate, have something that soothes your senses. And then identify and use your strengths. Think of a time that you could handle a challenge and what personal strengths did you have, and write those down. So tell yourself, I handled that really well. So I had that MRI and I was able to do some imagery and I was able to get through the MRI. That's usually tough for me. And so I have that strength. So think about, that's one of my strengths, and I'm going to write that down. So when I have problems and I'm starting to have a stressful situation, I'm going to do that again. Increase positive emotions on a daily basis. Express gratitude. Tell your caregiver you love them and thank you for everything they're doing. Sometimes they don't feel enough gratitude. Again, find humor in the tumor. Find out, there's times where in our support group, we are laughing and people at the cancer center are like, what's going on in there? Isn't that the brain tumor group? How come they're all laughing? Well, because they're finding humor in the tumor. Keep a journal of something positive that happened every day. Just write it down. One thing, positive thing that happened every day in your life. Engage in meaningful activities. So think about what has meaning to you and engage in those. If, and that's where you should spend your energy, engaging in things that are meaningful. Counter unhelpful thinking. So be kind to yourself. Give yourself a pat on the back. Understand that this is hard and that you're doing well and you're getting yourself through it. It really is okay to have a pity party every once in a while. And sometimes you have to do that in order to rebound. So give yourself a pat on the back, even if you're feeling a little sorry for yourself, get through that. Don't have a permanent pity party. And again, create a caring community. Find out who's important to you and who helps you. Write them down and make sure you're connecting with them. People want to help. Caregivers also get a resilience homework. So here's a plan for caregivers. Maintain your own health and well-being. It's very important for you to keep your own doctor's appointments, get your own mammograms, maintain your own health, get your exercise and nutrition. Figure out what you have to do to maintain your own health, because we need our caregivers healthy in order to be the best caregiver they can be. Build a team. Think of who's on your team. Again, think of who tires versus inspires you. People who offer to help need to have an assignment. So give them something to do and it will make them feel better. Identify what you need help with and then accept that help. Recognize that it's much easier to give than receive. So allow yourself to receive. Think about tasks that really don't have meaning to you. Now we're in leaf raking time. See who could come and rake your leaves, mow your lawn, shovel your snow. Let them do it. Ask someone to help you coordinate a job list and get help from people so you can maintain your own health and well-being. Maintain your friendships. Friendships are very important. So, find someone to, if your loved one can't be alone, find someone to stay with them so you can maintain your friendship. Healthy relationships are known to reduce stress. Organize your own life. So make sure that there's not a lot of clutter in your own life, because the brain tumor and everything around it will add clutter. One of the caregivers in my group said, don't focus on the negative until the negative appears. So don't sit there and wonder when the recurrence is going to happen. Just when it happens, it happens. Don't worry about it, for years up until the time it happens. And then someone else also said, the harder you try to make things better, the longer and better quality of life is possible and within reach. So spend every day trying to make things better for your loved one, and that will help improve their quality of life. Redefine your circumstances. Find meaning and purpose in your role as a caregiver. Find acceptance. Caregiving may not be something you asked for. It's something you have, and sometimes it's a thankless job. And so figure out how you can accept that this is your current situation. Adapt your role. Be as flexible as possible. Be playful and believe in serendipity. Serendipity is you take a bad situation and how can you get a life lesson, or how does it give you a gift? And a lot of our caregivers say, I have the gift of having spent such good, moments with my loved one that I maybe hadn't done before. Try to maintain a light spirit. And then just there's the, in case anyone wants to know, you can Google this, but there's a thing called the Connor-Davidson Resilience Scale. And it's just, you look at all these things and you give yourself 1 point for everything that you're able to do. So if you look at this and think, okay, what are some things I can do in order to increase my resilience? So these are just 25 things of if you have this, there's a better chance that you're going to be resilient. So think about, how can I take pride in my achievements? How can I, accept a challenge? What can I do about, my relationships? What kind of things I can do in order to be more resilient? And there's my disclaimer. Okay, hopefully I did okay on time, Emily, and I don't know if there's any questions.
Yes. Yeah, you did a wonderful job. Thank you so much, Jean. We really appreciate it.
Thank you to everyone for being resilient to stay till the end.
That's right. We will now have a few minutes for questions and answers. Just as a reminder, if you have a question, using the Zoom control panel found on the bottom of your screen, click on the Q&A button and type in your question. Okay, as some questions begin to come in, I have a question. What advice would you give to patients and caregivers to build resilience, especially as as all of us have been going through COVID?
Right. Well, I think then you get into the emotion type of resilience, right? There's nothing we can do about it. So think of what positive things come out of COVID. We did a survey with the International Brain Tumor Alliance, and we found out that some people said, COVID actually had more, we had more family around, and we had, a lot less stimulation going on. So it's kind of good for people with brain tumors to maintain some quiet. So think about what things you can change and what things you can't, and sort of focus on that, I guess.
Thank you so much. Another question we have here is, when one has developed unhealthy coping mechanisms, such as in a pattern of negative thoughts, what are some ways that a patient or even a caregiver can replace such habits with healthy coping mechanisms?
I think be aware of what your negative coping mechanisms are. Are you someone that eats a bag of potato chips or drinks a bottle of wine? Think about what those coping coping mechanisms are, and then what can you replace them with, and write them down. So when you're sitting down with a bag of potato chips, you say, you know what, I've written down that I can go take a bath instead, or I can, go buy myself some flowers and smell them, or I can, do something that is self-soothing to me. So identifying what those unhelpful coping mechanisms are, so you can try to avoid them.
Really good. Thank you so much. I have a question here about your support group. Is your support group for patients only, or caregivers and patients?
Definitely caregivers and patients. And I think our caregiver group has been so instrumental. And we actually, pre-COVID, we would divide off, and we still try to. Since we went live, we have less people. We used to have about 30 people, sometimes 50 people in our support group every week or every month, excuse me. Now we've had about a dozen, so we can, split off or not split off, but we definitely encourage caregivers. And oftentimes we've had many instances where caregivers come without the survivor. They come on their own, and they get a lot, because caregivers don't ever get the opportunity. Our support group is run by all nurse practitioners. So caregivers often don't get the opportunity, number one, to voice their concerns with the healthcare team, even if it's not their nurse practitioner, because we are not institution based. And but also to get advice from other caregivers on what's worked and what hasn't worked. So I think the caregiver part of my support group has really been instrumental in helping people get through this process.
Thank you so much. Another question we have here is going kind of off that thread of like, if somebody was developing unhealthy coping mechanisms, when would you suggest it is appropriate to seek professional help?
I think it's always, you should err on seeking professional help. There's nothing wrong with seeking professional help. This is tough. You're dealing with something that is hard to deal with. You're dealing with, something that threatens your life and your family. So there's nothing wrong with getting professional help. So I would always, if you're at all thinking like, oh, are these coping mechanisms not helpful for me, find some professional help, but find someone who specializes in cancer. A lot of cancer support centers have free counseling, and these are people who specialize in cancer counseling. So it's different than the soccer mom who's stressed out. You're being faced with something that's pretty profound, and sometimes you need someone not involved at all, not your spouse, not your healthcare team, but someone who's completely uninvolved, to just be able to get some support from. Hi, Dr. Chang.
Really good, thank you. Another question we have here is, what advice do you have for patients and even their loved ones when there is a scan coming up? Scanxiety is a real thing. How does one build up their resilience or prepare for the news of the scan?
That's a great question, because it comes up all the time. I think people with brain tumors, all of a sudden, and even their caregivers, are all of a sudden, all these symptoms are popping up, and they're popping up because they're getting a scan in a week. Even if they've been stable for years, all of a sudden, all these things happen. And when they go to group, they say, oh, I had all these, I had weakness and this and that. And they said, well, when did it go away? Well, it went away as soon as I found out my scan was okay. So I think, again, recognizing it as what it is, knowing that it's out of your control, and thinking about what kind of mindful things you can do ahead of time to do, relaxation, yoga, mindfulness, things like that, just to try to get through it. And then, in the scan itself, try to do imagery. I always say, think of your wedding, replay your wedding, lay there and replay your wedding, or your favorite vacation, or your favorite place in the world. Just shut your eyes and put yourself there. And, talk to your doctor about, or talk to your healthcare team. If you need something to get through the scan, talk to them about that. They're not easy.
Thank you so much. Another question we have here is, it sounds like for somebody who is a patient and they have a friend who is a caregiver who is new in this role. So everything is brand new, a little overwhelming. And it sounds like the caregiver has invested a lot of time into caring for their loved one while they're going through their diagnosis, but they may be neglecting themselves. So what is an appropriate way to maybe give advice to this person to nudge their friend as a caregiver? You might need to take care of yourself.
I think to bring them, do it outside of the context of, do it alone, do it in a confidential thing and just say, I'm concerned about you. These are my concerns. What can I do to help you cope with this? How about if I come over and take care of your loved one so then you can, take care of yourself, and can we go for a walk? Can we do something helpful? And just express your concern. You can't force them into anything, but in a calming way, just tell them you love them and you're concerned about them and you'd like to help them.
I'm really glad that that question was posed because so much of our care, and I think Jean, you highlighted this, is focused on the patient, right? You mentioned the importance of a caregiver support. And, we are very fortunate at UCSF to have a caregiver program. I think it's the only one in the world where the program exists completely for the caregiver. Wow. And what we do is we normalize what it's like for a caregiver from the beginning so that they're aware of the challenges of the roles that they have to play. And it's very clear that caregivers, take on everything. A lot of times they don't ask for help. They feel very isolated in their roles. And so supporting them is really critical. And I can also post perhaps a link to our caregiver resources that we have as well. So those are things that I think is so critical that we support the caregiver to help them enhance the lives of our patients, right? They're part of our care team. And so I think that was a really, really important question. It's kind of why it came on the video. So, but thank you so much, Jean.
I have a comment here that says that, Jean, you always give really practical and helpful advice. And I couldn't agree more that this session is definitely encouraging, but there's some practical tools and pearls of wisdom for attendees to pull from. And,
thank you.
And also another comment, Tony the Tiger, you mentioned Tony the Tiger, I think on slide 2, it was Tigger from Winnie the Pooh.
Oh, it was. I was like, is it Tigger or Tony? Okay, I stand corrected. Thank you for correcting me.
Yeah. And okay, one more question just came in here. So what advice can you provide for patients experiencing survivor's guilt, or advice for caregivers transitioning to changes in their life from in treatment to now survivorship?
Survivor's guilt, meaning for a patient or for a care? Sorry, I'm not understanding.
Yeah, for survivor's guilt. So as a patient, as they're going through treatment, they might feel like a burden on their caregiver or significant other. So they will have guilt. So do you have any advice for patients experiencing survivor's guilt? Like as they are continually surviving, it's putting a potential burden on their family members.
I think having real conversations with your caregiver, first of all, I think that that the caregiver, and find time to appreciate your caregiver. I think too often I've had caregivers say stuff, well, I'm the punching bag, I'm the one that they beat up on because they feel like they can be real with me. So, being aware of that and maybe, offering your gratitude. What can you do? Thank you very much for being here for me. I mean, you didn't ask for the brain tumor. You'd prefer to not have a brain tumor. So this was what you were dealt with, and the caregiver too. And they love you and want to take care of you. But I think it's important to have those discussions. What can I do, for you now that, especially now that I'm not in treatment, what can I do for you now that you've done all this for me? Dr. Chang.
Thank you.
Okay.
Yeah, no, I think that's absolutely key is realizing that these are very valid feelings.
Right.
It's something that we hear from our patients. And so, that's where I think support groups are really critical, right? We've learned that, we can give advice, but when you hear it from someone who's going through the process, and that's why we had the patient voices today, because that's what resonates, that's what validates what you're feeling. And so I think that that's the first thing, is to say, yeah, I'm not alone in how I feel like about this, right? This is something that other people do experience. And so this is where, again, having that ability to share your experiences in a safe and supportive environment through support groups. And I know that the ABTA does a fantastic job with that. And also for the caregiver support group as well.
We have an interesting, in our support group, we have like 40 people who are previous caregivers. That's the only way, sometimes they name themselves the Loves Lost group, but they still are active in our support group, and they're still active with each other. And so they have found, they got through this together. And I think that that's, you gotta find those groups, because you're gonna find someone who knows what you've been through, and it's the only time they know that, their loved one is with me. So they know that their loved one is, they don't have to worry about what's going on with them, and they can just really, say the hard things to each other, because they're all going through it, and give each other advice. So I think, every support group needs to include the caregivers, and whenever possible, to split them off. Even if sometimes we split off, even if we only have 6 people, that's okay, and the survivors also are able to say things that they might not want to say to their caregiver, their worries, their concerns, their fears. So it works really, it's really meaningful.
Absolutely.
So go ahead, Dr. Chang.
Yeah, no, absolutely. I think giving each, both the patients and the caregivers, a separate forum to share is so important, because as Jean pointed out, there are things that caregivers go through. It's hard, a lot of times what our caregivers tell us is that they come with their patient to the visit, and they're like almost invisible, right? They're sitting in the room, and it's kind of like, well, who's asking them about how they're doing? And by helping them, really, again, helps the patients. So really, really important messaging.
One more message, just that I've said in my group before to survivors, is if your caregiver says something's up, something's up. So they have no reason to say, you're acting funny and we need to call the doctor. They have no reason. So if they say something's up, believe them and say that something's up. So listen to them.
Thank you so much, Chang. Well, that's all the questions that we have time for. We really appreciate you sharing with us today the practical tools to building resilience. And thank you so much for continuously being a partner and supporter of ABTA.
Thanks for including me.
Thanks, Jean.
All right.
Well, this now concludes the main sessions of the ABTA Survivorship Taking Control of Your Journey patient and family meeting. As a reminder, today's meeting has been recorded and will be sent out later next week, along with some helpful resources that the speaker shared with you today. We invite those of you who wish to meet fellow attendees from around the world and engage in meaningful conversations to stay online and participate in the ABTA Social Hour taking place in just a few minutes. This is the only session where you will get the opportunity to turn on your camera, meet other people, and say hello. This session will not be recorded. Additionally, we invite you to connect with us and share your meeting experience through social media. We hope each of you gained some new insight and helpful resources from our meeting today. Before we go, we would love if you could help us to understand if you have learned something new today by responding to this last poll. So if you remember from the beginning, I asked the question, please rate your understanding of survivorship. So we just want to see if anybody has gained some understanding from today's meeting. I'm going to launch the poll now. So you will choose 5 for excellent, 4 for great, 3 for general, 2 little, or 1 very little. Just a few more seconds. 3, 2, 1. Okay, I'm going to share the results. Wow, so if you remember from the very beginning, we had nobody in the excellent category. So that's a huge jump, 42%. Most people were either great or lower in the general little or very little category. So well done. I'm really happy to see that each of you gained a greater understanding of survivorship. And that's what we were hoping for today. So thank you so much. We invite each of you to continue to share your feedback with us, just like you just did in this poll today, and let us know, how has this meeting impacted you? Each of you should receive an email asking you to take a brief survey to evaluate this meeting. We ask each of you to please take a few minutes to share your feedback, which is really important for us to plan for future programs. For everyone who fills out the survey and includes their email address, you'll be entered into a raffle for a chance to win a $50 Amazon gift card. The winner will be emailed the gift card post-event. I would now like to thank our program planning chair, Dr. Susan Chang, for all her time, effort, and leadership in putting together the Survivorship Patient and Family Meeting. Please welcome Dr. Chang back again to say a few closing remarks.
Thank you so much, Emily. I really want to thank everyone for spending time with us today and for being so engaged. There were so many great questions, and I know we were very hopeful to get these answered for you, and really appreciate all the time you've put into helping us also, as Emily mentioned, giving us your feedback. That's really important as we move forward with new programming for you. So we hope you found the meeting helpful to provide new information, resources, and support to help you thrive on your journey. And special thanks to all the presenters for their expertise, and to Emily and Mindy and Ambreen and Nicole, and all at the ABTA for making the topic of survivorship a priority for our patients and families. So I enjoyed the day. I really am so happy that we were able to do this for you today. And I look forward to hopefully a lot of you joining our meeting next year, for which I'll also be helping to develop with Emily and the ABTA. Thank you very much.
Yes, thank you so much, Dr. Chang. We truly appreciate all your leadership in the development of the program, and it has been wonderful to work with you. And I echo Dr. Chang's gratitude for all of our speakers and presenters and our patients and caregivers for sharing with us today. Thank you again to also our sponsors, to ABTA's presenting sponsor, Novacure, our gold sponsors, Servier Pharmaceuticals, Miami Cancer Institute, and Gannon Lee, our silver sponsor, Karyopharm Therapeutics, and of course our funders, Genentech and Integra Foundation. Thank you all for your support of this virtual event. Without the time and effort of each of these individuals and organizations, we would not be able to bring you this quality educational programming that has brought together the entire brain tumor community. And most importantly, thank you all for joining us today. We know that it was a long day. We hope you got a lot out of it. And we hope that you have found this information to be insightful and that you're walking away today with some new information. Thank you again for joining us, and enjoy the rest of your day. Take care.